Hello, students. I think we are live. Hi, Ranjit sir. Welcome to today's INICET Mega Recall, everybody. And finally, this
Hi,
is
Ranjit sir.
the
Welcome to
last.
today's INICET Mega Recall, everybody. And
Can you guys hear us? See us? Hello, Rishabh. Hello, Shika.
Hi, sir. So one more stressful exam over.
Yeah. So let's wait for students to join in. I think they must have had a decent time. Mixed responses. Some were easy, some were difficult, some were lengthy. Like, what's your take? Uh, we have split people here, like one from AIMS, one from PGA, one from JIBMA. So I think we will be a better combo to discuss on what INICET has done this time. Because every time they try to give some random bounces, they want them to feel themselves special. So unfortunately, the target is not the right target, but still, that's what they do. And what's your take, Rishabh? What is the students' first opinion on how the question was, whatever your friends, juniors, seniors discussed with you?
So whatever students I talked to few of them, some who've been studying well for this INICET exam, and they said that the exam was an easy to moderate level. So that means that the cutoff should go a little high this time. And as we have been seeing for the last few sessions, be it NEET, PG, be it INICET, so now gone are the days when at 160 or 165 rank, you would get a top 10 rank. I think it's safe to assume that the top 10 this year will be between 170 to 175, and especially if it's an easy paper. And as far as the marks breakup are concerned, question breakup is concerned between first, second year and third, fourth year. Uh, Students told me that it was 50-50 as far as first, second, and third year are concerned. Among the first year, anatomy was a little less. Sorry, anatomy was good. Biochemistry was little less. Physiology was little less. Path, in fact, path was at par because path questions are mixed between medicine, path both. So, but OBGYN had a lot of weightage. Again, medicine, pediatrics questions were a lot. And minors again had a little less weightage as compared to the last session of INICET.
Great, Rishabh. So, Shika, we had a discussion that students were saying that one of the part had very, very lengthy questions.
Yeah.
Because though the question might look easy, but having on a screen like 7, 8 lines,
Yeah.
it's something not good to feel. They might get stumped. Okay, has to be a difficult question, right? So, what's your take on that, and how do you think the students should take care of if in future exams if the same pattern repeat? Because I presume that the proposed next exam has something goes on comprehensive based questions. Maybe this is a bridge between that so that they have increased the length of the question. What's your take on that, and how students should look out for that in the next future exams?
So what I heard about this paper in particular was there was one particular part that had very long essay, like more, USMLE like questions where you had the long clinical vignette and then you had the options. So probably the keywords that helped you to arrive at the answer were actually less. If you could condense it, then it would be a one-liner again, but they made a huge question out of that. So I think the problem that students faced this time were two, as you said, sir. One was that, you tend to get a little confused and you automatically assume this is going to be a bouncer question. And you tend to, even if it's an easy question, you tend to think and overthink and second guess your answers. The second thing I feel could have been a problem for the kids, especially if many such questions were there in a single part, is the time management, because now we have limited time compared to previous years. Now we have limited time for each set, and if you're having to devote a lot of time per question in a single set, then you might have a little bit of problem with time management and tend to miss a few questions or not go back to questions that you have marked for review. So in terms of approach, because this seems to be what the pattern is going to be like for all of the exams in the future, I think one is that INI is a concept-based paper, and that is what NEET has been moving towards. So conceptually, I think students need to start approaching things rather than just looking at one-liners, and definitely practicing more and more tests and discussions. And of course, we are also going to try to come out with more and more questions that are based on the same pattern so that they find it easier and they're more confident and not second-guessing themselves.
Great. So there are a couple of questions in pathology based on vacuum trainers. I feel that if you worked in internship, both of the questions can be answered.
Yeah.
You need not go and read a textbook like what is the 𝐌𝐞𝐝 you use for HbA1c. If you worked in a medicine, what by default, the one most important job as an intern does is collecting blood and collecting reports, right? You must have done that. So don't look everything in a book. Don't look everything from the notes or videos, right? So what you practice in your hospitals during internships, the patients you might see, definitely might come handy sometimes, especially when the question is going to scenario based. I think
Yeah.
that will help a lot. Right. So, Rishabh, what's your take on how important is internship now? Because the students which we talk to are like third year, I want to crack NEET exam in first attempt.
Yeah.
That is the kind of becoming the most important thing. I 100% agree that with the thing next coming into picture, they are saying that you won't get a degree and everything. Definitely the tendency will shift to that, right? So what's your take on like what should students do? Is internship important, not important?
So there are two takes to it, sir, and a lot of students don't have a choice of a light internship. They are born into or they are in a hospital which has a hectic internship, so they don't have a choice regarding that. But let's say if you have an option of doing an internship, at least try to do the internship well in subjects which have a lot of clinics involved, especially obs and gynae, emergency medicine, medicine in general, and surgery, obviously, because these four things will, around 20 to 30 questions, and which is a big chunk of questions, will be from your knowledge which you are working. And, such questions, if they come in the exam, A, you don't read them in any textbook. And second, maybe while you're working, you're not conscious of the fact that this might come, but, that gets stored in the subconscious of your brain. Okay, that I saw this question. I remember during my time, there was a question which came about NG tube insertion, which is the best position to for NG tube insertion. So whether erect, erect, bent forward, sitting, bent forward, sitting backward, supine, etc. And so if you have done an internship, you know what the position you put an NG tube in. So similarly, a question on HbA1c collection, and some students would say that it is for glucose estimation, but it is actually you're measuring a hemoglobin. So the vial would be that of an hemoglobin.
Yeah.
Similar, those such of questions are questions you'll get correct if you attend your internship very well. And now, second important thing is when you're doing an hectic internship and your duties range from around 12 to 14 hours per day, obviously the question comes that how will I get time to study, right? So what I realized that during my internship, somehow used to make time for studies even during my hectic internship, and in my light internships, I had a tendency of, being lazy and being killing time because I had a lot of time. So that tendency sort of creeps in if you have a light internship throughout. If you have a good internship, you have to focus less on the clinical subjects. I think focus more on the first and second year.
Got it. Great, great, Rishabh. So, any final take, Oshika and Rishabh, before let's start the recall? I think students may be waiting for a thing. Oshika, OBG, especially if you've seen in the past few papers, the number of questions, the complexity of questions is increasing. Right?
Yeah.
So,
Yeah.
previously it used to be bro presentation, what's a diameter, right? Now it's becoming more and more what's a decision making,
Yeah.
rather than asking what has to be done or anything, right? So what's your take how a student should prepare for OBG, especially for NEET or FMG or INICET, because all three of them, I think they have easily 25-30 questions in all the exams, right? So what's the take?
So, like Dr. Rishabh just said, and I totally agree with that. And I have done a video on this also previously on the channel, how to prep for OBG. So, OBG will remain even in the coming years one of the major subjects, and the number of questions is not going to get any less with time. And it's not going to be one of those subjects where it's variable. Ki, acha, 1 year you have 5 questions, the next year you have 30 questions. It's going to have an average of 15 to 20 questions at least. So OBG, like I said, is one of the things that handling at least obstetrics, if not gynecology, is something that is expected out of an MBBS student. Deliveries, abortions, all of these things. And the best way to actually inculcate things apart from studying is attending your postings and attending your internships. So OBG is one subject where I feel, especially obstetrics, that internship really helps. I mean, there's a question that comes often, and it was here again this year, which was active management of third stage of labor. So if you have attended the labor posting, a question on restitution, cardinal movements of labor. So if you have attended your posting, these are things that will come to you automatically. So, and from I think the last few years, we have seen that there has been more of, a focus on labor-related questions, because that is something students find quite confusing. Even postgraduates find it confusing. So if you attended your labor postings well, this is something that, will come to you at a spinal level, like, other internship things. And INI is sort of known for practical things like, the �NG-tube question, like every year there'll be 1 or 2 questions like this. At my time, there was a question which was on the gauge of cannula. So, us time pe, I think in coachings, nobody taught what were the different gauges of cannula. I think that is the year after which they started teaching this. But if you've attended your internship, आप सब में एक particular type का cannula डाल रहे हो, आपको याद हो जाता है what is the gauge. You know, when your PG is screaming at you कि इसको shock है, इसमें green डालो, why have you put pink? So, you sort of just remember these things. So my take would be that, definitely, at least for OBG is an important subject, and good stress should be put on it, not just because it's my subject.
Yeah, I think OBG is now the new medicine of final year subjects. And the good thing with OBG is that you don't have to read as much as medicine.
Yeah.
You have to read very less, and the output from OBG is much
And
more.
the syllabus is limited. It's not ki Harrison say randomly they will pick up something and give it to you. So the syllabus is also limited, and it is a scoring subject, and good if there is more weightage because it is a scoring subject.
So I think that, sir, will start with the.
Sure. We'll go with the recall session. I'll be starting. So thank you, Dr. Rishabh and Oshika. So see you soon. After me, definitely Dr. Rishabh will come and catch up with radiology. Fine. Thank you, guys. Thank you. So hello guys, how many of you gave the exam? If so, if you're given the exam, put in the comment box yes, and let's start the discussion. Just give me a moment. Can you guys see my screen? Yes, no, maybe. So how many of you gave the exam? So tell me, Dr. A.K. Khanna, definitely radiology ka rapid revision, Dr. Rishabh will definitely put it out soon. So let's go. Pathology this time had a great future obstetrician, great Rahul. So I want you guys to comment on whatever answer you come across. We'll go quickly. There's going to be 20 questions you have recollected in pathology, most of them with good enough STEM and most appropriate answers, right? So let's go ahead. I want you guys to comment. Let's be interactive. If you make a mistake, it's completely fine. If you don't make a mistake, also it's great, right? Hello, Ashok. Okay, this is the first question. First is, was this the right question? Or maybe something similar to that, right? Which of the following transcription factors are important in the EMT or an epithelial mesenchymal transition, right? I won't be going and talking about what is EMT. EMT is a process where it's going to be useful in case of metastasis of cancers. It's also useful in case of embryogenesis and wound healing, right? And epithelium changes to mesenchyme. And the answer to this, anyone? What do you think is the right answer? I hope you guys know the right answer. The right answer is twist and snail. These are 2 genes and the transcription factors, which is going to be helpful in the transition of an epithelium to a mesenchyme, right? So this is from MedEd. So I've put most of the screenshots, whatever I could get in this timeline. Okay, so EMT, it's about twist and snail. See, most of the books, the questions of pathology has come exactly from Robbins, right? So please go with the standard books. That's going to help you in a very, very, very long way, right? So EMT, the answer is about twist and snail. I hope these are the other options. Is there any change in the options? If there's any change, do comment in the comment box. We'll definitely take it and give you a better recall soon. Fine. Cathepsins and associated TTF A and B and MMPs, right? So MMP cathepsins are also involved in epithelial mesenchymal transition or metastasis, but it's not exactly involved in epithelial mesenchymal transition, right? Perfect. Next question. Was this question correct? There was a flow cytometry image. I missed the flow cytometry image. And the student said that in the flow cytometry, the answer was it was positive for CD19 and positive for CD22. Is the statement right? Okay. Approximately, Ashok Rahul, future obstetrician. A 5-year-old kid brought to the pediatric clinic by the parents with bleeding gums, easy bruising for the past 2 weeks. Image of flow was given, which showed positivity for 19 and 22, right? So if it is an ALL, see, there are few options here, right? So when you have 2 options like BALL and TALL, most likely that should be the right answer. One of them should be the right answer, right? AML unlikely because I don't expect CD19 or 22 to be positive in AML. For a myeloid lineage, one thing which I look for is MPO. Okay, and CLL is not going to present like this. It's going to present with lymphadenopathy and an elderly. So we can easily ignore CLL. Again, even if it's CLL, you know that CD5, 23, and all those things are important for me. 19 and 22 is not important, right? So here, the blasts are positive for CD19. Everyone, repeat after me. What is the marker? CD19 is the marker for B cell, T cell, NK cell. What is the marker? It's the marker for? Perfect. It's a marker for B cell, right? 19 as well as 20 is a marker for B cell. Age is a very important clue criteria as well. So the answer, right option is BAL, acute lymphoid leukemia of the B cell lineage is the right answer for this, right? We had discussed in the classes. There are few classical markers, right? So if I see CD3, I go for this, right? And if I see CD19 and 20, you go for BALL. If you see MPO, you go for AML, right? There are classical markers. If I see cyclin D1, I go for mantle cell lymphoma, right? Look at these classical markers. If you're writing the upcoming NEET exam, please don't go and memorize everything. One marker, perfect, classical, that should help you in a long way than memorizing things. And like Ashok said, history also is important, right? Age also very, very important. Halofungi. Okay. Mostly the right recall. If there's any error in the recall, please do tell me so that I can change it very soon. Age, I've added a little bit extra findings there. So I got a recall saying that it is an umbilical cord stump bleeding, continuous bleeding, and easy bruisability. Fine. PT, APTT were normal. And also some of the students said that the clot retraction time also was there, right? So which of the following is the most likely deficient here? Anyone? What's the right answer? I'm sure you know the right answer. Right answer is it's a factor 13 deficiency, right? So if you look at umbilical cord stump bleeding, a delayed or a continuous bleeding from umbilical cord stump, I want you to look for two things. One is definitely factor 13 deficiency. Okay. The other one is Glanzmann thrombocythemia or Bernard-Solé syndrome. But by default, if it's a factor 13 deficiency, that's my first thing which I'll look for in case of a delayed bleeding from umbilical cord stump. Please do remember, this is a very classical clinching point, right? So you need not read everything here. Few classical points will definitely give you the right diagnosis. Please remember those points alone. Fine. Okay, the next question. Let's match. This is a very simple one, right? I want you guys to match. What will be the appropriate match? Ignore the 1, 1, 1. APC is for familial adenomatous polyposis, right? STK11 is for Peutz-Jeghers syndrome. There must be one more match. I don't know what it is. If you guys remember, put the gene and the syndrome. Let's match that as well, right? SMAD4 is for your juvenile polyposis syndrome, right? So 1 is for A, 2 is for, this has to be C, right? 1 is for C, 2 is for A, and 3 is for B. That's the appropriate match here. APC for FAP, STK11 for Peutz-Jeghers syndrome, and SMAD4 for juvenile polyposis syndrome. Anyone else? What's it? Any other answer? What do you discuss? All these are classical things. We have discussed this already in the classes. Please don't go and search for many things. Whichever teacher you like, whichever platform you like, go and have a look at that. Almost things. See, abundance is the biggest problem here. Read things, revise things, and clear the exam. That's more than enough, right? Okay. Was it the right answer? I think the feature was not. I hope you read the negative part here. Which of the following is not a feature of men to be? Parathyroid hyperplasia is actually a feature of men 2A. There are few features which is common for men 2A and 2B. One of them here is medullary carcinoma thyroid. The other one is pheochromocytoma. These are two things which are common for men 2A and 2B. And these two, like mucosal neuroma and marfanoid hepatitis, will be seen only in men 2B, right? So B, C, and D, all of these are features of men 2B. But parathyroid hyperplasia is a feature of men 2A, and that's the most right answer, right? So we discussed this. Like I said, these two are common for both men 2A and men 2B. Men 2A's other name is Sippel syndrome. Both of them are mutation in the red proton coding. If you want extra pointers for the next exam, please go and have a look at this. And that's how it is, right? Two common features and few unique features for men 2A as well as men 2B. Fine. Okay, next question. Okay. Now, this is a very simple question. Again, a classical exact image from Robbins, right? They have taken all the images, all the text from Robbins. Please read the standard book if you're very early in your career, right? 44-year-old person, history of fingers turning blue, pale, that's like cyanosis, response to cold Raynaud phenomenon. She reports of difficulty in swallowing, must be esophageal problem, heartburn. On examination, telangiectasia is noted in the face and nails, right? So what's the most common diagnosis? It's simple, right? Sclerodoma. If to be specific, I'll call it a CREST syndrome, right? You have the CREST syndrome, the limited systemic sclerosis, where you have the Raynaud's, esophageal dysmotility, telangiectasia, All those things are classical here. There's a classical of CREST syndrome. So an anti-nuclear antibody testing is given here, right? This was the image given. So this is a centromeric pattern. So how do I know it's a centromeric pattern? Is centromere is seen in the junction of every chromosome, right? So if you look at the dots, there are actually 46 dots in every cell here, right? That's how it's a centromeric pattern. We had discussed all the 4 patterns in the classes, and all this 4 pattern is from the image, right? Mahima, I was told that there are 2 options in the image. 2 options of sclerodoma. Can anyone help me with that? They told that we had both the options. It's nucleolar positivity and sclerodoma with centromeric positivity. Was sclerodoma in the option? I was told there were 2 options of sclerodoma, or was the option systemic sclerosis? Both means it's going to be one and the same. Systemic sclerosis? Okay, fine. Fine, Mahima. See, both are one and the same. Systemic sclerosis with centromeric positivity, or a systemic sclerosis with nuclear positivity, and sclerodoma means one and the same. You not confuse it. So this answer is sclerodoma, and this is then centromeric positivity. So option B will be the right answer. If I have to rephrase it saying systemic sclerosis with centromeric positivity also is good enough, right? So option B is the right answer. It's centromeric positivity, not a nucleolar, right? If anything comes in future, I'll have single nucleus in every nuclei, right? So it'll be a single dot. That's how a nucleolar positivity will look like, right? Okay, perfect. Next question. Was this the right question, guys? Help me with the right question. Then if so, let's go to the answer. I think this should be the right question, right? So which of the following tests can be useful to detect aneuploidy? And it was so told that it's a multiple choice option, right? So there are questions with multiple single choice as well. Aneuploidy is a problem in the chromosomal structure or the cell cytogenetic problem. Fluorescent in situ hybridization and conventional karyotyping, both of them can help us to detect aneuploidy. Or your, I can call it a monosomy, trisomy, all of them are aneuploidy, not 46 chromosomes, right? PCR for mutations, Sanger's to confirm mutations, both of them cannot detect aneuploidy. So option A as well as option B is the right answer here. We have discussed this exactly. Karyotyping in fish are a type of genetic test called as cytogenetics. Cytogenetics, for future questions, it will be useful to detect aneuploidies, translocations, chromosomal deletions, duplications. All of them, this will be helping it. Mutations, obviously karyotyping nor fish can help. It can help only bigger problems like aneuploidies or translocations like that, fine? Okay, let's go to the next question. Most likely the right answer. So most likely the appropriately framed question, right? Can anyone comment what could be the diagnosis here? Or was there a history with diagnosis here? Or only just like this, an image? If it's only an image, that's a classical image of Antony A, Antony B pattern, Verroque bodies, right? That's a classical image of schwannoma, fine? It's a classical image of schwannoma. And here, schwannoma, yes, they do arise from cranial nerve. Schwannomas, Verroque bodies are seen. That's a right statement. Associated with neurofibromatosis, yes, that's a right statement. Malignancy is not common. Schwannoma is a benign lesion. Neurofibromas, schwannomas are all benign lesions. But there's a possibility it can have a, okay, it came from nerve sheath, fine. Okay, thank you, Hemraj. Fine. There's a possibility it can go to malignancy, but it's not common. It's definitely a benign lesion, schwannoma. It can turn malignant. I call it malignant nerve sheath tumor, right? But it's generally a benign tumor. So option D is the wrong statement. I think the question was which of the following is the wrong statement, right? We did discuss about schwannoma. We did discuss about cranial nerve palsies, Antony A, Antony B pattern, Verroque bodies, right? Like I said, path this time has been a little bit easier, at least from what we have recollected, right? Maybe other subjects were a bit long stem questions, but path was a little bit easy. This also was a very simple question, right? Okay. Cystic fibrosis is autosomal recessive. Duchenne's muscular dystrophy, I think it should be X-linked recessive. Fine. Optic neuritis is your mitochondrial inheritance. Marfan syndrome is an autosomal dominant inheritance, right? That's also very simple recall. See, if it's a match the following, you need not know everything. If you know like 3 or 4 things, that's more than enough for us to, 2 or 3 things, it's more than enough for us to know the last one, right? By default, you must have read about Duchenne's, you must have read about cystic fibrosis, optic neuritis, Leber's hereditary optic neuropathy, and Marfan's, right? We have discussed all the classical inheritance for the tables of Robbins, right? So every question which has been asked this time with respect to pathology is a little bit on the easier side. Question is right? Question is right. Can you guys comment on the answer? I think you guys are tired after a big exam, long exam. It's fine. Hepatocellular carcinoma, I go for, okay, Pradhan, I go for AFP. Systemic sclerosis and scleroderma, Pradhan, both are one and the same. So let's not confuse there. Fine. Choriocarcinoma, It's for beta-HCG. Medullary customer thyroid is definitely for an calcitonin. Pheochromocytoma, I am not sure. There are two sets here. Some of them said it's metanephrine. Some of them it said catecholamines. Whatever may be the answer, it's completely fine. Okay, immortal. Systemic sclerosis with an centromeric positivity or a scleroderma with centromeric positivity, both are one and the same. Centromeric was the most important there and not nucleolar. Fine. Okay. Be it catecholamines or metanephrines, it's fine. If it's catecholamines, it's good enough, or metanephrine also, pheochromocytoma will be the most appropriate answer, right? Again, tumor markers are something which is a very repeatedly asked subject, right? We have discussed tumor markers multiple times, nothing much to worry here. Only one mutation which everyone knows by heart is this, right? Thankfully, INICET this time didn't go much in depth to ask many changes, right? Sickle cell anemia is a mutation which every MBBS graduate knows. Substitution of glutamine by valine 6 portion of beta globin chain, right? So glutamic acid becomes valine. That's your HBS, right? I'm just going to ask a simple question. If glutamic acid becomes lysine in the same 6th position, what do you think is the right answer? Is it HBS or something else? Same 6 position. If glutamic acid becomes lysine, look for it in the future exams. It's HBC, fine? HBC and HBS, same position, beta globin chain, but the change is different. That's all. No hail for Jesus. Let's see if next comes or not. We'll leave it to the authorities for that. Fine. Okay. So again, I match the following. I'm sure you must have done this match the following, right? Because in this match the following, one thing we'll never forget: rabies and Negri body, right? That's a direct match. Myeloma, you have the Dutcher body, the intranuclear inclusions in a plasma cell. We call it Dutcher body. Parkinson's is an old repeat. Lewy body dementias, Parkinson's, you have that. Malakoplakia also is an old repeat, right? Last year also we had a cutaneous malakoplakia as a question in an image base. That image was Michaelis-Guttman body. Michaelis-Guttman body is seen in malakoplakia, right? Rabies is your Negri body, myeloma for Dutcher, Parkinson's for Lewy body, and malakoplakia is your Michaelis-Guttman body. Fine. We have discussed the Michaelis-Guttman body and malakoplakia in our classes, and definitely we must discuss about Mott cells, your Dutcher body, your Russell body, everything in plasma cell myeloma, right? Perfect. Great, doctor. Okay. Is this the right question? Here, one of the options might be a bit difficult. Maybe in the next exam, remember them, right? Marsh criteria, that's also right. That's more than enough. Marsh criteria is a way to diagnose a microscopic celiac disease, right? It's based on counting the CD4 positive cells, based on the destruction of the glands and everything, right? So this is something which is new for you, right? This is the right answer, right? It is DQ6 or DQ8 and DQ2. Celiac is associated with DQ2 and DQ8 and not DQ6, right? It's not as if with DQ6, so that could be the wrong option. Yes, you'll have tissue transglutaminase, you'll have anti-gliadin antibodies, right? So all of them are right. Against your bro food, you'll have diarrhea, everything is right. Marsh criteria might be a new thing, information for you. That's a microscopic diagnostic criteria. You need not remember this. They have asked it. If the same repeat comes in next exam, please do remember. Otherwise, you not go and read. Please don't go and read what is Marsh criteria, how to remember about that, right? So DQ6 is the right answer. That's the wrong option, which makes the answer right because the question is asking incorrect response. Fine. Okay. Okay. Again, here ruling out helps a lot. Fine. Is this question right? All of the following are hereditary causes of thrombosis except yes. If it's right, this is inherited or hereditary cause. Inherited hereditary cause, inherited hereditary cause, which is not the hereditary cause is PNH. PNH is an acquired mutation, right? It's an acquired mutation. We have emphasized this multiple times in the classes. PNH is a mutation only, it's acquired, which means you, me, and any person in the world can get PNH, right? That's how it is. PNH is not inherited, so it will not be transmitted to the next generation also. Fine. Okay, next. Okay, this is where we had most of the students arguing it, right? Was this the right question? Or maybe some of them said that electrolyte imbalance. I'll change it. Doesn't make sense, but still I'll change it, right? Which of the vacutainers are used in electrolyte imbalance? That's the right question. Yes, perfect. Have you, during an internship, collected RFT with electrolytes blood sample? Have you collected? Okay, I'll add Dr. Lavender. I'll take something else and I'll add lavender. You must have collected RFT, blood test, LFT. Which vacutainer do you collect, RFT or LFT? It's red or yellow vacutainer, right? The best answer here is yellow. right? The best answer undoubtedly is yellow, because yellow has a gel. When they have a gel, all the serological examination can easily be taken care of, because when you centrifuge, the plasma goes on the top, the RBC goes down, right? So yellow is the best one because it has gel. Most of the hospitals might have not had yellow because yellow is expensive, right? That's why you go for the next one, red. Green also I can do, but green is again rare available option, right? So the best option here is yellow. If yellow is not there, logically speaking, I'll look for red or green, right? Yellow is not there. I was told yellow was there and red was not there. Can you guys confirm that? Okay, if gray is there, then the answer will change. If it's red, green, or yellow. If yellow is there, I'll prefer yellow, then I'll prefer green. If yellow is not there, my answer will definitely change. But this is the right thing. I was told by multiple students, yellow was there, and yellow is the right answer, right? Okay, other things I don't know. If yellow was there, yellow is the right answer, right? Other three options, let's mix and match with every WebGR color, fine? Okay, that's another question. Okay, Mortal. Okay. Was this the question right? Gray doesn't matter. Gray is not going to help us for electrolyte estimation. It's yellow. Was the right question? Which of the following products are not produced by centrifugation? Yes. This is the right question. Perfect, right? See, it's a very, very simple question. We have discussed this in our classes as well. See, when you have a blood collection, you collect a blood from any patient. So what do I do is we centrifuge them. Once we centrifuge a blood, we get packed RBCs, we get platelets, we get plasma. In the plasma, I get fresh frozen plasma and cryoprecipitate. Albumin cannot be filtered, because albumin, you cannot filter albumin. So that's why we synthesize albumin. How will you take 3 milligram from a deciliter? You cannot centrifuge and filter albumin, right? Albumin is always produced. It's a product. It's produced. It's not filtered or centrifuged, right? I can centrifuge only this from a blood bank, right? So platelet concentrase is centrifuged. RBC is a product of centrifugation. Cryo is a product of centrifugation. Albumin is not made by centrifugation. I have to create albumin. It's been produced by in industries, in medical, big, huge industries like producing paracetamol. They create albumin. They don't do it by centrifugation. Fine. Okay. The right answer here is albumin. If this is the right question, right? Or in the words, if it's something like not produced by centrifugation, albumin is not produced by centrifugation. Fine. Okay, Ananya, we'll look into that. Was this a question? Which of the following is the most common inherited cause of thrombosis? If it's the most common inherited cause of thrombosis, I would say it's factor V laden mutation. That itself is very rare, but amongst this option, protein C, proteinase deficiency, antithrombin 3, prothrombin mutation, factor V laden mutation is the most common cause of thrombosis. And the way factor V causes thrombosis is, factor V, when it's mutated, it is resistant to inactivation by protein C and proteinase. So I cannot remove the factor V. So it keeps on activating and causes the damage, fine? Okay, tell me, Urvi, what is the options? Let's have a look at it. If factor V was there, that's the right answer. The rest options might be a little bit here and there. Please let me know the exact option so we can come into it. Okay, was this also a question? Because I think lots of questions were also was on 𝐌𝐞𝐝, right? Was this the right question? Which of the following is used for factor V is not there? Was there, right? Perfect. This question was the right question, right? 𝐷𝐿 used for HbA1c. Perfect. Okay. If this is, maybe this is why you get confused between the yellow and everything. And here, answer is simple, EDTA. See, it is HbA1c. Most of the student wrote sodium fluoride and trying to justify that it's a sugar test. It's not a sugar test. HbA1c is not a sugar test. It is a hemoglobin test. It's hemoglobin. I'm not looking at the sugar. How do you estimate hemoglobin? EDTA, right? I'm not estimating sugar here. If I'm estimating sugar, then I'll think of sodium fluoride. But still, sodium fluoride is not an anticoagulant, right? Sodium fluoride is a preservative. Okay, it's a preservative which is used in your gray color 𝐷𝐿. It's not an anticoagulant, right? So HbA1c is a test of hemoglobin and not a sugar. Hemoglobin is always tested using EDTA. Again, this is something which you can easily learn when you do the job in internship, right? You would collect a blood sample, you put in a purple tube or your lavender tube, and you send it for HbA1c estimation, right? So HbA1c is due to hemoglobin and it's due to EDTA and not sodium fluoride. Sodium fluoride is not an anticoagulant, it's a preservative. Fine. Okay. Was this a question? Maybe the image might be a little bit wrong. Which of the following is the correct regarding the picture given below? I don't know the fourth option. Okay. Levi bodies and intracellular accumulation, let's ignore that. Some of my bodies, they will be a little bit bluish in color. Because calcium accumulation, it will be a little bit bluish in color. Fine. Okay, perfect. This is classical content of corpora amylacia. We have discussed this also in the classes. Corpora amylacia can be seen in many conditions. It can be seen in your prostate. It can be seen in CNS, right? Corpora something. Fine. Okay. This is a classical case of corpora amylacia, right? So this can be, whenever you see corpora amylacia, we think that it's most likely a benign normal secretion and we don't think of a cancer, right? As a classical corpora amylacia we discussed in the classes, and this is nothing but a corpora amylacia. Pradhan, I am completely with you. Sodium fluoride is definitely useful because it inhibits enolase, right? So tell me, Pradhan, will HbA1c affected by today's glycolysis? No, right? It gives an estimation of 3 months blood sugar, which means it's already a bond made between sugar and hemoglobin, and it's stored in the hemoglobin and not as blood sugar outside. It's already a stored thing, right? So it doesn't matter for me. HbA1c is a hemoglobin test and not a blood sugar test. So I will use only EDTA. Fine. Okay. If this is the appropriate image, then answer should be corpora amylacia. Fine, guys. Okay. This is also a multiple choice question. This is the last question, I think so. So it's also a very simple one. Comment on the answer and let's wind up and let's call Rishabh. Which of the following is the are vaccine preventable cancers? Again, there are two questions. One question is which are the vaccinations you give after 65 years age? I will leave it to Dr. Murugan for PSM and Mamta for micro to discuss with it. This is for vaccine preventable cancer, multiple choices. HCC, obviously all of us are vaccinated for HCC. Hepatitis B, yes, to some extent I can prevent that. Obviously hepatitis C and others I can't, but hepatitis B I can prevent. Cervical cancer for HPV you can prevent. EBV cannot be prevented. As of now, there's no FDA validated vaccine for EBV. Maybe in future it might come. Merkel cell carcinoma, you'll not be able to prevent with vaccines. Fine. Okay. So these two multiple choice questions are the appropriate answer for vaccine preventable cancers. Fine. I hope path was doable. I think most of you must have got most of the questions right. Maybe a little bit of glitch with the HbA1c and everything. You will never make a mistake again. It's hemoglobin's problem, not a sugar problem. Fine. Okay. Great. Hi, Rishabh. You there? I'm done, Rishabh. So that's all from my end. I hope this INICET was good. Let's have a quick recall of everything. Dr. Rishabh is there. Thank you, Dr. Rishabh. Over to you.
Thank you, sir. Thank you for the discussion. And we are all right on time, and we'll start with the radiology questions now. So not a lot of questions came from radiology. And if I combine some clinical as well as core radiology questions, I can recollect up to 7 questions till now. Maybe there are more. I'll do a separate recall for those. And as compared to this year's NEET PG, the radiology questions were not so tough. Most of them were doable, and I'm sure all of you got the all of you got the questions correct. Now, let's discuss the first question. So easy question. A 64-year-old man cough, bad breath was given in the question stem, and dysphagia for 7 months. So long-standing dysphagia, barium swallow image was given, and I think all of you got the answer here correct, right? So we can see this is a barium swallow image. We can see a contrast outpouching in the upper esophagus, right? So halitosis, dysphagia, elderly, triad of Zenker's diverticulum. Easy question. I think all of you got this question correct. Nothing to worry about. Now let's move on to the next question. Now this is one question that you have to tell me which structure was marked. So what students have told me that yes, there was an MR angiography image was given and a vessel was marked. Now, if the vessel was marked, can you tell me which of the vessel was marked? Whether it was this one A or was it this B? Because both of these vessels are separate. Both of them run parallelly in the coronal section in the lateral part of the skull. But one is a middle meningeal artery and the second is a superficial temporal artery. Now, can you tell me where was the arrow? Because if the arrow was at the outermost aspect, if it was at the outermost aspect of the scalp, then the option is this is superficial temporal artery. Whereas if it is slightly inner to it, inner to the scalp, then this one is my middle meningeal artery. Right? So yes, if it was the most outside vessel which was marked, then yes, it is the superficial temporal artery. This is B. And if it was a slightly inner, if that was A. Right? So most of the students are saying कि बिल्कुल outside था. Okay, thank you Urvi, thank you Riyansh, thank you Chota Doctor. So we'll take as the answer, correct answer as fourth for this question. Correct? Thank you, Immortal. Now, next question is again a controversial question, and this is a tough question to ask, frankly, if these four were the options. Now, tell me first, please tell me in the comment section, what was the language of the question? Now, what students have told me was it was an elderly, it was not a young patient. So it was an elderly patient, 65-year-old, had a trivial trauma and trivial trauma fracture and inability to weight bear. There was inability on weight bearing. So weight bearing means there was a trivial trauma fracture, and students have told me there were 3 X-rays which were given. One was a pelvic X-ray, another one was a knee X-ray. Now, I don't have the exact image, obviously, and none of the students could recall the exact image. But yes, these were the 4 options. Now, in an elderly patient, we can safely rule out a eosinophilic granuloma. The chances of it happening are very less, right? Now, among the rest 3, brown tumor, METs, and disseminated TB, can all of them present with a pathological fracture? Yes, they can. Okay, METs, disseminated TB, brown tumor, all of them occur in the elderly. All of them can have a pathological fracture. In fact, all of them can present with a lytic lesion in the bone, a black appearing lesion in the bone. So the answer, so exact answer is difficult to tell unless you show me the exact image. Now, what students have told me is that there was a ballooning of the bone, multiple lytic lesions were there. Now, in an elderly, if history of a trivial trauma fracture is given to you, no other history is given to you of weight loss, of any fever, of any other comorbidities, in an elderly patient, my thought process goes either it is metastasis or a brown tumor. Okay. Either it is metastasis or a brown tumor. Now, amongst these, एक बार देख लो कोई आया. My inclination is towards picking up a brown tumor. In my opinion, brown tumor is the correct answer. But again, it all depends on what was the exact image. Right? So femoral head was there on both sides. Okay, on X-ray was right side hip joint was not there. Destroyed acetabulum. Yes, students have told me that yes, the acetabulum was destroyed. But in a destroyed acetabulum, if it was a destroyed acetabulum, tell me whether what was happening to the joint space. Tell me what was happening to the joint space. What was happening to the joint space? You know, if joint space are reduced, joint space is reduced, then you have to think of an arthritis in that situation. If joint space is reduced, then that means that there is an infectious arthritis. And in that case, the answer becomes TB. Can TB have lytic lesions? Yes, TB can have lytic lesions. Can TB have pathological fractures? Yes. So you guys have to tell me what was the location. So it becomes a controversial question. Let us wait for a while. Let me collect other image as well. So Nagi Reddy is saying head dislocated हो गया था sir. Pelvic bone area, acetabular area was radiolucent. So lytic lesions था. There was fever in the question and 2 more symptoms. हाँ तो अगर fever भी दे रखा है, joint space reduced है, तो then तो fever joint space reduced है, फिर तो आंसर TB है. ठीक है, बट अगर joint space normal है, then brown tumor metastasis both can be the answer. Again, this becomes a controversial question. Let's wait and watch for the right image. And I'll get back to you on Instagram or Twitter or YouTube. Now let's move on to the next question. Very easy question, straightforward. Ureteric stone investigation of choice is asked. So all of us know for renal stones nephrolithiasis, NCCT is the investigation of choice. All stones and NCCT except gallstones. Right? Now this is again a little controversial question. So it was a clinical scenario, and I think it will be covered in medicine as well. So clinical scenario was given of fever and weight loss, right? In the stem of the question, it was written, treen bud appearance is seen on TB. Now, plural tap was done, plural aspirate showed low ADA and lymphocytic predominance. And they were saying, you have done a lymph node aspirate, what do you expect? So options, in my opinion, were, can you tell me the options? So non-caseating granuloma, caseating granulomas, non-caseating granulomas with giant cells. I think these were the options you were thinking. What were the options for this? So, the clinical scenario looks like that of a TB. So if treen bud appearance, can it only happen in tuberculosis? No. Treen bud appearance can happen in a lot of other conditions as well. Basically, any condition which has an endobronchial spread of infection. So it can happen in pneumonia also. Bronchopneumonia can also have a treen bud appearance. But I don't think in a bronchopneumonia, you would be given a history of a chronic weight loss. And again, the lymphocytic predominance would not be there. So if all of these things combine, and again, low ADA is given in the option, still, I think in this scenario, you have to think in terms of a tuberculosis, and a caseating granulomas with giant cells should be the answer. But again, this will again be covered in a medicine recall. Now, FRAX was again a direct question which was asked, what does it stand for? So fracture risk assessment tool used in osteoporosis. Okay, so straightforward question, fracture risk assessment tool. Now, again, a surgery question. I've stolen it from Sandeep Sir, surgery. Adjunct of primary survey in trauma is all except. So again, a straightforward question. The answer is NCCT. This is done as a secondary survey, not as a primary survey. Chest X-ray, pelvis X-ray, and EFAST are radiological modalities in primary survey. Right? So with that, we complete our radiology recall, whatever questions I could recall from the students. So if there are any more questions related to imaging, radiology, even integrated radiology questions, please mention them in the live chat so that I can cover them. So if there are no more questions, we'll move on to Dr. Jagdish Chaturvedi sir for ENT recall. Jagdish sir, you are next, sir. Sir, you're not audible.
Hi, everyone. I hope you can hear me now.
Yes, sir. Yes, sir. You're audible.
Thanks, Dr. Rishabh. And how is everyone doing today or feeling about their exam? I think ENT questions were fairly straightforward. I think everything is there directly out from your notes. There is just maybe one application-based question, जो भी बहुत common sense वाला था. Let me also just quickly pull up your comments. So guys, so these questions from ENT, as you know, these are just memory recall. Okay? So we may not have the full questions or, the exact words. But let us, if there's anything else, you can just, put your questions over here. All right. So I think, see, this question was asked. Let us take this. First of all, see, ye common sense and English-based question hai. So tell me if this is exactly how this question was worded, because if the question wording changes, then our answers also changes. So was it like this? What causes maximum conductive hearing loss or hearing loss to that effect? Otitis media with effusion, partial fixation of footplate of stapes, ossicular discontinuity with intact TM, and malleus incus disruption with TM disruption. Was this worded exactly like this? Maximum hearing loss, Chota doctor is saying. But isme kuch, see, this is basically, look guys, conductive pathway is from the eardrum, malleus incus stapes into the cochlea. Anywhere if there is conductive hearing loss, issue, then it, will be, and so you think about it, maximum kab hoga? Maximum to tabhi hoga na, when the discontinuity is there. If you're in a relationship, breakup means over. But disruption does not mean over. You have to understand that. Okay. Disruption means it could be like, if there is a separate topic, I have taught an additional topic section of ossicular discontinuity where I talk about Austin's classification. There are different types of disruptions, grade A, B, C, D, for malleus and incus, incus and stapes and all of that. Disruption does not mean discontinuity. So here what the examiner is asking in very simple way, otitis media with effusion mein, second. This is charged, but it is not working. No problem. Okay. So if you see the first option, otitis media with effusion, it is not going to be completely blocking the hearing. Of course, the ossicular chain will be slightly disrupted. Partial fixation of footplate of stapes. Agar ye complete fixation hota hai, if it is complete biscuit type otosclerosis or complete type of otosclerosis where the entire footplate of stapes is fixed, I agree this would cause maximum conductive hearing loss. But ossicular discontinuity with intact TM, whether the TM is intact or not, if the ossicles are discontinuous, there is no connection between them, there is zero conductive pathway, this is the maximum conductive hearing loss. But malleus incus disruption, that is not really complete conductive pathway ka stoppage of that. So that's why here ossicular discontinuity with intact TM would be the most simple and basic common sense answer. Here 60 decibels is the maximum that most ENT community believes. 60 decibel is the maximum conductive hearing loss. But recently another research article came that said up to 105 decibels can be the maximum conductive hearing loss. Okay? So I don't think there is any confusion in this over here. This is a very straightforward thing. Carhart's notch, I think the examiner was fixated on otosclerosis. And Carhart's notch is actually sirf the conductive deafness. Bone conduction mein 2 kHz pe there is a dip, not in air conduction. When there is air and bone conduction together, that dips at 4 kHz, that is a noise-induced hearing loss. This is Carhart's notch, where only in the bone conduction it is 2K, because this is the maximum vibrating frequency for the footplate of stapes. It is otosclerosis. So there is basically nothing much to explain over here. This is a very standard question, and it is also covered nicely in our notes as well as our classes. Now, which of the following has the worst prognosis in laryngeal nerve injuries? Is this the question that was asked, and these options? एक बार clarify कर दीजिए. Unilateral recurrent laryngeal, bilateral recurrent laryngeal nerve palsy, unilateral sensorineural, and bilateral sensorineural nerve palsy. So here you can see that even in our notes we have told that there is this, when there is bilateral recurrent laryngeal nerve palsy, that is the only condition where patient will have stridor, because the only abductor, the only muscle that abducts the vocal cord, the posterior cricoarytenoid, is supplied by the recurrent laryngeal nerve. And the cricothyroid muscle, which is the only intrinsic muscle which is lying outside, that is supplied by superior laryngeal nerve, and wo ek adductor hai. That is it improves the tone, it is a tensor and an adductor. तो उस वजह से क्या होगा, out of all of these four, the only life-threatening emergency situation which can kill the patient is bilateral recurrent laryngeal nerve palsy. In all the other conditions, there is no threat to life. If छोटा डॉक्टर, every option was recurrent laryngeal nerve, कैसे हो सकता है? या तो उसके 4 ऑप्शन में तो या तो unilateral होगा या bilateral होगा. What could be the other 2 options of recurrent laryngeal nerve? It can either be there or not be there, no? So it can be unilateral palsy or bilateral palsy. But regardless, if wherever bilateral recurrent laryngeal nerve palsy will be there, that will be the correct answer in this case. And all the other options will not be there. Complete partial, it's fair enough. If it is complete partial, then bilateral, complete, recurrent laryngeal nerve palsy would be the answer, and partial would not cause, stridor, and that all others, there is decent prognosis, but when there is a stridor, the prognosis is poor because a person can die unless they get an immediate emergency tracheostomy. Okay? So partial or complete, agar aapke options hain, then you have to choose bilateral complete recurrent laryngeal nerve palsy. All right. Was an image like this? Somebody just said an image-based question of stepidotomy was shown. I don't know if this was the image or was it an actual intraoperative image with a prosthesis going in the middle of the stapes. ऐसा कोई image था. We don't have access to the exact image, but I believe stepidotomy का एक image-based question पूछा गया था, which I think is the treatment for otosclerosis. Stapedectomy पहले करते थे, but nowadays we don't do stapedectomy because this thing. So stapes foot plate prosthesis image, Chota doctor is saying. So like this, a foot plate prosthesis image is there. So that if stepidotomy was an option in those four, then stepidotomy would be the correct answer. Question read pregnant female. Yeah, because in pregnant female is where otosclerosis worsens. So the examiner is trying to give you a hint that this is otosclerosis. Because in female, when they are in females during their pregnancy, there is worsening of the otospongiotic process and otosclerotic process, and that is when they present. So that's why there is. I've also covered situations in which when you will operate. And one of those situations are whether you will operate during the pregnancy or after the pregnancy, and you will obviously do the surgery after the pregnancy once the complete ossification is done. So this is a well-known hint that the examiner is giving you कि boss हम otosclerosis की बात कर रहे हैं. This is stepidotomy. Okay. Sukhbir is saying partial recurrent laryngeal nerve palsy. Okay. Pradhan is saying stepidotomy was the option. Sukhbir is saying partial recurrent laryngeal nerve palsy. The answer would be complete recurrent laryngeal nerve palsy, but partial recurrent laryngeal nerve palsy would basically mean that there is still some abductor function that is there. So the patient will not be in stridor. Okay. Now, this is a very, very straightforward bachcho question. Literally, screening test of choice for newborn hearing, of course, otoacoustic emission. Baki options, humne man ghadant bana diya. I'm just assuming that if the examiner would be there, would give options like these. We don't remember all the exact, options that are there. So OAE is the screening tool of choice. If the child fails the otoacoustic emission test, then only we do the, BERA, which is to confirm whether the pathway of hearing has any issue or not. Otoacoustic emission, we are basically just seeing brainstem audiometry bhi tha, that's BERA. So BERA is also called ABR. So there can be auditory brainstem response or test, or it can be brainstem evoked response audiometry. And what was there? Visual evoked potential was also an option. Ossiculoplasty was there in the option. So I think Dr. Rohit, you were saying ossiculoplasty for the previous one. Ossiculoplasty mein kya hota hai? They put a prosthesis between the incus and between the malleus and the stapes, or incus and stapes. But stepidotomy means, the word otomy means hole. Okay, and ectomy means removal. So jab bhi otomy aata hai, there is a hole, and if there is a hole in the footplate of stapes, then that is a stepidotomy prosthesis. Okay. So that is all clarified. This is very, very straightforward. Is pe zyada time waste nahi karte. Identify the hearing loss as per the audiogram. ऐसा कुछ audiogram आपको दिया था. I was told that mixed hearing loss का audiogram आया था, and this is a representative of mixed hearing loss, where you see conductive component also, where air and bone gap is more than 20 decibel. As you can see, the red circle and red bracket, they in the beginning between 250 to 500 and 1K, it is more than 20 decibel. After that, it becomes less than 20 decibel. So this would be a mixed, hearing loss of the right ear. I don't know whether option mein right, left tha ki nahi, but I think we have covered audiograms in great detail. Also in our theory classes, I think for more than an hour and a half, step by step, these symbols and how you understand to interpret this, it is very, very straightforward. And I think overall, ENT is not very difficult in this times INICET. Of course, ear se dominate hua hai. They were no intersecting each other. Okay, Sukhbir. ठीक है, I don't know the exact audiogram. इधर intersecting लग रहा है, but generally they don't intersect. Okay, here because the right and left ear, both of them are there. That's why it appears intersecting. But if you're just looking at the right ear's lines, the airborne gap will be less than 20 decibel. ठीक है. So I think this is also done. I think कोई fracture image था. Was it a X-ray image that was asked, or was it an image like this? I don't know. I think Chevrolet's fracture of the nasal septum, पूछा गया था. Chevrolet's fracture is this straight line fracture. Is usually from lower blow from below the nose, which causes this kind of a fracture, and small trauma, not a very big trauma. Just mild to moderate trauma can also be can cause Chevrolet's. Jarjaways requires a little bit more force, and it will be associated with some maxillary and mandibular fractures also, and it is usually either front or side view injury. So Chevrolet's image was there, not X-ray. Okay, so Dipendra, thanks for clarifying. Chota doctor also thanks for clarifying. So ऐसा कोई image आपको पूछा होगा, ये भी बहुत ही straightforward है, already covered fractures of the nose and face, so should not have been a problem. I think there is one other question that I came to know late. Oh, Pradhan is saying exact same image, sir. वाह, ठीक है, तो GP publisher से लिया है इन्होंने image. Now, I think one question that is missed is causative organism for croup, laryngotracheal bronchitis, causative organism. I think the options were Haemophilus influenzae, Streptococcus pneumoniae, and another influenza virus, या कुछ और virus होगा. And I think we have already covered laryngotracheal bronchitis. Almost every entrance exam में कहीं ना कहीं croup आता है, या तो वो steeple sign आता है X-ray का, or something or the other around this comes. Your answer is parainfluenza virus if that was asked, or any influenza virus, not Haemophilus influenza virus. Haemophilus influenza causes epiglottitis. Okay, for epiglottitis, where you see the thumb sign, the Haemophilus influenza is the causative organism for epiglottitis. But for laryngotracheal bronchitis, it is a parainfluenza virus. And if parainfluenza virus is not an option, then influenza virus is the option. Like Dr. Tushar Gupta is saying, agar influenza option tha, then that would be the closest that you can pick, because it is from the same family. And Streptococcus pneumonia causes, pneumonia. Any other questions if I have missed? Otherwise, I think ye 8 questions the very, very straightforward. Hamara to 100% strike rate raha with our training in this particular segment. And INICET this time was not really very, very difficult when it comes to ENT. Straightforward and basic. Or koi question tha, then, or if you have any other doubts, you can ask me. Otherwise, I will request the next faculty to take over. And I think Dr. Oshika is waiting. रामनारायण दास, ये क्या इमोजी यार, मेरे को समझ में नहीं आ रहा, 2-3 बार भेजा है आपने, इसका मतलब खत्म. अच्छा, हेमराज गोस्वाल virus. Okay, no other questions. All right, so over to Dr. Oshika.
I would just like to ask you, actually,
Yeah.
I interacted with a couple of students, and they were a little not happy about third year subjects like opthal and ENT. So obviously as faculty हमें लगता ही है, we find the questions easy obviously, but आपके जो 8 questions that you had, do you think they were pretty straightforward, and if students had read from the notes? Because INI usually has a tendency of giving bouncers कि एक randomly textbook से उठा के कुछ दे दिया, या some image from some OT that they have done at AIMS, or some instrument that they use at AIMS, they'll just put a picture of that. So anything you felt on your end that was out of the ordinary in the ENT paper?
No, I think all the questions were fairly straightforward, Dr. Oshika. And I'm not saying being an ENT, faculty and expert. I'm just saying that these are usually all standard questions, and I think majority of them have been asked in the past also. Like otosclerosis and laryngeal croup, so they are like celebrity chapters. ये हर बार एक दर्शन तो आ जाता है इनका. And things like stepidotomy का वो image है, you can see the footplate of stapes and a hole. And audiogram and audiometry, proton audiograms पे question पूछा, hearing screening पे पूछा. I was definitely ear dominated. There's probably just one question from nose and one or two questions from throat, just for making the balance, but nothing like anything controversial or something like that. बस वो most highest conductive hearing loss वाला component, little bit application based and also common sense. You just have to know whether which option में there is discontinuity. So this may not be there in your books or textbooks exactly verbatim, but it is common sense. Wherever the ossicular chain is broken, the conductive hearing loss is maximum there. तो थोड़ा सा एक application based question है, and otherwise image based questions were also about 20-30%. So honestly, I don't really feel ENT was a difficult question this time from INICET. I'm very disappointed with INICET. हम लोग इतना prepare करते हैं, अब कम prepare कराते हैं।
Don't challenge them, sir. Next कुछ और ही आ जाएगा।
हाँ, कुछ और दो यार हमें, हमें भी तो बताना चाहिए यार, ये क्या है ये सब चीजें। ठीक है, all right, but over to you, doctor. Thank you, guys.
Okay, so next I'd like to invite Dr. Vivek, and we will discuss physiology. So, like I said, the input that we got from the first year for the first year subjects was कि anatomy अच्छा खासा आया था, but physiology and biochemistry were a little less. So, Dr. Vivek, what is your take on that, and what is your overall impression of the questions that came?
Questions of physiology, and I thought I hope I'm audible.
Yes, sir.
Ma'am?
Yes, sir. You are audible.
Okay. So I just have gone through the questions, and whatever I could gather, they were pretty straightforward questions.
Okay.
And what was the feedback that you got, ma'am?
I got the feedback ऐसे questions के बारे में तो नहीं, but they were a little disappointed because I think kids tend to love physiology more than anatomy. Sorry, Pradeep sir, but physiology ज़्यादा पसंद आती है, easily solve कर पाते हैं, याद करने का थोड़ा component कम है physiology में, तो they were a little disappointed that the number of questions जितना वो expect करते हैं, usually INI relies very heavily on first year subjects. तो first year subjects barring anatomy उनको लगा कि weightage इस बार कम था.
All right. What I feel is that फिजियोलॉजी के साथ अक्सर ऐसा होता है, अन्याय होता है एक तरीके से, कि फिजियोलॉजी हर किसी सब्जेक्ट में आती है।
हाँ.
तो अक्सर ऐसा होता है कि कोई दूसरे सब्जेक्ट में भी कहा जाता है कि हमारा क्वेश्चन है, और फिर देखते देखते फिजियोलॉजी एज सच जो कहते हैं ना, वो बहुत कम दिखाई देने लगता है।
जाती है।
हर एग्जाम की स्टोरी है, नथिंग न्यू।
अभी मैं सिराज सर से भी आई एम गोइंग टू स्टील अ क्वेश्चन। सो यस, डेफिनेटली फर्स्ट सेकंड ईयर के सब्जेक्ट्स में दिस इज अ प्रॉब्लम, बहुत इंटीग्रेशन में यूज होता है ये।
यस,
सो ओवर टू यू सर, लेट्स गो अहेड विद द रिकॉल।
Yeah, so hello students, I'm Dr. Vivek Nargirkar, and we are going to have recall of physiology questions. Feel free to jump in, and if there are some options that you can recall which we could not get so far. और जैसा मैंने कहा कि मुझे अब ना ये कहने को मैं नहीं पसंद करता हूँ कि एवरीथिंग केम फ्रॉम माय टीचिंग्स, क्योंकि अब इतने सालों से पढ़ा रहा हूँ तो ऑब्वियसली सब कुछ ही आता है टीचिंग में, और इसलिए मतलब वो आ ही जाता है एग्जाम में। तो खैर चलो, तो लेट्स स्टार्ट and let's have a look at these questions one by one. Most potent stimulus for peripheral chemoreceptors. You know, peripheral chemoreceptors, or the carotid bodies and aortic bodies, they are sensitive to two things. One is hypoxia and the other one is arterial H+. And the central chemoreceptor is most sensitive to the changes in the arterial CO2 or hypercapnia. So among the given options, could you attempt this question? Hello Snehajit, welcome to the INICET recall. I'm waiting for the other students to also butt in and just give their opinion about this question. ये question ऐसा ही था। अगर ये question ऐसा ही था तो देखो, carotid bodies and aortic bodies, the peripheral chemoreceptors, they have O2 sensitive potassium channel. अगर आपको respiratory system का वो chapter याद हो तो O2 sensitive potassium channel, they sense the hypoxia and then accordingly they respond. वो चैनल्स जो है वो क्लोज हो जाते हैं और फिर पोटेशियम जो है वो accumulate होता है मेम्ब्रेन में, and that generates the impulses in the 9th and 10th cranial nerves. So yes, Ram Narayan Das ji, yes, इसका आंसर हाइपोक्सिया था, C, that is. तो ये काफी हद तक स्ट्रेट फॉरवर्ड था. आपको याद रखने के लिए, अगर आगे आप कभी एग्जाम दो, तो बस इतना याद रखो कि पेरिफेरल कीमोरिसेप्टर्स मोस्ट सेंसिटिव टू हाइपोक्सिया, और अगर हाइपोक्सिया नहीं होगा तो सेकंड बेस्ट इज आर्टीरियल H+ या मेटाबॉलिक एसिड्स. आपको पता है कि मेटाबॉलिक एसिडोसिस में it is compensated by the respiratory system. How? By stimulation of the peripheral chemoreceptors, because they respond to arterial H+ metabolic acids, and then respiration is stimulated. And the central chemoreceptor, as I said, is more sensitive to, or most sensitive to changes in the arterial CO2, क्योंकि arterial CO2 जो है, it crosses the blood-brain barrier easily, it enters the brain, locally forms the H+ hydrogen ions or H+, and then that H+ stimulates the central chemoreceptor. तो ये क्वेश्चन था, काफी हद तक स्ट्रेट फॉरवर्ड क्वेश्चन था. चलिए आगे देखते हैं. ये एक मैच द फॉलोइंग क्वेश्चन हमको बताया गया कि ऐसा कोई क्वेश्चन आया था, मैच द फॉलोइंग. तो उसमें एक तरफ लिगैंड्स या हार्मोन्स दिए हैं और दूसरी तरफ उनके रिसेप्टर्स या उनकी सिग्नलिंग पाथवेज दी गई है. तो आई होप कि ये क्वेश्चन ऐसा ही था, आप लोगों ने भी यही क्वेश्चन देखा इसी फॉर्म में, और इसके यही ऑप्शंस थे. या सौरभ, थैंक यू. मूविंग टू द नेक्स्ट क्वेश्चन. एसिटाइलकोलिन, growth hormone, insulin, thyroxine, and they have given the signaling pathways. So acetylcholine, आपको याद होगा, ligand gated ion channel, निकोटिनिक एसिटाइलकोलिन रिसेप्टर होता है ना न्यूरोमस्कुलर जंक्शन में, तो ligand gated ion channel फॉर एसिटाइलकोलिन. उसके बाद ग्रोथ हार्मोन, आपको याद होगा, ग्रोथ हार्मोन रिसेप्टर इज a tyrosine kinase associated receptor. इंसुलिन का रिसेप्टर इज टायरोसिन काइनेज रिसेप्टर, क्योंकि उस रिसेप्टर को टायरोसिन काइनेज एक्टिविटी है, इंट्रिंसिक टायरोसिन काइनेज एक्टिविटी है. ग्रोथ हार्मोन का जो रिसेप्टर है मेम्ब्रेन में, उसको इंट्रिंसिक एक्टिविटी नहीं है टायरोसिन काइनेज की, लेकिन उसकी जो साइटोप्लाज्मिक टेल है दैट इज लिंक्ड टू द टायरोसिन काइनेज एंजाइम. और इसलिए ग्रोथ हार्मोन और इंसुलिन अगर दोनों ऑप्शंस है तो इंसुलिन का रिसेप्टर इज अ टायरोसिन काइनेज रिसेप्टर, और ग्रोथ हार्मोन का रिसेप्टर यहां नहीं दिया है, इट्स अ टायरोसिन काइनेज लिंक्ड रिसेप्टर या एसोसिएटेड रिसेप्टर, एंड दैट एक्टिवेट्स द जैक स्टैट मशीनरी इनसाइड द सेल. तो ये था ग्रोथ हार्मोन, जैक स्टैट, इंसुलिन, टायरोसिन काइनेज एसोसिएटेड रिसेप्टर, एंड थायरॉक्सिन. तो बचा थायरॉक्सिन, और आपको ये तो पता ही है कि थायरॉक्सिन का रिसेप्टर इज एन इंट्रान्यूक्लियर रिसेप्टर. उसके अलावा ईस्ट्रोजन का रिसेप्टर इज एन इंट्रान्यूक्लियर रिसेप्टर, और ये मिनरलोकॉर्टिकॉइड रिसेप्टर MR इज आल्सो इंट्रान्यूक्लियर रिसेप्टर. तो ये सारे इंट्रान्यूक्लियर रिसेप्टर्स होते हैं. तो ये करेक्ट, प्रधान वेलू जी ने भी कहा कि सेम, ही थिंक्स द सेम. तो ये भी एक स्ट्रेट फॉरवर्ड क्वेश्चन था. लेट्स मूव ऑन टू द नेक्स्ट क्वेश्चन. हाँ, इसके ऊपर मुझे काफी स्टूडेंट्स ने अलग अलग बताया कि ये क्या क्वेश्चन था एक्चुअली. सो लेट्स हैव अ लुक एट द क्वेश्चन. एक इमेज दिया गया था, इमेज बेस्ड क्वेश्चन शोइंग द ट्रांसपोर्टर्स एंड विच ऑफ देम यूजेस द ATP, ऐसा क्वेश्चन था. तो क्या आपको ऐसा कोई क्वेश्चन रिकॉल हो रहा है? चलो, तो जो आया था, जो हमें बताया गया उस हिसाब से, मतलब अब तक जो स्टूडेंट्स ने इनपुट दिया है, तो उसमें उन्होंने पैरासेलुलर ट्रांसपोर्ट, पैसिव ट्रांसपोर्ट, कैरियर मेडिएटेड ट्रांसपोर्ट एंड एक्टिव ट्रांसपोर्ट ऐसा दिया, ऐसे ऑप्शंस थे. जस्ट टू ऐड टू योर एग्जिस्टिंग नॉलेज, लेट्स से सोडियम का ट्रांसपोर्ट, सोडियम ट्रांसपोर्ट ये चारों तरीके से हो सकता है. ओके, तो सोडियम का ट्रांसपोर्ट पैरासेल्युलर, मतलब अगर ये रीनल ट्यूब्यूल दिखाया है, एक साइड की उसकी लाइनिंग दिखाई है, तो ये दो सेल्स के बीच में से भी ऐसे ट्रांसपोर्ट हो सकता है. ओके, एंड दैट्स कॉल्ड एज अ पैरासेल्युलर ट्रांसपोर्ट. तो सोडियम इन द पीसीटी पर्टिकुलरली पैरासेलुलर ट्रांसपोर्ट होता है उसका इन द पीसीटी। ओके, तो ये ऐसे दिखाया है तो पैरासेलुलर ट्रांसपोर्ट। देन अगर पैसिव ट्रांसपोर्ट बताया, पैसिव ट्रांसपोर्ट, तो दे विल शो ए चैनल लाइक लेट्स से इनैक, या ऐसा कोई चैनल दिखाएंगे और जिसमें से सोडियम एंटर कर रहा है, तो ये हो गया पैसिव ट्रांसपोर्ट। आई एम जस्ट ट्राइंग टू टेल यू कि आप इमेज दिखाया तो उसको कैसे रिकॉग्नाइज करोगे कि ये कौन से टाइप का ट्रांसपोर्टर है। एंड या लेबल्ड पिक्चर वाज देयर, ऐसा बताया गया, तो वही मैं आई एम ट्राइंग टू जस्ट ड्रॉ एंड देन लेबल एंड जस्ट ट्राइंग टू टेल यू कि कैसे आइडेंटिफाई कर सकते हो आप इन ट्रांसपोर्ट्स को। कैरियर मेडिएटेड ट्रांसपोर्ट, सोडियम के लिए कैरियर मेडिएटेड ट्रांसपोर्ट कौन सा है पता है आपको? जस्ट आस्किंग, एनीबॉडी कैन आंसर दिस। सोडियम के लिए कैरियर मेडिएटेड ट्रांसपोर्ट कौन सा था एग्जाम में, या कौन सा रहता है जनरली स्पीकिंग? एनीवन? नहीं, पैरासेलुलर, आई एम सेइंग कैरियर मेडिएटेड ट्रांसपोर्ट फॉर सोडियम। ओके, चलो मैं बताता हूं। SGLT, SGLT is a carrier, okay, sodium glucose transporter. Secondary active transport, sodium and glucose are transported by whom? By the carrier. तो अगर आपको डायग्राम में, इमेज में अगर दो लोग बताए हैं सोडियम के साथ और एक कोई बताया है, तो सर्टनली वो ऑफ कोर्स अदर देन सोडियम पोटेशियम पंप, तो उसको तो अलग से दिखाएंगे हम, लेकिन सोडियम और ग्लूकोज दिखाया है, तो सोडियम ग्लूकोज ट्रांसपोर्टर SGLT, दैट्स राइट। और अगर वो है तो इट्स अ कैरियर मेडिएटेड ट्रांसपोर्ट, तो शायद वो भी दिखाया था, वो दोनों एक ही डायरेक्शन में जाते हुए भी दिखाए होंगे शायद, या NCX भी हो सकता है, कैरियर एक्सचेंजर है ना वो, सोडियम कैल्शियम एक्सचेंजर, तो SGLT। लेकिन ये सारे तीनों जो है ना ट्रांसपोर्ट, तो उस डायग्राम में सोडियम पोटेशियम पंप अगर दिखाया है, और सोडियम पोटेशियम पंप इज अ प्राइमरी एक्टिव ट्रांसपोर्ट एंड इट बाइंड्स टू द ATP, breaks down the ATP and utilizes the energy for its transport। तो ऐसा क्वेश्चन था एंड उसका आंसर एक्टिव ट्रांसपोर्ट या सोडियम पोटेशियम पंप जो उस डायग्राम में दिखाया गया था। ओके, प्रधान वेलू जी इज सेइंग कि मल्टीपल करेक्ट आंसर्स एंड विच ऑफ देम डज नॉट यूज ATP। अगर डज नॉट यूज ATP है तो फिर पैरासेलुलर ट्रांसपोर्ट, पैसिव ट्रांसपोर्ट एंड कैरियर मेडिएटेड ट्रांसपोर्ट, ये डायरेक्टली ATP यूज नहीं करते। क्या उसमें डायरेक्टली ये वर्ड था? आई एम जस्ट आस्किंग सुखबीर सिंह जी, प्रधान वेलू जी, आई वांट टू नो कि had they used the word directly? अगर वर्ड है डायरेक्टली कौन ATP यूज नहीं करता, तो पैरासेलुलर ट्रांसपोर्ट, पैसिव ट्रांसपोर्ट एंड कैरियर मेडिएटेड ट्रांसपोर्ट, ये तीनों डायरेक्टली ATP यूज नहीं करते। डायरेक्टली ATP यूज करता है तो सिर्फ एक्टिव ट्रांसपोर्ट। लेकिन अगर अगर सिर्फ पूछा गया विच डज नॉट यूज ATP डायरेक्टली और इनडायरेक्टली, क्योंकि why I'm just flagging this, I'm just trying to flag this issue is that SGLT जो है secondary active transport which is a carrier mediated transport, तो वो indirectly ATP यूज करता है, यानी कहीं ना कहीं पहले ATP ब्रेकडाउन होती है और उसके ऊपर बेस्ड ये अपना SGLT जो है वो कैरियर मतलब ट्रांसपोर्ट करता है। तो ठीक है, अगर ऐसा कोई नहीं था ऑप्शन में डायरेक्टली, सॉरी मतलब क्वेश्चन में अगर डायरेक्टली इनडायरेक्टली ऐसा कोई वर्ड नहीं था, तो let's go with this, only active transport utilizes ATP and जो which does not use the ATP, तो first three do not use the ATP। all right, क्या हो गया? okay, चलो तो let's go to the next question। There was a question related to the oxygen dissociation curve। क्या आपको ये क्वेश्चन रिकॉल हो रहा है? ऑक्सीजन डिसोसिएशन कर्व दिखाया था and after the RBCs are transfused or the blood is transfused, तो वो कर्व कहाँ शिफ्ट होगी, और ऐसा बताया गया था इफ दिस इज द एन मतलब नॉर्मल, ये अगर नॉर्मल कर्व है तो आफ्टर द ब्लड ट्रांसफ्यूजन, okay, Pradhan Veluji is saying options were simple, facilitated, paracellular and active transport. हाँ, इवन इन दैट केस चलो मैं अपने क्वेश्चन में वो करेक्शन कर लेता हूं, लेकिन अगर ये चार ऑप्शंस थे प्रधान वेलू जी, तब भी एक्टिव ट्रांसपोर्ट विल यूज एटीपी, द अदर थ्री विल नॉट यूज एटीपी। और ये तो बहुत सिंपल सा क्वेश्चन है, आपको मतलब मैं समझ सकता हूं कि आप लोगों को क्यों डिसअपॉइंटमेंट हो गई होगी, क्योंकि आप लोगों ने बहुत डिटेल में पढ़ा होगा और क्वेश्चंस काफी सिंपल, मतलब जो देखे दिखाए रटे रटाए क्वेश्चंस होते हैं ना, वैसे ही क्वेश्चंस आ गए, तो ये डिसअपॉइंटमेंट हो गई होगी। चलो आगे बढ़ते हैं। ये अगर नॉर्मल है तो ब्लड ट्रांसफ्यूज करने के बाद शिफ्ट कहां पे होगा, ये शिफ्ट होगा कि ये शिफ्ट होगा, ऐसे और दो कर्व दिए थे और पूछा गया था कौन सी कर्व है जो आरबीसी ट्रांसफ्यूजन के बाद बन गई है, ऐसा कुछ क्वेश्चन था। तो जय श्री राम इज सेइंग राइट शिफ्ट होगा, यस बिल्कुल। देखो जस्ट फॉर दिस क्वेश्चन याद रखने के लिए बता रहा हूं कि स्टोर्ड ब्लड जब होता है तो द कर्व इज शिफ्टेड टू लेफ्ट एंड अपवर्ड, और जब ब्लड आप वो स्टोर्ड ब्लड निकाल के उसको ट्रांसफ्यूज करते हो तो इन नेक्स्ट 24 आवर्स द कर्व गेट शिफ्टेड टू द राइटवर्ड एंड डाउनवर्ड। ओके, स्टोर्ड ब्लड एक तो 0 to 4 डिग्रीज में होते हैं, और आपको पता ही है शिफ्ट टू राइट एंड लेफ्ट में इंक्रीज H प्लस, इंक्रीज टेम्परेचर, इंक्रीज कार्बन डाइऑक्साइड एंड इंक्रीज 2,3 बिसफॉस्फोग्लिसरेट, these things shift the curve to the right and opposite factors shift the curve to the left. तो in this question, ये क्वेश्चन था, ये तो सब कह रहे हैं अटेंड जिन्होंने एग्जाम अटेंड किया, और ये क्वेश्चन ऐसे ही था। बहुत सारे स्टूडेंट्स ने कहा आने के बाद, बाहर आने के बाद, कि या एक डायग्राम थी, O2 डिसोसिएशन कर्व था, और ब्लड देने के बाद शिफ्ट कहाँ होगी, कहाँ कर्व शिफ्ट होगी, ऐसा पूछा गया था। तो बस राइट वर्ड शिफ्ट होता है, तो याद रखो स्टोर्ड ब्लड कर्व शिफ्टेड टू द लेफ्ट। जस्ट आपको एक एडिशनल इंफॉर्मेशन बता देता हूं, कार्बन मोनोऑक्साइड पॉइजनिंग कर्व शिफ्टेड टू द लेफ्ट, स्टोर्ड ब्लड कर्व शिफ्टेड टू द लेफ्ट। उसके बाद फीटल हीमोग्लोबिन, फीटस में जो होता है ना फीटल हीमोग्लोबिन, इंट्रायूटेराइन लाइफ में या जितना भी फीटल हीमोग्लोबिन है, चलो 80% है या जो भी है, कर्व शिफ्टेड टू द लेफ्ट, तो ये हाई एफिनिटी ऑफ ऑक्सीजन फॉर द फीटल हीमोग्लोबिन की वजह से होता है। सो दीज फैक्टर्स, ये 3-4 रिमेंबर कर लो, शिफ्ट टू लेफ्ट। उसके अलावा डिक्रीज H प्लस, डिक्रीज टेम्परेचर, डिक्रीज कार्बन डाइऑक्साइड, दीज ऑल्सो शिफ्ट द कर्व टू द लेफ्ट। ऑल राइट, तो ये क्वेश्चन था और सिंपल सा क्वेश्चन था, नो प्रॉब्लम। आगे बढ़ते हैं। GFR कैलकुलेशन के ऊपर क्वेश्चन था, तो प्रधान वेलू जी, रामनारायण दास जी, सुखबीर सिंह जी, आई थिंक यू आर द पीपल हु हैव अटेंडेड द एग्जाम एक्चुअली। तो क्या ऐसा कुछ क्वेश्चन याद आ रहा है आपको? GFR कैलकुलेशन के लिए डेटा दिया गया था और पूछा गया था कि कैलकुलेट द GFR। प्रधान वेलू जी, डू यू रिमेंबर दिस क्वेश्चन? GFR कैलकुलेशन के लिए डेटा दिया गया है and you are supposed to calculate the glomerular filtration rate. चलो, जब तक आप रिकॉल करते हो मैं आपको बताता हूं कि अगर ऐसा क्वेश्चन था तो आपको कैसे प्रोसीड करना था। सी, देयर इज वन फैक्टर दैट favors the filtration at the glomerulus and that is glomerular capillary hydrostatic pressure। तो आपको एक ब्रैकेट में लेना है ग्लोमेरुलर कैपिलरी हाइड्रोस्टैटिक प्रेशर, ओके, और द टू फैक्टर्स दैट अपोज द फिल्ट्रेशन एट द ग्लोमेरुलस, तो वो है प्लाज्मा कोलॉइड ऑस्मोटिक प्रेशर and Bowman's capsule hydrostatic pressure. These are the forces that oppose the filtration. So glomerular capillary hydrostatic pressure, please don't mind these ये writing थोड़ा सा खराब आ रहा है बहुत, but I'll read it out, तो आपको मतलब पढ़ना की जगह पे आप सुन लो. ग्लोमेरुलर कैपिलरी हाइड्रोस्टैटिक प्रेशर एक ब्रैकेट में लो, और प्लाज्मा कोलॉइड ऑस्मोटिक प्रेशर प्लस बोमन्स कैप्सूल हाइड्रोस्टैटिक प्रेशर दूसरे ब्रैकेट में लो, एंड 1 - 2 फर्स्ट ब्रैकेट माइनस सेकंड ब्रैकेट, दैट विल बी नेट फिल्ट्रेशन प्रेशर. और फिर जो भी आएगा उसको मल्टीप्लाई करना है बाय KF, कैपिलरी फिल्ट्रेशन कोएफिशिएंट. जय श्री राम जी कह रहे हैं कि शिफ्ट टू द राइट होता है, तो मैंने भी शिफ्ट टू द राइट ही कहा ना. स्टोर्ड ब्लड में शिफ्ट टू द लेफ्ट कहा था, और वो जब ट्रांसफ्यूज करते हैं तो 24 घंटे में कर्व शिफ्टेड टू द राइट, यही कहा था मैंने भी. एनीवेज, क्वेश्चन वाज व्हिच वन इंक्रीजेस द GFR. ऑल राइट, तब तो बहुत आसान था. व्हिच वन इंक्रीजेस द GFR, तो ये तो आपका स्ट्रेट फॉरवर्ड देखा दिखाया क्वेश्चन है. ग्लोमेरुलर, अच्छा ऑप्शंस क्या थे बाय द वे? सौरभ सिन्हा जी, कैन यू रिकॉल द ऑप्शंस? क्या ऑप्शंस थे? डिक्रीज GFR सीन इन, अच्छा सुखबीर सिंह जी भी वही कह रहे हैं, डिक्रीज GFR इज सीन इन. ठीक है, तो इस क्वेश्चन को मैं फिलहाल टेम्पररी साइड में रख देता हूं. ऑप्शंस क्या थे, क्या फैक्टर्स दिए थे उन्होंने? जब तक आप ऑप्शंस रिकॉल करते हो तब तक मैं आपको बता देता हूं कि इंक्रीज या डिक्रीज GFR करने वाले फैक्टर्स कौन कौन से हैं. उसमें कोई एफरंट आर्टीरियोल, इफरंट आर्टीरियोल या इन फैक्टर्स का जिक्र था, ऐसा कुछ आपको याद आ रहा है? सौरभ जी, सुखबीर जी, कैन यू रिकॉल समथिंग लाइक दैट, कि उसमें एफरंट आर्टीरियोल, इफरंट आर्टीरियोल, कॉन्स्ट्रिक्शन, डायलेशन, नेफ्रोलिथियासिस, या फिर ऐसे कोई फैक्टर्स मेंशन किए हो? हाँ सुखबीर सिंह जी, यस, थैंक यू. ऑप्शंस वेर डिक्रीज्ड बोमन्स कैप्सूल हाइड्रोस्टैटिक प्रेशर. ओके, अंडरस्टूड. तो मतलब उन्होंने प्लाज्मा कोलॉइड ऑन्कोटिक प्रेशर, कैपिलरी हाइड्रोस्टैटिक प्रेशर, बोमन्स कैप्सूल हाइड्रोस्टैटिक प्रेशर, ऐसे सारे ऑप्शंस दिए थे, राइट? तो बस आपको ये याद रखना है कि कैपिलरी हाइड्रोस्टैटिक प्रेशर is a force that favors the filtration at the glomerulus. तो जो भी फैक्टर इसको इंक्रीज करेगा, it will increase the GFR. जो भी फैक्टर इसको डिक्रीज करेगा, that will decrease the GFR. And then on the other hand, plasma colloid oncotic pressure and Bowman's capsule hydrostatic pressure, these two factors, they oppose the filtration at the glomerulus. तो अगर ये इंक्रीज होते हैं तो GFR will decrease, अगर ये डिक्रीज होते हैं तो GFR will increase. इस तरीके से आपको इसका आंसर देना था. ओके, समझ रहे हो बात को? प्लाज्मा कोलॉइड ऑन्कोटिक प्रेशर, अगर ये इंक्रीज हुआ तो GFR will decrease. Bowman's capsule hydrostatic pressure, it opposes the filtration. तो अगर ये इंक्रीज हो गया तो GFR will decrease. जैसे कि होता है रीनल स्टोन्स में, मैंने ये लेक्चर में बताया भी है कि नेफ्रोलिथियासिस की कंडीशन में ट्यूबुलर फ्लूइड्स का फ्लो रेट कम हो जाता है, एंड फ्लूइड accumulates in the Bowman's capsule. So Bowman's capsule hydrostatic pressure increases and GFR decreases. So you just have to know these factors. कौन सा फेवरिंग है, कौन सा ऑपोजिंग है, और उस हिसाब से आपको इसका आंसर देना था. आई एम श्योर आपको मतलब याद आ जाएगा, तो हम एक बार और इसको रिकॉर्ड करके प्रॉपरली इसको अच्छे से डाल देंगे वंस अगेन. ओके, चलो नेक्स्ट क्वेश्चन की तरफ बढ़ते हैं. इमेज ऑफ अ सार्कोमेर एंड मैच द फॉलोइंग. सुखबीर सिंह जी, प्रधान वेलू जी, डू यू रिमेंबर दिस क्वेश्चन? सार्कोमेर का एक हिस्टोलॉजिकल व्यू दिया था या माइक्रोस्कोपिक व्यू दिया था, एंड दे आर आस्किंग कि कौन से बैंड्स है वो मैच करो, ए इज व्हाट, बी इज व्हाट, सी इज व्हाट। तो चलो फटाफट इसको रिवाइज कर लेते हैं। आई एम श्योर आपने इसका आंसर करेक्ट दिया होगा, बिकॉज सार्कोमेर ना डन टू डेथ कहते हैं ना, मतलब बार 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 हम वो पढ़ते हैं सार्कोमेर और उसके बैंड्स वगैरह। तो ये तो आई एम श्योर कि नीम में भी आपको करेक्ट आंसर आएगा आपका। सो लेट्स सी, देखो दिस इज अ सार्कोमेर and Z lines. On either side of the Z line, some distance, there are only thin filaments. So this is I band. Correct? तो ये हो गया I band, isotropic to polarized light, and the remaining portion is A band, anisotropic to polarized light. So this is I band, this is A band, जिसमें थिन और थिक दोनों फिलामेंट्स आते हैं। देन एट द वेरी सेंटर ऑफ द ए बैंड देयर इज एच जोन, जिसमें सिर्फ थिक फिलामेंट ही है, थिन फिलामेंट एंड हो गए, तो सिर्फ इतना पार्ट है एच जोन, और उसके सेंटर में एम लाइन है। सो यू नो दिस सौरभ सिन्हा जी, आई बैंड, ए बैंड, जेड लाइन एंड एम लाइन, करेक्ट। तो हमने आपने आई एम श्योर कि इसका करेक्ट दिया होगा आंसर, ऐसे ही दिया था ना डायग्राम। तो आई बैंड और अच्छा, ये तो मैंने डायग्राम निकाला है, वहां पे आपको शायद पिक्टोरियल मतलब इमेज था या माइक्रोस्कोपिक व्यू दिया था, बट एनीवेज वो देख के समझ में आता है कि कौन कौन से बैंड्स है। ऑल राइट, सो आई बैंड, ए बैंड, और क्या क्या दिया था, जेड लाइन। हाँ, जेड लाइन तो देखने पर उधर वो माइक्रोस्कोपिक व्यू में भी समझ में आती है। तो जेड लाइन एंड एच बैंड ना, एम लाइन, सॉरी एम लाइन। तो एम लाइन यहां पे होती है एट द वेरी सेंटर। दिस इज अ रिपीट क्वेश्चन बाय द वे, जितने भी लोगों ने अटेंड किया है और अभी ये सेशन अटेंड कर रहे हैं, दिस इज अ रिपीट क्वेश्चन, ये पहले भी आ चुका है, सेम इमेज पहले भी दिखाई जा चुकी है। तो दीज आर द बैंड्स इन द सार्कोमेर। और एक क्वेश्चन स्टूडेंट्स ने हमको बताया, ये क्वेश्चन, लेकिन इसके बारे में ज्यादा कुछ बता नहीं सके। तो रामनारायण दास जी, आप ये क्वेश्चन देखो, आपको याद आ रहा है क्या? ट्रू स्टेटमेंट रिगार्डिंग फिजियोलॉजिक डेड स्पेस इज, क्या आपको ये रिकॉल हो रहा है क्वेश्चन? ट्रू स्टेटमेंट रिगार्डिंग फिजियोलॉजिक डेड स्पेस इज, इट इज लेस कंपेयर टू द एनाटॉमिक डेड स्पेस, स्पेस विथ लेस अल्वियोलर वेंटिलेशन, स्पेस विथ लेस रीजनल ब्लड फ्लो, और एक ऑप्शन था जो कि किसी स्टूडेंट को याद नहीं आया। तो सुखबीर सिंह जी, सौरभ सिन्हा जी, क्या आपको ये क्वेश्चन याद आ रहा है? कैन यू रिकॉल दिस क्वेश्चन? ये क्वेश्चन था भी, हो सकता है होगा ही ना, तभी तो 2-3 स्टूडेंट्स ने बताया कि ऐसा क्वेश्चन था। वन ऑप्शन वाज इट कैन बी कैलकुलेटेड बाय स्पायरोमेट्री। ओके, इट कैन बी कैलकुलेटेड बाय स्पायरोमेट्री। नहीं, स्पायरोमेट्री से फिजियोलॉजिक डेड स्पेस डायरेक्टली तो कैलकुलेट नहीं कर सकते। डेड स्पेस के लिए, उसके मेजरमेंट के लिए आपके पास फाउलर्स मेथड, बोर्स मेथड, ऐसे मेथड्स है अलग से। तो फिजियोलॉजिक डेड स्पेस इज कैलकुलेटेड बाय और मेजर्ड बाय बोर्स मेथड, एक्सपायर्ड पीसीओ2 एनालिसिस। हाँ, जय श्री राम जी कह रहे इट इज मोर कंपेयर टू एनाटॉमिक डेड स्पेस। तो करेक्ट, ये ऑप्शन सही नहीं है, लेस कंपेयर टू एनाटॉमिक डेड स्पेस। चलिए, फिजियोलॉजिक डेड स्पेस क्या होती है? एनाटॉमिक डेड स्पेस प्लस द अल्वियोलर डेड स्पेस इज फिजियोलॉजिक डेड स्पेस। ओके, नॉर्मली स्पीकिंग एनाटॉमिक डेड स्पेस एंड फिजियोलॉजिक डेड स्पेस शुड बी आइडेंटिकल, मतलब ऑल अल्वियोलाई शुड बी फंक्शनिंग परफेक्टली, लेकिन ऐसा होता नहीं है। तो फिजियोलॉजिक डेड स्पेस इज स्लाइटली मोर देन द एनाटॉमिक डेड स्पेस। एनाटॉमिक डेड स्पेस तो फर्स्ट 16 जनरेशंस की होती है, और स्पेस विथ लेस अल्वियोलर वेंटिलेशन। फर्स्ट ऑप्शन इज रॉन्ग। हाँ, फर्स्ट ऑप्शन इज रॉन्ग, करेक्ट, हम कह रहे हैं ना वो रॉन्ग है ऑप्शन। व्हाट एल्स? अच्छा, पार्थ आचार्य जी कह रहे हैं कि स्पेस विथ लेस रीजनल ब्लड फ्लो। हाँ, करेक्ट। तो जस्ट आपको क्विकली बता दूं यहाँ पे कि फिजियोलॉजिक डेड स्पेस बेस्ड ऑन द वेंटिलेशन परफ्यूजन रेशियो, V to Q रेशियो। हाँ, आपको पता ही है नॉर्मल अल्वियोलर वेंटिलेशन इज 4 liters per minute and normal blood flow is 5 liters per minute, therefore 4/5 0.8। तो अगर वेंटिलेशन है किसी रीजन में, एडिक्वेट वेंटिलेशन है, लेकिन ब्लड फ्लो, डिनोमिनेटर ब्लड फ्लो, वो अगर उसको मैच नहीं कर रहा, इनफ ब्लड फ्लो नहीं है, तो वो बन जाता है वेस्टेड वेंटिलेशन एंड इट बिकम्स अ पार्ट ऑफ फिजियोलॉजिक डेड स्पेस। ओके, तो आपको ये रिमेंबर करना है कि अगर लेस रीजनल ब्लड फ्लो है, तो क्योंकि ब्लड फ्लो नहीं है उन अल्वियोलाई को, तो वहां वेंटिलेशन और गैस एक्सचेंज नहीं हो सकेगा एंड इट्स अ वेस्टेड वेंटिलेशन, इट्स अ पार्ट ऑफ फंक्शनली डेड स्पेस। राइट, तो करेक्ट। स्नेहजीत ने तो 3-4 ऑप्शंस, मतलब 3-4 में से इसमें और भी बहुत कुछ लिख दिया। थैंक यू स्नेहजीत। INICET में आपका भवितव्य उज्जवल है, काफी काफी लिख दिया आपने और वो सब सही है। चलो आगे बढ़ते हैं, और कोई MCQ आपको याद आता हो तो। हाँ, अब ये सौरभ सिन्हा जी, पार्थ आचार्य जी, देखिए और बताइए, 2-point डिस्क्रिमिनेशन, विच इज द बेस्ट रिसेप्टर फॉर 2-point डिस्क्रिमिनेशन। क्या आपको ये क्वेश्चन याद आ रहा है, देखा दिखाया लग रहा है? टच के 4 रिसेप्टर्स दिए हैं, मीजनर्स कॉर्पस्कल, मर्केल डिस्क, पैसिनियन कॉर्पस्कल एंड रफिनीज एंडिंग। हाँ, सुखबीर सिंह जी ने पूछा कि इसका फिजियोलॉजिक डेड स्पेस का आंसर क्या था। आंसर वाज द थर्ड ऑप्शन, व्हेन देयर इज लेस ब्लड फ्लो, less regional blood flow compared to ventilation. So third option was the correct, I mean that was the answer. अगर blood flow inadequate है, तो ventilation अगर alveolus में है तब भी वो wasted है ना, क्योंकि ऑक्सीजन जा नहीं पाता, ब्लड ही नहीं है, ब्लड फ्लो नहीं है alveolus को, तो it becomes a part of functionally dead space. So third was the okay. क्या ये क्वेश्चन आया था? एग्जैक्टली सेम आया था सौरभ सिन्हा जी। डू यू रिकॉल द क्वेश्चन एंड इज दैट द क्वेश्चन? ओके, मुझे यहाँ पे किसी स्टूडेंट्स ने ये भी बताया, कोई कोई स्टूडेंट्स ने, कि इसके साथ पूछा गया था फॉर द रीडिंग ऑफ ब्रेल विच रिसेप्टर इज द बेस्ट। तो क्या ब्रेल भी था उसमें या सिर्फ 2-point डिस्क्रिमिनेशन था? तो मैं यहां पे थोड़ा सा आई वांट टू डिफरेंशिएट बिटवीन द टू। 2-point डिस्क्रिमिनेशन के लिए क्या जरूरी है? उसके लिए रिसेप्टर डेंसिटी अच्छी होना जरूरी है। मतलब रिसेप्टर डेंसिटी जितनी ज्यादा, उतना 2-point डिस्क्रिमिनेशन इज बेटर। और 2-point डिस्क्रिमिनेशन बेटर मतलब क्या? 2 पॉइंट्स बहुत नजदीक होते हुए भी आप उनको 2 पॉइंट सेपरेटली डिस्क्रिमिनेट कर पाते हो, वो डिस्टेंस लेस होते हुए भी। तो फिंगर टिप्स पे होता है, आपको पता है। और वो क्यों होता है? बिकॉज मर्केल डिस्क, जिनकी डेंसिटी फिंगर टिप्स में ज्यादा है और वो लोकेशन ऑफ द टच डिटेक्ट कर पाते हैं अच्छे से, इसलिए वो बेस्ट है फॉर 2-point डिस्क्रिमिनेशन। ओके, तो क्या सौरभ सिन्हा जी यही क्वेश्चन था? अगर यही क्वेश्चन था तो इसका आंसर है मर्केल डिस्क। ओके, अगर ये सेम क्वेश्चन ऐसा था, तो मैं सिर्फ आपसे और पूछना चाह रहा हूं कि क्या ब्रेल का मेंशन था उस क्वेश्चन में, तब प्रॉब्लम हो जाएगा। मैं जानता हूं एनाटॉमी में कुछ प्रोफेसर बताते हैं, मेरे फ्रेंड ही है वो, राजेश कौशल सर, वो हमेशा बताते अक्सर कि ब्रेल के लिए मर्केल डिस्क इज गुड। और मैं फिजियोलॉजी में पढ़ाता था, ब्रेल के लिए मीजनर कॉर्पस्कल इज गुड। तो स्टूडेंट्स हमेशा हम दोनों को पूछते थे, सर वहां सर ने ये बताया, आप यहाँ पे ये बता रहे हो। तो आई वुड जस्ट लाइक टू से वन ऑप्शन वाज ऑल ऑफ द अबव। अच्छा, ऑल ऑफ द अबव भी था इसमें? खैर, डॉक्टर मेडिको इज सेइंग ऑल ऑफ द अबव भी था ऑप्शन में। खैर, आपको आगे के लिए बता के रखता हूं कि अगर ब्रेल पूछा जाए, ओके, आई एम नॉट सेइंग कि इसमें था, अगर ब्रेल इज देयर इन द क्वेश्चन, then your answer should be Meissner's corpuscle. Okay, please mark my words again. इसमें बहुत सारा कंफ्यूजन और कंट्रोवर्सी है, मैं जानता हूं उस बात को, लेकिन देखो, मीजनर्स कॉर्पस्कल और मर्केल डिस्क ये दोनों ही मैकेनो रिसेप्टर्स है, ये दोनों ही रिलेटिवली सुपरफिशियल रिसेप्टर्स है. मोस्ट सुपरफिशियल इज मर्केल डिस्क, द ओनली रिसेप्टर इन द एपिडर्मिस इज द मर्केल डिस्क, और उसके बाद मीजनर कॉर्पस्कल थोड़ा नीचे, यहां तक ठीक है. दोनों ही टच के लिए है, दोनों ही मैकेनो रिसेप्टर्स है, दोनों ही स्किन में है. तो अब ब्रेल पढ़ते वक्त ये सारी प्रॉपर्टीज चाहिए, लेकिन एडिशनली एक और प्रॉपर्टी चाहिए. देखो ब्रेल कैसे पढ़ा जाती है, वो ब्रेल कैसे पढ़ी जाती है, आप एक लेटर को टच करते हो, उसका टच का सेंसेशन जाता है कॉर्टेक्स तक, तो लेटर आपको मालूम पड़ गया. फिर द रिसेप्टर हैज टू क्विकली अडैप्ट, अडैप्टिंग रिसेप्टर है ना, रैपिडली अडैप्टिंग, तो रिसेप्टर हैज टू अडैप्ट and then you move to the next letter. So we need a rapidly adapting mechanoreceptor in the skin, और वैसा रिसेप्टर है मीजनर कॉर्पस्कल. ओके, तो अगर ब्रेल लिखा है तो आंसर शुड बी मीजनर कॉर्पस्कल. अदरवाइज अगर क्वेश्चन ऐसा ही था एग्जैक्टली तो आंसर शुड बी मर्केल डिस्क. तो इस तरीके से ये क्वेश्चंस अभी तक मिल गए हमको, एंड आई थिंक दैट्स ऑल फॉर नाउ फ्रॉम मी. थैंक यू वेरी मच. फिजियोलॉजी क्वेश्चंस इतने तो मिल चुके हैं अभी तक, और बाकी हम और स्टूडेंट से लेंगे. आप लोग फटीग्ड रहते हो, टायर्ड रहते हो, सो दैट्स ऑल आई गेस. ओके, सुखबीर सिंह जी ने क्वेश्चन पूछा है. वन क्वेश्चन वाज देयर, एन ओल्ड एज मैन अबाउट 60 इयर्स whose pulse pressure is increased due to okay, अगर 60-year-old man है तो pulse pressure is increased because of an increase in the systolic blood pressure. आपको याद होगा, अच्छा वो है ही नहीं क्वेश्चन में, ऑप्शंस में there is a decrease in the stroke volume, there is increase in the stroke volume and there is increase in the systolic pressure. डिक्रीज्ड कार्डियक आउटपुट, ये भी सही नहीं है. डिक्रीज्ड आर्टीरियल कॉम्प्लायंस, ये ठीक है. डिक्रीज्ड आर्टीरियल कॉम्प्लायंस होता है 60-year-old मैन में, वेसल्स आर स्टिफ, और उसकी वजह से डिक्रीज्ड आर्टीरियल कॉम्प्लायंस. बिकॉज ऑफ दैट, बिकॉज ऑफ द एथेरोस्क्लेरोसिस एंड अदर रीजंस, सिस्टोलिक बीपी बिकम्स हायर. आपको याद है ना, आफ्टर द एज ऑफ 40 सिस्टोलिक बीपी इज इक्वल टू 100 प्लस एज इन ईयर्स. याद है ना, तो 100 मतलब 60 साल की उम्र में सिस्टोलिक बीपी शुड बी 160 मिलीमीटर्स ऑफ मर्क्यूरी, एंड इट्स मेनली बिकॉज ऑफ द स्टिफनेस ऑफ द वेसल्स. वो कंप्लायंट नहीं रहती है, ओके, वो स्टिफ हो जाती है, एंड दैट इज द रीजन व्हाई सिस्टोलिक बीपी एंड देयरफॉर पल्स प्रेशर इज वाइडर इन दिस एज ग्रुप. चलो, डिक्रीज्ड इलास्टिसिटी या इंक्रीज्ड आर्टीरियल कॉम्प्लायंस. सो आई गेस इतना ही था. अरे अल्लादिता जी, वेलकम. Physiology is just about to get over, so I request the next subject to take over.
Thank you,
Hello,
sir.
ma'am.
Thank you for that
Yeah.
recall. And आपका assessment क्या रहा for this paper? Dr. Vivek, if you could just come on board for a second.
Yeah, I think overall physiology questions were quite straightforward, and
Okay.
I hate to say this all every year कि everything came from my notes or my teachings. But yeah, I mean physiology ऐसा सब्जेक्ट है कि हम सब कुछ कवर कर ही लेते हैं और फिर नोट्स में से बहुत कुछ आता ही है.
Okay. Thank
But
you.
इस बार सच में वैसा था.
सर, स्टूडेंट्स को बहुत गुस्सा आता है जब हम ऐसा बोलते हैं ना आफ्टर द
हाँ, बिल्कुल गुस्सा आता है. उनको लगता है कि ये अपना प्रमोशन कर, अपनी मार्केटिंग कर रहे हैं, देखो देखो. और कुछ हद तक ये सही भी है मैम, क्योंकि मैं अक्सर जोक करता हूँ अपने क्लासेस में भी कि कल को उठ के गाइटन और गैनोंग बोलना शुरू कर देंगे. देखो देखो हमारे बुक से क्वेश्चन आ गया. तो
But
ऐसे थोड़ी होता है
sir,
वो।
the
चल ठीक है,
question is
कोई
कि
बात नहीं।
not that कि हम जो एक होता है कि प्रिडिक्ट करते हैं, कभी कभी हम क्लास में बोलते हैं ना कि ये इंपॉर्टेंट क्वेश्चन है, इससे आएगा, तो
हाँ
पढ़ने को देयर इज अ लॉट ऑफ थिंग्स इन द सिलेबस ऑलरेडी। वो तो गाइटन गनोंग कोई नहीं पढ़ता है ना प्रेप के लिए, बट द क्वेश्चन इज
नहीं, मैम मैं कह रहा था कल को गाइटन और गैनोंग खुद ये बोलना शुरू करेंगे।
आई अंडरस्टूड सर व्हाट यू वर सेइंग, बट हाँ, बट मैं बोल रही हूँ कि जो हमारा प्रिडिक्शन रहता है कि जिस टॉपिक्स पे ज्यादा स्ट्रेस करना है, वेदर दोज टॉपिक्स वर द वंस, कभी कभी हम ऐसे 2 मिनट लगा के एक टॉपिक बोलते हैं और कभी क्वेश्चन उससे आ जाता है तो हमें भी बुरा लगता है।
यस
थैंक यू सर,
ओके,
थैंक यू।
या थैंक यू
We
मैम।
have Alekhya ma'am, our
ma'am.
female orthopedician. So,
How are you,
ma'am,
ma'am?
good evening. What was your assessment of the paper this time? Ortho say usually, questions, usually they are not the ones that people are unhappy with. Weightage इस बार काफी कम रहा ortho का, it
Yeah.
seems.
Good evening, ma'am. Can you hear me?
Yeah, I can hear you. You're audible, ma'am.
Yeah, thank
I
you.
heard this time the weightage was less in ortho, which is a pity
Yes,
because usually ortho is one of the scoring short subjects.
yeah.
So,
Yeah, disappointed, ma'am. Even I was so disappointed. I was just looking for my questions on a group. I couldn't find them. There were only hardly some 3 or 4 questions. So I was deeply disappointed this time. But I hope people have done well because most of them from the
but
basic.
if most of the students were like the way I was when I took my exams, तो मैंने तो exam के बाद phone off करके I had gone to sleep that I don't want to discuss anything with anyone. It will just spoil my mood. So maybe
Okay.
we'll get more questions as the
Yeah.
progress. So
Let's
for
hope.
now, yeah, for now, let's just make do with what we have, and later maybe we can come back with more questions if we get
Yeah.
them.
Let's
Okay.
hope people are more like you and they'll get up tomorrow and let me know more questions from INICT. So, guys, welcome. Hope you're all doing good. Don't feel disappointed, guys. It's fine, it's okay. It is a matter of only one exam. We have so many exams lined up there. So this was one of the important questions we keep discussing every time. What is the treatment for the intracapsular fracture, especially in the younger population? That is, if you see 40 years is a younger population, right? So usually what we do is whenever there is an IC fracture, there is an algorithm for it. So IC fracture, there are various, we have classifications. We have to see whether it is an undisplaced fracture or a displaced fracture, right? Based upon that, we treat. But most important thing for any IC fracture is first you have to know whether it is in a young patient or an elderly patient. So if it is in a young patient, usually we go for osteosynthesis. So what is osteosynthesis? Osteosynthesis is we are trying to protect whatever is there. So we are trying to fix the fracture, right? But if it is more than 60 years, that is elderly population, what we do? We go for replacement. That is nothing but by the prosthesis. So this prosthesis will come into play whenever there is an elderly population sitting there, okay? But now in our question, because this is a 40 years old, thinking that this is a young individual, and now it depends upon whether it was a displaced fracture or a undisplaced fracture. If it was an undisplaced fracture, straight away we go for closed reduction and internal fixation, that is by the CC screws. If the fracture is notorious, if they're unable to displace, if they're unable to reduce it, then we go for open reduction and internal fixation. But if the answer is closed reduction and internal fixation, happily you can mark that because this is done mainly by the CC screws fixation with the help of the C arm. And if you all remember, it is done in a triangular fashion, right? If you remember, inverted triangular fashion like this. So these are called the the cancellous screws. So these screws are something like this with the threads at the end, and there is a gap here. So this is there to pass the guide wire. So this makes the surgical technique easy. So this is called the cannulated cancellous screws. That is the CC screws. And we put in this inverted triangular fashion. That means one screw should be there in the inferior cortex, one in the posterior cortex, right? So this is the treatment for any intra-articular fracture, which is in 40 years old. Now coming to elderly population, that is above 60 years. Is there anything we need to add to the question? So if the population is above 60 years, then we go for prosthesis. So this could be a hemi arthroplasty, that is only replacement of the femoral head, or if the patient is an active individual, or if something is associated with the acetabulum, or if there are any acetabular erosions, if the patient is a very active individual, then we directly go for what is called as the total hip replacement. That is completely replacing the acetabulum and the femoral ball, that is the femoral head, right? So now the answer would be CRIF, that is the closed reduction internal fixation, that is with CC screws. So this is the answer for the intracapsular fracture. I think this is the one question which is straightforward and which is, easy, and we have discussed it numerous times in our classes. Fine. Okay, now going to the next question. This is question number 2, and this was asked in the recent previous exams also. What is FRAX? What is FRAX? So now slowly the medicine is shifting toward the prevention, right? So we want to prevent the diseases before they occur. Like for the cancers, now we have preventive vaccinations, we have various tools. Similarly, to prevent fractures, because this is one of the most important thing in the elderly population, which cause morbidity and mortality, right? So that is why now the shift is towards FRAX. So what is this FRAX? It is fracture risk assessment. So this is individual risk assessment tool. So you already know the one thing which tells you whether the patient is osteoporotic or not is your bone mineral density. So for that, we have the DEXA scan, right? So this DEXA scan is already there, but what happened is the UK government, I mean, many physicians from the United Kingdom has developed this tool, which is called as the fracture risk assessment tool for the individual risk assessment. So this will tell you in the near future, that is in 10 years, what is your risk of having a fracture. So for that, you have to go to their website. So this is the fracture risk assessment tool. And there are various questions which are being asked to the patient based upon their individual treatment or the individual conditions. You're going to mark them. So you are going to put the age, then the sex, then the weight, height. They will calculate your BMI accordingly. And then they will ask you a set of questions like if you're having previous fractures, are you alcoholic, a smoker? Are you suffering from any other diseases such as rheumatoid arthritis, or you had any previous history of tumors and all? And then they will calculate your fracture risk. So this risk, if it is less than 5%, usually you're not at risk. That means you're at a low level. If this risk is more than 20%, that is you are at a higher risk. So this is called high risk for that fracture. I mean that for that particular individual. And now we will put this patient on the treatment for the prevention of fractures, such as your osteoporosis treatment. But this doesn't stand only as an individual tool. So this FRAX, sometimes it is combined with the DEXA scan. Right? So we combine this with the DEXA scan and then we try to treat the patient. For example, if you take this DEXA scan also, sometimes you come between, if it is less than 2.5, you all know that this is osteoporotic, right? So it is somewhere between more than 1 and less than 2.5. There you can go for this FRAX. Okay, so this is not only tool which is there to know your bone mineral density. You can club it along with your BMDs, or you can club the BMD along with the FRAX. Overall, you will tell the patient about their risk of having fractures in the near future. That is up to 10 years. 10 years fracture fragility test. Understood? So based upon the percentage, how much, whatever the percentage they get calculated based upon their points, they will be treated accordingly. Okay, if the risk is low, then they can just change their lifestyle. So the lifestyle modification would be enough. If the risk is high, they have to do the lifestyle modification along with the treatment. So that is the answer. But here the question was straight away, what is the full form of this? So that the answer would be fracture risk assessment tool. That's it. So the answer is straight away fracture risk assessment tool. So I think no confusion about this question anywhere. And now the confusion arises controversy arises here with the third question. So I couldn't frame the entire question, nor I couldn't get the exact image for you. But what I have received is only this, that is, there was an X-ray which was put up showing you that involvement of the femur and the hip joint. And there are certain wordings, that is the trivial injury, patient had fracture and got admitted. Right. So whenever there is a trivial injury and if a fracture happens, that means this is no doubted, it is a pathological fracture. So this is a pathological fracture, right? So whenever there is a pathological fracture, there could be an underlying disease in the bone. So that disease could be a tuberculosis or a metastasis or any other primary condition, right? So based upon that, so here what happens is the clinical scenario will come into the play. So the clinical scenario, such as if the patient has any fever or if there are any parameters or if there was loss of weight and loss of appetite. So all these clinical scenarios will come into play for us to diagnose based upon the X-ray, right? So because the wordings are not so clear, we didn't know whether there was fever given in the question or whether there was loss of weight or loss of appetite, which was included in the question. But if there was something like this, a motor and a pestle appearance, right, motor and a pestle appearance, or if there was protruding acetabulum, protrusio acetabuli. So these are certain things which are very much seen in tuberculosis. So straight away, if you see something like a motor and a pestle, that is this kind of appearance. So the head becomes very, very small, which keeps wandering. And then you have this wandering acetabulum, which is called so, and then the protrusio acetabuli. So the acetabulum will be seen moving forward compared to the other side. So all these are very much typically seen in tuberculosis. If not, if there is a lot of lytic lesions and if the bone, a lot of, irregularities in the bone, and if you can see here, the bone, the pelvis bone is completely eaten up here. So this is an example of carcinoma. So exactly based upon the X-ray, we usually cannot diagnose it whether it's a tuberculosis or a cancer. That is mainly depending upon the biopsy. But at our level, sometimes based upon the clinical conditions like having fever, loss of weight, loss of appetite, we can come to a conclusion, right? If there was a fever, loss of weight, and loss of appetite, again, it could be a TB or cancer, because fever, evening rise of temperature is usually in favor of tuberculosis. Loss of weight and loss of temperature are sometimes also in favor of your carcinomas, right? So I need to construct this question again and to also know what was the exact image given. So we can put this question aside. Instead of answering it, we can just wait for a few more, 1 or 2 days to construct this question again. And final question, this was again a integrated question from anatomy. So what is a pin? Pin is nothing but the posterior interosseous nerve. So this is a branch of the radial nerve. So this is a branch of the radial nerve, right? So whenever there is a damage to the pin, so when will be there damage to the pin? It is usually iatrogenic. This pin damage is usually iatrogenic. Yes, it is usually done by the surgeons, right? So whenever we operate near the proximal radius, that is near the radial head, because this pin enters into the forearm in a muscle which is called as the supinator muscle. In the substance of the supinator muscle, this pin enters, and then it usually starts supplying the supinator and rest of the forearm muscles. And the one thing which we see in the pin palsy is digit drop or the finger drop. So the patient will be unable to extend the fingers, especially the thumb and the other finger, that is the MCP. They will be unable to extend the metacarpophalangeal joints, and they can extend the wrist because the ERCB is still intact. The extensor carpi radialis brevis is still intact. Hence, they can do the wrist extension. So wrist drop is not seen in pin injury. No wrist drop in pin injury. So there will only be a finger drop. So the answer would be the finger drop. So the answer would be the finger drop. So that is the answer. I think these are only the questions which I have collected for ortho. Let's look for more and more questions by maybe tomorrow, and we'll come back again with the constructed questions and answers. Over to Oshika ma'am back.
Thank you, ma'am. Thank you. Very crisp, very concise. Hopefully, we can get more questions in the coming days.
Yes, ma'am.
So next we have another major subject with regards to INI. I'd like to call upon Dr. Pradeep sir. Pradeep sir, are you there?
Hello?
Hello, sir. Yes, you're audible.
Hello, just one moment. Am I audible?
Yes, sir, you're audible. Sir,
Hello?
hello.
Am I audible, Dr.
Yes,
Ushika?
sir. Yes, sir, you're audible.
Thank you.
Sir,
So,
anatomy is a major subject. वो तो
one
हर
moment,
बार
I can't
INI
hear
में भर
you.
के आता ही है. तो इस बार भी आया था. Thankfully, anatomy was spared. Physio
Yeah,
biochem का
one
मैंने
moment.
सुना कि the questions were very few. So, what was your analysis of the questions?
So the questions were good. There were some visuals which were difficult, but the rest of the questions were really good. Something that we have been discussing in the lectures here and there, concepts clearing, conceptual questions थे.
Conceptual scoring questions. So that is the hallmark of INI. वो हमेशा even in paraclinical subject जिसमें बच्चा सोच के चलता है कि ये तो बस चीजें याद करनी है, उसमें भी they will find a way to incorporate concepts. And AIMS is known for this. वो बच्चों को जैसे अपना पढ़ाते हैं डायग्राम वाइग्राम बना के या कुछ उन्होंने DS में दिखा दिया, they'll put up a picture of exactly that.
Right,
So, sir, over to you. Let's discuss anatomy.
Yeah, okay. So, hello students, welcome to the questions of anatomy. I'm sure बहुत सारे questions आपने answer किए ही होंगे. So let us discuss, see the options. If you have some more options with you, we can discuss them. Okay, we'll start. So the first question, student, this everyone must be knowing. This we have been discussing so many times. This H-shaped suture. Bacho, this H-shaped suture, which is formed by the joining of the frontal, the parietal, the sphenoidal, and the temporal bones. Yes, what is that? Pterion. Yes, the pterion. Hi, good evening to all of you. So this is the pterion, and what lies deep to the pterion? This question has been asked in many of the MCQs. Kabhi options alag aa jate hain. So what lies deep to the pterion? Number one is the stem of the lateral sulcus, and second is the anterior branch of middle meningeal artery. Correct? Stem of lateral sulcus and the anterior branch of middle meningeal artery. Just one moment. Okay. Right. Clear to all of you. So answer for this is stem of the lateral sulcus. Yes, bacho. Answer if you have written this. Clear. The second thing which lies deep to this pterion is the anterior branch of middle meningeal artery. Right. So that's the pterion formed by the joining of four bones: the parietal, the temporal, the frontal, and the sphenoidal bone. Clear, students? So that's the answer. Stem of lateral sulcus. Very good. Now coming to the next question. Yes, this was marked. There are plenty of visuals which have come, as always comes in the INICET. So what is this which is pointed? The inferior conchae. And what opens in the inferior meatus of the nose? Yes, that was the question. What opens in the inferior meatus of the nose? The nasolacrimal duct. Nasolacrimal duct. Clear? Inferior meatus. Middle meatus, what opens is, you must be knowing all this, the frontal sinus, the maxillary, the anterior, and the middle ethmoidal air sinus. Superior meatus, the posterior ethmoidal air sinus, and the supreme meatus, what opens is the sphenoethmoidal recess. Clear to all of you? So this pointed structure is the inferior conchae. Below that is the inferior meatus. What opens here is the nasolacrimal duct. Fine, perfect. किसी को कुछ बोलना है? कुछ variations है इसमें? Okay, fine. Okay, one of the following is not a derivative of neural crest cells. Chalo bacho, we have always been discussing this neural crest cells. Neural crest cells gives rise to a variety of structures. So out of all the structures, which is the structure not derived from the neural crest cells? Yes, what do you say? Come on, bacho, you can answer this. What have you answered this as? What have you attempted this? The chordate tendency. Chordate tendency is the structure which is not derived from the neural crest cells. Otherwise, neural crest cells gives rise to a variety of structures, mainly the leptomeninges, the melanocytes, the Schwann cell, the myelin sheath, yes, the skeleton of the face, the parafollicular C cells of thyroid, the corneal stroma, the pharyngeal arch derivatives, right? So answer for this is chordate tendency. Ciliary muscles bhi hai, they are also derived from neural crest cells. So answer for this would be chordate tendency. Yes, Nayajit. और कुछ ऑप्शंस था इसमें? Yes, बच्चों. Okay. Going to the next question. Identify the mark structure. What have you identified this as? Yes, anyone? Can you answer this? Hello, बच्चों, बोलो. थोड़ा सा difficult था ये. You remember the first thing which is formed in the third week, the formation of procaudal plate. The procaudal plate decides the formation of mouth. जैसे procaudal plate form होता है, exactly at the caudal end, what is formed? The primitive streak, right? At the caudal end of the embryo, primitive streak. एक बार primitive streak बन जाता है, what happens? It helps in the formation of 3 germ layers and it forms the notochordal process. Notochordal process से बनता है notochord. The notochord lies in the mesoderm, and this notochordal process divides the mesoderm into 3 parts: the paraxial, the intermediate, and the lateral plate mesoderm. You can see the formation of somites here, which are derived from the paraxial mesoderm. And the last thing which happens, which I always tell during the lectures of general embryology, the last thing, what is that? ऐसे depression बनता है, depression, the ectoderm folds like this. There's the formation of a groove. The ectoderm, the fold deepens, and this then separates out. What is this formation of? Yes, bolo. This is the formation of neural tube. Neural tube. So how is the neural tube formed? The neural tube is derived from the neural folds. Neural folds. Right? So the last thing is the formation of neural tube. Okay, clear? Fine. So the answer for this is neural folds. Ye hai neural folds. This neural folds, the ectoderm invaginates like this, and that forms the neural folds. The neural groove, neural folds hote hain, and this separates out to form the neural tube. The neural tube is therefore ectodermal in origin. That is how we say. And during the formation of neural tube, there are some cells which get separated and which lies on either sides of the neural tube. These are the neural crest cells. So ये जो elevated edges है ना, which have been marked, that's the neural folds. Okay. Yes, Aryan, point was out of primitive streak. Point was out of primitive streak in the exams. मतलब, see, अगर neural fold option में नहीं है, तो then it would be primitive streak. But अगर neural fold option में है, तो that is the answer would be neural fold. Aryan, fine. You can see this elevated things here. That is the neural folds. Clear? Notochord would be in the mesoderm. The pointing was behind. ठीक है? अगर पॉइंटर यहाँ पे है ना, अगर पॉइंटर यहाँ पे है तो वो प्रिमिटिव स्ट्रीक होगा. अगर पॉइंटर यहाँ पे है तो वो प्रिमिटिव स्ट्रीक होगा. लेकिन अगर और पीछे है, that's a neural folds. ठीक है? This is the slide which we have got. चलो, good. Students, you must be knowing this. ये सबने लिखा ही होगा. I'm definitely sure about this. What is this marked structure? क्या लिखा आपने? Okay. That's fine. That's fine. What is this? What is this artery? The artery which is present between the skull and the dura mater. The artery whose thrombosis leads to an extradural hemorrhage. Bacho, what is this? Bolo, bolo. You can guess. I'm waiting for your answer. That's the middle meningeal artery. Middle meningeal artery. This is the carotid angiogram. That's the middle meningeal artery, which is pointed, which lies between the skull and the dura mater. Hemorrhage. That's the extradural hemorrhage. Superficial temporal नहीं लग रहा है ये. Image is not looking like this, but something ऐसे ही था ना, something similar it was there. ठीक है, later on we'll be compiling all the questions and then we'll be putting this for you. ठीक है, fine. Identify the type of gland. ये था बच्चों. Was this the question? Was this the slide shown? The type of gland. What do you think? What is this gland histologically? Anterior view tha. ठीक है. That's fine. That's fine. Fine, Pooja. We'll come back with the actual questions later. Answer this question. What is this slide of? Bacho, can anyone tell me? What is this slide of? You can see glands here. Glands. Histologically, what would the slide be? If you know that, you would be able to answer this MCQ, the type of gland. So this is the slide of mammary gland. Okay, this is a lactating mammary gland. You can see this alveoli here. You can see the alveoli here. So if it is the breast, what is the type of gland? It's an apocrine gland. Apocrine. So answer iska hoga apocrine gland. Yes, बच्चों, ठीक है. Apocrine. Clear? Fine. Going to the next MCQ. Mitochondrion is present in which part of the sperm? चलो बच्चों, this image was different. ठीक है, image similar था बच्चा. Image was a similar image. ठीक है. Hairy follicles. Okay, fine. Answer this question. एक बार वो सवाल आ जाएंगे, we'll put those questions for you. Mitochondria is present in which part of the sperm? So we have got a head, we have got a middle piece, and we have got a tail. The head contains DNA. The middle piece contains the mitochondrion. So look, ये तो answer क्या ही होगा ना सबने. The middle piece contains mitochondrion, and the tail is used for motility by the sperm. Yes, Pooja, is this clear? Jayendra Singh. Yes, Mr. Srivastav. Aryan. Okay, great. So this was the question. The posterior intraosseous nerve injury leads to. Yes, what is the answer for this? The posterior intraosseous nerve injury leads to. Connecting part भी था option में पूजा. Okay. चलो इसको आंसर करिए. You know, radial nerve is a branch of posterior cord. The root value is C5 to T1. The radial nerve first lies in the axilla. Axilla say it enters into the spiral groove. Spiral groove say it turns and comes on the lateral aspect of the arm. And on the lateral aspect of the arm, the radial nerve is going to supply the brachialis, the brachioradialis, and the ECRL muscle. The extensor carpi radialis longus is mainly responsible for extension of the wrist. So extension of the wrist would be intact. There is not going to be any wrist drop because the radial nerve is going to supply the ECRL. After that, the radial nerve enters in the cubital fossa. In the cubital fossa, it divides into two branches. It divides into a posterior intraosseous nerve and a superficial branch. The superficial branch of radial nerve supplies the skin on the dorsum of the hand and 3 and 2.5 fingers. The posterior intraosseous nerve pierces the supinator and supplies all the muscles on the posterior aspect of the forearm. ठीक है? So supinator is pierced by posterior intraosseous nerve. Supinator is supplied by posterior intraosseous nerve. If the posterior intraosseous nerve is damaged, would supination be lost? No, not completely lost, because supinator is also supplied by whom? I mean, the supinator is supplied by posterior intraosseous nerve, but yes, it also does receive a branch from the radial nerve. So the answer for this is going to be loss of extension of the digits, because who's going to do this extension of the digits? Yes, Supination is also done by one more muscle. कौन है ये muscle? Biceps brachii. Biceps brachii का main action is flexion. Second action is supination. So even if posterior interosseous nerve is damaged, वो musculocutaneous nerve is intact, which supplies the biceps. So supination would not be lost. The movement which is going to be lost would be the extension of the digits, right? The extension of the digits is done by extensor digitorum, and this extensor digitorum is supplied by the posterior interosseous nerve, right? So posterior interosseous nerve injury leads to loss of extension of digits. This is going to be the answer. Extension of wrist is going to be intact because this is done by extensor carpi radialis longus, which is supplied by the radial nerve. Radial nerve kahan pe? On the lateral aspect of the arm. ठीक है? ठीक, clear to all of you? स्नेहा जी, dorsal interosseous क्या करते हैं? Fine. Okay, was this picture there? Name the mark structure. What is this nerve? Can anyone tell me what is this nerve? Come on, students. What is this nerve? That's the oculomotor nerve. Okay, this was a slide in which the skull cap was cut. The interior was shown with the nerve pointed. So the nerve is oculomotor nerve. Oculomotor है बच्चा. Aryan, ये oculomotor nerve है. ठीक है? Fine. ये क्वेश्चन था, in walking leg raise, hip support is maintained by. So which is the muscle which is responsible for supporting the thigh, the hip, when one foot is off the ground? When one foot is off the ground, the opposite side, gluteus medius and minimus, are going to stabilize the pelvis, right? So answer for this is going to be the gluteus medius. Gluteus medius and minimus है ना वो? Yes. Yes, Pooja, correct. So when one foot is off the ground, which the opposite side, gluteus medius and minimus, would prevent the pelvis from falling on that side. So answer for this is gluteus medius. Right? Fine. Identify the mark structure. Chalo bachcho, this all of you must have answered. What is this pointed structure? This is a slide of cardiac muscle, and the characteristic of cardiac muscle: nucleus in the center, striation seen, and what is that which separates the two cells? Yes, the intercalated disc. So this pointed structure is the intercalated disc, right? ठीक है? So this is as far as anatomy goes. I hope all these things are clear to all of you. कुछ डाउट, कुछ? वन मोमेंट. ठीक है बच्चों? यस, वेयर इज ओशिका मैडम? फाइन. सो दिस इज ऑल अबाउट एनाटॉमी. ये सवाल थे, और भी कुछ एक सवाल होंगे which we'll be getting it later. We'll be giving it to you later. Fine.
Thank you,
Hello,
sir.
Dr. Rishabh.
Hello, hi, sir. Thank you for that elaborate introduction.
थैंक यू. काफी विजुअल्स आए थे. एक दो विजुअल्स थोड़े से डिफिकल्ट थे, बट यस, अगर है ना, स्टूडेंट्स मस्ट हैव आंसर्ड.
यस सर, थोड़ा इस बार इवन रेडियोलॉजी में और ऑब्जन गाइनी में वन और टू क्वेश्चंस वर लिटिल ट्रिकी. थोड़ा बाउंसर टाइप आ गए, बट ओवरऑल वी वुड लेबल इट अराउंड मॉडरेट क्वेश्चन.
ओके,
थैंक यू सर.
थैंक यू सो मच. थैंक यू बच्चों. थैंक यू डॉक्टर ऋषभ. थैंक यू.
Thank you, sir. So now we'll start with biochemistry by Jambulkar, sir. So welcome, sir. First of all, a brief overview of today's examination. Biochemistry में लोग बच्चे बोल रहे हैं थोड़े कम क्वेश्चन आए as compared to last session. What are your views, sir?
Hi, Rishabh, sir. Am I audible?
Yes, sir.
Hello, everyone. Hello, students. Good evening to all of you. कम क्वेश्चन आए ऐसा कुछ नहीं है. इंटीग्रेटेड क्वेश्चंस आए, मतलब 10 to 13 क्वेश्चंस वाज देयर, और आखिरी के 3-4 क्वेश्चंस जो है वो ओवरलैपिंग क्वेश्चंस है, ओवरलैपिंग विथ अदर सब्जेक्ट. सो इंटीग्रेटेड अप्रोच वाज देयर. एंड सेकंड थिंग इज द क्वेश्चंस वेयर प्रैक्टिकल एस्पेक्ट्स, क्लिनिकल एस्पेक्ट. जैसे आप इंटर्नशिप में वैक्यूटेनर पे 2-3 क्वेश्चन है, फिर इन्वेस्टिगेशंस रिलेटेड 1-2 क्वेश्चंस है. तो ऐसा थोड़ा सा इंटीग्रेटेड और प्रैक्टिकल अप्रोच पूछा गया है. हाय ऋषभ सर.
Hello, hi, sir.
Should I start?
Yes, sir, please.
Okay. So the starting from the first question, so level was moderate, not easy, क्योंकि यहाँ पे आके एनालिसिस करते वक्त वो इजी लगते हैं, लेकिन जब हम एक्चुअल में सॉल्व करते हैं एग्जाम हॉल में बैठ के तब डिफिकल्टी लेवल थोड़ा हाई लगता है. तो इट इज मॉडरेट टू डिफिकल्ट लेवल क्वेश्चंस, बट मेनली द प्रैक्टिकल बेस्ड क्वेश्चन मोर देन, मतलब अंदर के जो पूछते हैं क्वेश्चंस उस वैसे पूछे नहीं गए इस बार. थोड़े से ऊपर से थे क्वेश्चंस, बट दे वेर बेस्ड ऑन प्रैक्टिकल एस्पेक्ट्स. तो जिसने काम किया है एक्चुअल में इंटर्नशिप में उसके लिए क्वेश्चंस थोड़े इजी हो जाते. ओके, सो सी which of the following, the first question was which of the following is not a cytochrome oxidase inhibitor. Cytochrome oxidase means complex 4 of electron transport chain. और ये काफी इजी क्वेश्चन था. आप होप कि आप सबने ये करेक्ट किया होगा. सो गैसेस, ऑल गैसेस, कार्बन मोनोक्साइड, हाइड्रोजन सल्फाइड, साइनाइड, अजाइड, these are the inhibitor of complex 4. Here answer is nitric oxide. Okay. Hi Snehajit, hi Pooja, hi Aryan, hi Jiten, जयेंद्र, हाय श्रीवास्तव. आपने काफी अच्छा इनपुट दिया है क्वेश्चंस को. थैंक यू वेरी मच. ओके, सो दिस वाज द फर्स्ट क्वेश्चन. नाउ सेकंड, व्हिच ऑफ द फॉलोइंग इज अमोनिया डोनर टू benzoate. So benzoate, it is used in the treatment in the urea cycle disorders. It is used in the treatment of urea cycle disorder. Which of the following is ammonia donor? So this question, it is based on detoxification reaction, and also it is based on the treatment, in the treatment of hyperammonemia. So here answer is glycine. Glycine combines with the benzoate to form hippuric acid and excreted. So it lowers the ammonia level. It lowers the ammonia level. Here answer is glycine. Okay. Nitric oxide. Hi Snehajit, correct. Nitric oxide is the correct answer was for the first question. Bright moon. Okay, glycine. Glycine is the correct answer. Okay, here glycine combines with the benzoate to form hippuric acid and it is excreted. It is based on detoxification and it is in the treatment of hyperammonemia. Now the similar question, now see the similar question. In urea cycle, which amino acid, here amino acid, is a donor of ammonia group? Now see, urea cycle, there is synthesis of urea. There is synthesis of urea and amino groups. These two amino group, first and second amino group. First one is donated by the ammonia and second is from the, yes, bright moon. Here answer is aspartate. Ammonia is donated. One is from the ammonia, which is detoxified, and second is from the aspartate. Okay. सो ये पोर्शन जो है अमोनिया डिटॉक्सिफिकेशन, इस पे काफी बार क्वेश्चन आते हैं. हाउ अमोनिया इज ट्रांसपोर्टेड? इट इज फ्रॉम द मसल इन द फॉर्म ऑफ एलानिन, फ्रॉम द इंटेस्टाइन एंड ब्रेन in the form of glutamine. It is transported. Benzoate combines with the glycine to form hippuric acid, lowers the ammonia level. And in urea, in the structure of the urea, amino group, one is from the ammonia, second is from the aspartate. The question were specifically on the amino acid. Okay. Now the next question, deficiency of copper. जनरली विटामिन और मिनरल पे काफी सारे क्वेश्चंस रहते हैं. इस बार सिर्फ ये एक मिनरल पे क्वेश्चन देखा, विटामिन पे जो क्वेश्चंस थे वो काफी कम आए इस बार. डेफिशिएंसी ऑफ कॉपर which is needed for lysyl oxidase. See, lysyl oxidase, here hint, lysyl oxidase causes defective cross-linking of collagen in. Here answer is Menkes disease. What happens in the Menkes disease? It is related with the copper absorption in the intestine when there is mutation in the ATP7A. ये पोर्शन हम लोग करते हैं प्रिपेयर करते वक्त. वेरियस ATP बाइंडिंग कैसेट ट्रांसपोर्टर जिसमें A is related with the Menkes disease, ATP7A, ATP binding cassette transporter. So 7A is related with the Menkes disease, 7B is related with the Wilson's disease. So A comes first, M comes first. So Menkes disease, ATP7A mutation. That's why there is decreased absorption of copper occurs. And as there is decreased absorption of copper, this lysyl oxidase enzyme, it is dependent on the copper. So there is defective collagen cross-linking. इसका काम क्या है? Collagen cross-linking में इसका रोल है किसका? लाइसिल ऑक्सीडेज का. सो इसकी एक्टिविटी कम हो जाती एंड in Menkes disease. So this is related with the Menkes disease. Okay. The next question, see, just wait. Menkes disease, it is neurodegenerative disorder, mental retardation is there, hypopigmentation is there, steely wire, मेंकेज किंकी हेयर सिंड्रोम भी बोलते हैं इसको. स्टीली हेयर मतलब हेयर रहते, इजीली प्लकेबल हेयर्स रहते, न्यूरोडिजेनरेटिव डिसीज है बिकॉज ऑफ डिक्रीज कॉपर लेवल एंड डिक्रीज एक्टिविटी ऑफ लाइसिल ऑक्सीडेज एंजाइम. ट्रू रिगार्डिंग एक्यूट पैनक्रियाटाइटिस. एक्यूट पैनक्रियाटाइटिस, इसमें हम लोग दो एंजाइम ऐसे करते हैं, एक अमाइलेज और लाइपेज, जिसमें से अमाइलेज काफी पॉपुलर है क्योंकि अमाइलेज के एस्टिमेशंस के मेथड्स पहले आए और लाइपेज के थोड़ा बाद में आए, और लाइपेज एस्टिमेशंस के जो कीट्स है वो काफी महंगे हैं. ओके. Now, lipase is more specific for the diagnosis of acute pancreatitis than the amylase because amylase level increases in other diseases. It is not particularly specific for pancreatitis. So here answer is lipase is more specific than amylase because lipase increases in pancreatitis while amylase also increases in salivary gland diseases. Also, intra-abdominal tumors, intra-abdominal perforations or conditions, amylase level increases while lipase is specific for the diagnosis of pancreatitis. It is specific than the amylase. So here answer is lipase is more specific than the amylase. Okay. द नेक्स्ट क्वेश्चन इज, ये ऑलरेडी रंजित सर ने कवर किए तो मैं शॉर्ट में कवर करूंगा. विच वैक्यूटेनर इज यूज फॉर HbA1c एस्टिमेशन. नाउ सी, वैक्यूटेनर पे 2 क्वेश्चंस थे और हर साल, मतलब अभी पिछले साल से हर एग्जाम में, वेदर इट इज INICET और दैट इज INICET में भी पूछा जाता है और नीट PG में भी पूछा जाता है और FMG में भी पूछा जाता है इस पे क्वेश्चन वैक्यूटेनर पे. तो ये पार्ट अच्छे से करके रखना है. इसके लिए एक न्यूमोनिक भी हमने पढ़ाते वक्त बताया था, दैट बनी रैबिट गेट प्रेग्नेंट फूड. बनी रैबिट मीन्स पहले ब्लड कल्चर बॉटल आती है, रेड, गेट ग्रीन, पर्पल एंड द फ्लूराइड वैक्यूटेनर ग्रे ट्यूब. ऐसे ट्यूब्स, डिफरेंट ट्यूब्स एंड द ऑर्डर ऑफ ड्रॉ इज इंपॉर्टेंट. सो विच वैक्यूटेनर इज यूज फॉर HbA1c एस्टिमेशन. रंजीत सर ने इस पे काफी अच्छा फोकस और काफी अच्छी चीज बताई. इट इज रिलेटेड विद द हीमोग्लोबिन. It tells about the average blood glucose level for preceding 6 to 8 weeks, but it is related with the hemoglobin. So here answer is EDTA. EDTA tube अभी काफी कॉमनली ये HbA1c ग्लाइकेटेड हीमोग्लोबिन का इन्वेस्टिगेशन किया जाता है एंड द ब्लड इज ड्रॉन इन द EDTA ट्यूब. इट इज EDTA ट्यूब फॉर द एस्टिमेशन ऑफ HbA1c. नाउ रिमेंबर दिस ऑर्डर ऑफ ड्रा. सी, bunny, rabbit get pregnant food. Now see, this is blood culture first, followed by the blue tube, that is citrate, which is for the coagulation studies. In short, I will discuss in short. Rabbit means red. In place of red, yellow tube can be used, which is with the clot activator, और ये थोड़ी सी महंगी रहती है, तो red is commonly used. Red or yellow for the serum and the biochemistry parameters. Red tube means without anticoagulant it is used. Gate, so green, it is heparin bulb. Heparin bulb, it is immediate heparin, just wait. It is for immediate investigations, immediate biochemistry investigation, particularly for the ABG analysis. Okay. Purple tube, purple or lavender, it is for the cells, RBCs. It is HbA1c. And this is fluoride, sodium fluoride, potassium oxalate. It is for the glucose estimation. So this is a commonly asked question in the preparation of any entrance examination. Okay, so here answer is EDTA for HbA1c, glycated hemoglobin. Second important MCQ related with this is it tells about the average blood glucose level for preceding 6 to 8 weeks. See, next question, which vacuum is used for electrolyte estimation? यहाँ पे थोड़ा सा कैच है. यहाँ पे अगर blood है, so I will go with the green heparin tube if it is blood electrolyte estimation along with the ABG. If it is serum here, the answer is the yellow tube or the red tube. Answer is yellow or red tube. Remember, blood electrolyte मतलब immediately अगर ABG analysis के साथ में करना है, so it will be with the green. But here answer, most preferred answer is yellow if it is not mentioned whether it is blood or serum. Okay, it is most commonly done parameter along with the urea and creatinine. So yellow tube means with clot activator, or the red tube without anticoagulant. It is used for collection of the blood sample for the electrolyte estimation. Okay. तो यहाँ पे थोड़ा सा कैच है. मुझे एग्जैक्टली क्वेश्चन पता नहीं है. यहाँ पे ब्लड लिखा है, सीरम लिखा है, या कुछ भी नहीं लिखा है. बट इट see, match the following amino acid and their derivatives. So multiple options were there. So see here, histidine will give you histamine. Tryptophan, from tryptophan you will get NAD, NADP, melatonin, serotonin, and it is excreted in urine in the form of hydroxyindole acetic acid. Tyrosine you will get from the tyrosine and phenylalanine you will get epinephrine, norepinephrine, dopamine, that is catecholamines, and cysteine, gamma glutamyl cysteanyl glycine, that is glutathione. So multiple options were there. C, D, A, B. Hi Bright Moon, hi Snehajit. So आप लगा लो कौन सा क्या है तो. So ये जनरल यूजी का क्वेश्चन है, लेकिन हमको डेरिवेटिव अगर पता है तो we can solve easily. एंजाइम यूज्ड इन रिकॉम्बिनेंट डीएनए टेक्नोलॉजी. क्रिस्पर पे काफी सारे क्वेश्चंस आते हैं. मुझे लगा कि इस बार माइक्रो आरएनए पे क्वेश्चन आएगा, पता नहीं लेकिन आया कि नहीं. तो माइक्रो आरएनए, क्योंकि इस बार नोबेल प्राइज उस पे था, माइक्रो आरएनए जीन साइलेंसिंग पे. तो क्रिस्पर पे काफी फेवरेट रहा है पिछले 2 साल से क्रिस्पर. ओके, एंजाइम यूज्ड इन रिकॉम्बिनेंट डीएनए टेक्नोलॉजी. दिस वाज आल्सो मल्टीपल ऑप्शंस वेयर देयर, मतलब इसमें से काफी सारे ऑप्शंस करेक्ट है. सी, आइसोमरेज इट इज नॉट यूज्ड इन द रिकॉम्बिनेंट डीएनए टेक्नोलॉजी, इसका कोई रोल नहीं है. फॉस्फेटेज इट इज टू रिमूव द 5 प्राइम फॉस्फेट, डिफॉस्फोराइलेशन के लिए ये यूज करते. देन टर्मिनल ट्रांसफरेज, इसका रोल है 3 प्राइम एंड पे न्यूक्लियोटाइड अगर ऐड करना है, स्पेसिफिकली होमोपॉलीमर टेलिंग में टर्मिनल ट्रांसफरेज का यूज करते. और ब्लंट एंड को, जो हाइब्रिड जो मतलब प्लास्मिड का जो ब्लंट एंड है उसको स्टिकी एंड में कन्वर्ट करने के लिए इसका रोल है टर्मिनल ट्रांसफरेज. होमोपॉलीमर टेलिंग में इसको यूज करते हैं रिकॉम्बिनेंट डीएनए टेक्नोलॉजी में. ये तो नोन है. क्रिस्पर कैस9, क्लस्टर्ड रेगुलरली इंटरस्पेस शॉर्ट पैलिंड्रोमिक रिपीट, एंड क्रिस्पर एसोसिएटेड 9, that is the Cas9 enzyme. So this is RNA targeted, DNA directed nuclease. It is genome editing tool. इसके बारे में तो सबको पता है, तो ये यूज करते हैं recombinant DNA technology. So multiple options were there. So B, C, and D, all 3 are correct here. Okay. So phosphatase, terminal transferase, CRISPR-Cas9. Next question. In diabetic patient, high VLDL is due to which of the following? So इसमें थोड़ा सा वाइस वर्सा करके ऑप्शंस थे. दिस वाज द करेक्ट ऑप्शन. सी, there is insulin deficiency and there is increased glucagon and epinephrine, and glucagon and epinephrine will stimulate the hormone sensitive lipase, will increase the hormone sensitive lipase and increase the degradation of triacyl glycerol, and low LPL, lipoprotein lipase, which act on the VLDL. So it means there is low level of lipoprotein lipase. So here answer is high हार्मोन सेंसिटिव लाइपेज एंड लो लेवल्स ऑफ लाइपोप्रोटीन लाइपेज. लाइपोप्रोटीन लाइपेज का लेवल लो रहेगा तभी VLDL एक्यूमुलेट होगा. ओके, एंड हार्मोन सेंसिटिव लाइपेज का लेवल ज्यादा रहेगा तभी TG का डिग्रेडेशन होगा, एंड इट हेल्प्स इन द इनकॉर्पोरेशन ऑफ द लिपिड्स इनटू द VLDL. ओके, विच ऑफ द फॉलोइंग इज इसेंशियल फैटी एसिड? इसका ये क्वेश्चंस किसी को पता होगा तो इस पे इनपुट दो। हाय ब्राइट मून। एक्चुअली लिनोलिक एंड लिनोलेनिक बोथ आर इसेंशियल फैटी एसिड। मल्टीपल ऑप्शंस था या नहीं पता नहीं है। लिनोलिक, लिनोलेनिक और लिनोलिक दोनों ही इंपॉर्टेंट है। लिनोलिक is further converted into arachidonic acid, and linoleic is also important for the formation of prostaglandins, leukotrienes, lipoxins. इसके लिए important है। Linoleic acid is converted into icosapentaenoic acid and also DHA, docosahexaenoic acid. दोनों ही इसेंशियल फैटी एसिड्स है, लिनोलेनिक भी और लिनोलिक भी। अभी यहाँ पे अल्फा गैमा का थोड़ा सा रोल अगर पूछा तो पता नहीं, बट बी इज मोर देन ए। हाँ, क्योंकि ये आर्किडोनिक एसिड भी बनाता है और ये, लेकिन दोनों ही इसेंशियल फैटी एसिड है, लिनोलिक एसिड एंड लिनोलेनिक एसिड। ओके। ओमेगा 6 और ओमेगा 3 अगर पूछा है, सी ओमेगा 3 इट इज अल्फा लिनोलेनिक एसिड, लेनिक एसिड, and omega 6 it is linolic, arachidonic and gamma linolenic acid। तो आप देखो इसमें कौन सा आंसर आपका, कौन सा क्वेश्चन बैठता है। तो ओके, सो अल्फा लिनोलेनिक एसिड इज द ओमेगा 3 फैटी एसिड and these three are omega 6 fatty acid. It depends on the position of double bond. ओके, सो यहाँ पे आंसर तो दोनों ही है, डिपेंड करता है यहाँ पे ओमेगा 3 पूछा है कि ओमेगा 6 पूछा है, क्या पूछा है उस पर डिपेंड करता है आंसर। द नेक्स्ट क्वेश्चन इज, देयर वर क्वेश्चन ऑन सिकल सेल एनीमिया जो रंजित सर ने ऑलरेडी कवर्ड किया है, जिसमें पूछा था कि द आंसर वाज म्यूटेशन। इट इज द 6th पोजीशन ऑफ बीटा चेन, द ग्लूटामेट इज रिप्लेस्ड बाय द वैलिन, पार्शियली एक्सेप्टेबल मिससेंस पॉइंट म्यूटेशन। देयर वेर क्वेश्चन ऑन द नॉर्मल एनायन गैप मेटाबॉलिक एसिडोसिस, जिसका आंसर डायरिया है, ये शायद से संतोष सर कवर करेंगे। और अनुप्लाइडी पे एक क्वेश्चन था, दैट वाज आल्सो कवर्ड बाय द रंजीत सर। और इसके अलावा विटामिन B12 पे एक पार्शियल गैस्ट्रिक्टोमी मतलब सर्जरी रिलेटेड क्वेश्चन बायोकेम से रिलेटेड या इंटीग्रेटेड वे में आता है। सो दीज आर क्वेश्चंस related with biochemistry. Integrated questions were there and they were based on the practical approach. So thanks all of you for your valuable feedback. Over to you, Rishabh sir.
Thank you, sir. Thank you. That was a really good discussion. And as we see that lot of questions from biochemistry were previous year topics, standard question, urea cycle से question आना ही है, and
Yes, sir.
वैक्यूटेनर से हमारे टाइम पर भी आता था सर क्वेश्चन, एंड अभी तक कंटिन्यू हो रहा है,
सर
स्पेशली
वैक्यूटेनर पे हर एग्जाम में अभी रिपीट हो रहा है वैक्यूटेनर, मतलब वो अभी टॉप रेटेड टॉपिक हो गया है।
स्पेशली HbA1c वाला हमसे इंटर्नशिप में पूछे थे सर ये ना,
हाँ,
क्योंकि
द मेथड ऑफ एस्टिमेशन फॉर HbA1c, ये भी थोड़ा पॉपुलर क्वेश्चन है।
ओके, थैंक यू सर।
ओके सर।
ओवर टू यू ममता मैम, लेट्स सी द माइक्रोबायोलॉजी रिकॉल।
Hello, sir. Hi, everyone. This is Dr. Mamta. Let's start with the microbiology questions. तो microbiology तो काफी doable थी, touchwood. So we'll start, guys. पहला क्वेश्चन जो है वो मैच द फॉलोइंग पे है। द डिजीजेस वर टू बी मैच्ड विद द बैक्टीरिया। ठीक है, ओरोया फीवर, रैट बाइट फीवर, पेंटा एंड डोनोमोनोसिस। इफ यू फील एनी मिस्टेक इज देयर इन द क्वेश्चन, प्लीज करेक्ट मी। ठीक है, तो ये तो आसान है, ओरोया फीवर, बार्टोनेला, रैट बाइट फीवर। अच्छा, इसमें प्लीज लेट मी नो स्ट्रेप्टोकोकस क्वेश्चन में था या स्ट्रेप्टोबैसिलस था। रैट बाइट फीवर इज कॉज्ड बाय स्ट्रेप्टोबैसिलस मोनोलिफॉर्मिस एंड स्पाइरलम माइनस। इन दोनों में से कुछ था राइट वाले कॉलम में, तो प्लीज लेट मी नो। पेंटा बाय ट्रिपोनीमा कैरेशियम एंड डोनोमोनोसिस बाय क्लेप्शियला और कैलिमैटोबैक्टीरियम ग्रैनुलोमैटस। इज दिस क्वेश्चन फाइन? एनी करेक्शंस ओवर हियर? जब क्लेप्शियला, बार्टोनेला, ट्रिपोनीमा सीधे सीधे बैठ रहे हैं ना, तो फिर जो हमारे पास बच गया, अगर स्ट्रेप्टोकोकस मान लो दिया भी होगा तो हम उसको फिर मार्क करना पड़ेगा रैट बाइट फीवर के साथ। दैट्स व्हाई आई एम आस्किंग कि वो स्ट्रेप्टोकोकस देयर या फिर कुछ और था। एनीवन, एनी इनपुट्स ऑन दिस? प्लीज लेट मी नो। So if anyone is able to recall कि streptococcus था या क्या था, let me know please in the comments. Next question, which of the following causes croup? Haemophilus influenzae, influenza virus, streptococcus pneumoniae. Now ये तीन तो correct options हैं. कई students ने इसको recall किया है, but I'm doubtful about the option D. Please let me know, was diphtheria mentioned or para-influenza virus mentioned? क्योंकि ये डी ऑप्शन इन दोनों में से जो भी होगा उसके अनुसार हमारा फिर आंसर बदल जाएगा. अगर तो डिप्थीरिया था फोर्थ ऑप्शन, तो हम इन सारे ऑप्शंस में से इन्फ्लुएंजा मार्क करेंगे. ठीक है. क्रूप इज कॉज्ड बाय वायरसेस, मोस्ट कॉमनली बाय पैरा इन्फ्लुएंजा. फिर बाकी सारे बाद में आते हैं. आरएसवी भी कर सकता है इन्फ्लुएंजा वायरस एंड रेयरली एडिनो वायरस ऑल्सो. ठीक है. हिमोफिलस इन्फ्लुएंजा और स्ट्रेप निमोनिया तो है ही नहीं. ओके, योगी इज कमेंटिंग डिप्थीरिया, तो पैरा इन्फ्लुएंजा इसका मतलब नहीं था. Okay, no para-influenza. Anyone else has a different opinion? अगर पक्का डिप्थीरिया ही था तो हम सेफली ऑप्शन बी मार्क कर सकते हैं. ठीक है. So croup is nothing but laryngotracheobronchitis. चलो next question. All of the following are causes of urethritis in males except gonococcus. Yes, that is Neisseria gonorrhoeae. गार्डनेरेला बस स्पीशीज मेंशन नहीं था. आई मीन सिर्फ जीनस मेंशन था, बस स्पीशीज नहीं दे रखा था. ट्राइकोमोनास, क्लैमाइडिया. ट्राइकोमोनास भी कर सकता है, क्लैमाइडिया भी कर सकता है, नॉट गार्डनेरेला. आंसर यहाँ का बी है. थैंक यू श्रुति. तो चलो इसको हम लॉक करते हैं क्वेश्चन को. इसमें अब कोई गड़बड़ नहीं है. पहले वाले क्वेश्चन में, सेकंड क्वेश्चन में तो आंसर इन्फ्लुएंजा बनता है उसका. ठीक है. तो इस क्वेश्चन में आंसर इज गार्डनेरेला. गार्डनेरेला वजाइनालिस का नंबर आपको पता है किस कंडीशन में बढ़ जाता है? बैक्टीरियल वजाइनोसिस, जो अपने आप में काफी महत्वपूर्ण टॉपिक है. उस पे भी अलग अलग तरीके से क्वेश्चंस आए हैं. नीट पीजी में भी और एनआईसीटी में भी आता रहता है. सो ये भी आसान सा क्वेश्चन है गाइस. तो क्लैमाइडिया ट्रैकोमैटिस मोस्ट कॉमन कॉज, D2K सीरोवार्स आर द मोस्ट कॉमन कॉज ऑफ NGU, नॉन गोनोकोकल यूरेथ्राइटिस. ठीक है. तो नेक्स्ट क्वेश्चन, ड्रग ऑफ चॉइस फॉर फेशियल और हेपेटिका. ये आपका शायद फार्मा में भी डिस्कस होगा. आसान है. इसका आंसर क्या है? प्राजिक्वांटल. नाउ द अदर टू ऑप्शंस व्हिच आई गॉट, एल्बेंडाजोल, मेबेंडाजोल, जो कि गलत हैं. ऑप्शन डी पे कोई कमेंट करना चाहेगा तो प्लीज लेट मी नो. ये क्वेश्चन हमारा कंप्लीट हो जाएगा. इफ एनीवन कैन प्लीज रिकॉल द फोर्थ ऑप्शन. चलो नेक्स्ट क्वेश्चन, टेस्ट यूज्ड फॉर एंटीमाइक्रोबियल ससेप्टेबिलिटी टेस्टिंग. ओके, ट्राइक्लाबेंडाजोल. Anyone else has a different opinion? यही था क्या? टेस्ट यूज्ड फॉर एंटीमाइक्रोबियल ससेप्टेबिलिटी टेस्टिंग. कैम टेस्ट नहीं, ई टेस्ट यस, एलएक्सएल प्रेसिपिटेशन टेस्ट नहीं, लेटेक्स एग्लूटिनेशन टेस्ट नहीं. ठीक है. तो एलएक्सएल प्रेसिपिटेशन टेस्ट पे अलग से भी क्वेश्चंस आते हैं. इट्स अ टॉक्सिजेनिसिटी एसे फॉर मेकिंग अ डायग्नोसिस ऑफ डिप्थीरिया, जिसके लिए टॉक्सिजेनिसिटी एसेज आपको करने पड़ते हैं. कैम टेस्ट सबसे पहले किसने डिवाइस किया था? क्रिस्टी, एटकिंस, मंच, पीटरसन. 4 लोग नहीं है, 3 ही लोग हैं. जीबीएस या स्ट्रेप्टोकोकस एगेलेक्शे के संदर्भ में इसको डिस्कवर किया गया था. फिर बाद में रिवर्स कैम टेस्ट सी परफेंजेंस को लेकर आया. लेटेक्स एग्लूटिनेशन टेस्ट इज यूज्ड टू डिटेक्ट it's used for the diagnosis of a lot of infections. ठीक है, एंटीजन डिटेक्शन के लिए. ठीक है. तो हमारा आंसर क्या बनता है? ई टेस्ट और एप्सिलोमीटर टेस्ट, विच इज एन MIC बेस्ड टेस्ट. एक स्ट्रिप होती है, उस पे एंटीबायोटिक की ग्रेडियंट इज सेटअप. फिर अकॉर्डिंगली उसके बाद हम इसको टेस्ट करते हैं ग्लॉन कल्चर ऑफ द बैक्टीरिया पे. ठीक है. So this is used to test MIC. तो देखो ये भी आसान आया. नेक्स्ट क्वेश्चन, स्टेरिलाइजेशन मेथड यूज्ड फॉर इनोकुलेशन लूप इज autoclave, placing over heat 3 times, placing over heat until it becomes red hot, which by the way is the answer. Option D किसी को याद है? योगी, श्रुति, ब्राइट मून. if anyone can recall. So इनोकुलेशन लूप, बैक्टीरियोलॉजिकल लूप्स जो मेटल लूप्स यूज करते हैं, दे आर टू बी हीटेड टिल दे बिकम रेड हॉट. फिर उनको कूल करना होता है टू अवॉइड द हॉट लूप सिंड्रोम. एंड दिस मेथड कम्स अंडर द मेथड ऑफ क्या? Dry heat. Okay, microwave was the fourth option. Thank you, Himmat Singh. Everybody else, I hope यही था D option. कुछ और किसी को याद आ रहा हो तो बता दो. Next question. A gardener from Himachal Pradesh presented with painless ulceronodular lesions on the limbs. Axillary lymph nodes were found to be enlarged. Lymph node aspirate reveals structures as shown. What can be the cause? I have zoomed the picture. क्या लग रहा है guys ये? ये आप क्या देख पा रहे हो? दिस इज द मोल्ड फॉर्म और क्वेश्चन में ही आपको सारे हिंट्स दे रखे हैं. जब मैं हमेशा बोलती हूँ जब क्लिनिकल वेरिएंट आता है ना तो अच्छी बात है क्योंकि क्वेश्चन में इतने हिंट्स दे रखे होते हैं. तो गार्डनर है, एचपी से हेल करता है and that is the region where Sporothrix shenkai, which is a dimorphic fungus, is prevalent, and this is the only dimorphic fungi, thermally dimorphic fungi amongst the 6 थर्मली डायमॉर्फिक फंगाई जो हमारे को पढ़ने होते हैं, जो कि क्या करता है सबक्यूटेनियस माइकोसिस. बाकी 5 क्या करते हैं सिस्टेमिक माइकोसिस. ठीक है. पेनलेस अल्सरोनोडुलर लीजन्स ऑन द लिम्स. And what is this reflective of this picture? This shows the mold form of this fungus which is encountered at the room temperature. ठीक है. तो the conidia are arranged. इस अरेंजमेंट को क्या बोलते हो? रोजेट अरेंजमेंट. Rosette arrangement, or this is nothing but lymphocutaneous sporotrichosis, the most common type, clinical type of sporotrichosis. So ulcers are seen in series or rows. That is the typical description of the disease of the clinical presentation. तो सेकंड ऑप्शन यहाँ पे कॉक्सीडियोइड्स था जो नहीं बन रहा बिल्कुल भी. सी और डी अगर ऑप्शंस किसी को याद आए तो प्लीज लेट मी नो. Then next question, gram-positive cocci in chains causing necrotizing fasciitis are. ये भी आसान है. Staphylococci, streptococci, enterococci. Now please let me know guys, यहाँ पे जो second option है streptococcus अकेले mention था या फिर they mentioned streptococcus pyogenes. Irrespective आंसर हमारा ऑप्शन बी ही बनता है. अगर streptococcus pyogenes था तो वो बिल्कुल सही बैठता है इस क्वेश्चन में. Anyone if can please recall the fourth option, I will be very thankful. हमारा क्वेश्चन कंप्लीट हो जाएगा. एंड ऑल्सो वेदर स्ट्रेप्ट पायोजीन्स पूरा मेंशन था या सिर्फ स्ट्रेप्टोकोकस ही वर्ड मेंशन था. ओके, किसी को याद आए तो प्लीज लेट मी नो. नेक्स्ट क्वेश्चन. नाउ इस क्वेश्चन में आई वुड नीड हेल्प. आई होप ये इसी तरह से आया हो. Which of the following statements is false regarding Escherichiasis? Okay, thank you हिम्मत सिंह. तो इसका मतलब स्ट्रेट पायोजीन्स था. So this was mentioned. पूरा नाम था. Thank you. Which of the following statements is false regarding Escherichiasis? Most infections are asymptomatic. ये सही statement है, false नहीं है. तो ये हमारा आंसर नहीं है. Unembryonated eggs are shed in the feces which need time to become embryonated and infective. तो ये I discuss in the classes also कि जो freshly passed eggs होते हैं ना एक patient के जो कि suffer कर रहा है from this बीमारी Escherichiasis, the freshly passed out eggs are not infective. They have to undergo development in the soil. ठीक है. Only after they undergo development in the soil they become competent enough to cause infection in somebody else. तो ये भी सही है. अब I think यहाँ पे number of worms probably mention था third option. So and so many worms can cause rectal prolapse. चाहे जो भी नंबर उनको देना हो देने दो. Rectal prolapse आ गया ना, लेकिन Ascaris क्या है? Ascaris lumbricoides is an example of a small intestinal nematode. तो ये तो वैसे भी गलत है. Spread to lungs can cause asthma-like features. ये भी सही है. तो इसके हिसाब से अगर तो यही था, यही सारी स्टेटमेंट्स थी जो मैंने लिखी है यहाँ पर. हमारा आंसर क्या बनता है? ऑप्शन सी. Is this clear everyone? Any inputs on this question? Are these 4 options correct? क्वेश्चन भी ऐसे ही था या कोई हिस्ट्री दे रखी थी? प्लीज लेट मी नो. चलो नेक्स्ट क्वेश्चन. A farmer presented with swelling of the foot with ulcers. The likely disease is seen in individuals who walk barefoot. इसी पर ये पूरी स्टेटमेंट ऐसे दे रखी थी. What is the likely disease? अब देखो फार्मर मेंशन कर रखा है, swelling of the foot with ulcers भी बता रखा है, disease occurring on walking barefoot. What more do we want to arrive at the right answer? Answer is mycetoma. बाकी 3 ऑप्शन अगर किसी को याद आ रहे हैं तो प्लीज हेल्प मी आउट. Sorry, I'm talking a little softly क्योंकि मेरा गला काफी बैठा हुआ है. Any other option which you can recall? B, C, D? Okay, हिम्मत सिंह, आप पहले वाले क्वेश्चन की बात कर रहे हो. Rectal prolapse in children. Was this mentioned? यही statement थी. Number of worms था mentioned या नहीं था? This was mentioned. This is what you're saying. ओके गाइस, ये 10th क्वेश्चन में अगर किसी को याद आता है ऑप्शन प्लीज मुझे बताना. हम आगे बढ़ते हैं अब. अगला क्वेश्चन. ओके ओके वेट. Actinomycetes infection. Himmat Singh, you're talking about this question only. Yogi, you're saying no to what? Any correction you would like to do in the question? Ascaris वाले में या इसमें? Let me know. Okay guys, अगला question. A patient presented with pain abdomen. USG abdomen showed a cystic lesion in the liver. What can be the likely cause? I hope these were the options which you got. Echinococcus granulosus, Fasciola hepatica, Tinea solium, Tinea saginata. ठीक है, तो सीधा सीधा आंसर इसका क्या बन रहा है? और कुछ था बाय द वे क्वेश्चन में मेंशन? आई थिंक द हिस्ट्री अकॉर्डिंग टू मी इट्स अ लिटिल इनकम्प्लीट क्वेश्चन. Are these options correct? And the question is complete as far as the history is concerned. तो चलो यहाँ हमारा आंसर क्या बनेगा? एकाइनोकोकस ग्रैनुलोसस. पैरासाइटोलॉजी में हमेशा बोलती हूँ काफी स्कोरिंग है, ठीक है, और देखने में थोड़ी डरावनी जरूर लगती है, लेकिन ज्यादा मुश्किल नहीं है. इनफैक्ट बिल्कुल भी मुश्किल नहीं है. और पैरासाइट से वो घुमा फिरा के वही सेम क्वेश्चंस पूछेंगे. आपकी थ्योरी कंसोलिडेटेड है तो आप सारे क्वेश्चंस निकाल लोगे. हिम्मत सिंह, यूर टॉकिंग अबाउट कौन सा क्वेश्चन? एचनाना वाला? Are you talking about this question only which is there on the screen right now? 11वां question. Anybody else with any inputs on this question? And if anyone can recall about H nana, must be, I think you are talking about probably about the options क्योंकि H nana का अलग से question तो मैंने नहीं सुना आज. Okay. USG guided aspiration इस प्रकार की भाषा लिख रखी थी. Okay, okay. ऑप्शन में था एंड स्लाइड थी. आई डिडंट गेट. तो आप ये कह रहे हो कि एक इनमें से एक ऑप्शन था एच नाना. ओके, तो जो ऑप्शन नहीं था प्लीज ट्राई टू रिकॉल. आई विल डिलीट दैट. In the meantime, let's proceed with the next question. A 2-year-old child presented with a 2 days history of diarrhea and severe dehydration. What can be the likely cause? 2 साल का बच्चा है, डायरिया की हिस्ट्री है, तो amongst the options क्या मार्क करोगे आप? रोटावायरस, शिगेला डिसेंट्री, एस्कैरिस, एस्चेरिशिया कोलाई. आपको क्या मार्क करना है? रोटावायरस, द मोस्ट कॉमन कॉज ऑफ इन्फेंटाइल डायरिया एंड ऑल्सो डायरिया इन किड्स लेस देन 3 years of age. Okay, what image Himmat Singh was given? तो कमिंग बैक टू क्वेश्चन 12, यहाँ पे आंसर क्या है? रोटा वायरस. अब शिगेला डिसेंट्री तो क्या करेगा? डिसेंट्री करेगा, ठीक है. द ओनली स्पीशीज ऑफ शिगेला विच कैन कॉज डायरिया, मतलब माइल्डेस्ट फॉर्म ऑफ शिगेलोसिस इज शिगेला सोनी, विच कैन at times cause just diarrhea and not dysentery. एस्कैरिस डायरिया नहीं करेगा तो बहुत माइल्ड करेगा। और इस एज ग्रुप में हम क्या मार्क करेंगे? रोटा वायरस। इकोलाई भी आंसर नहीं है, बट डू नो दैट EPEC एंट्रोपैथोजेनिक इकोलाई जो है दैट ऑल्सो इज एन इम्पॉर्टेंट बट नॉट द मोस्ट कॉमन इंपॉर्टेंट कॉज ऑफ डायरिया इन इन्फेंट्स। ठीक है, तो यहाँ पे सीधा सीधा आंसर क्या बनता है? रोटा वायरस। आगे बढ़ते हैं। विच ऑफ द फॉलोइंग डज नॉट इम्पार्ट पैसिव इम्यूनिटी? IgE एंटीबॉडी, टॉक्सॉइड, एंटीटॉक्सिन, मोनोक्लोनल एंटीबॉडी। तो यहाँ पे सीधा सीधा आंसर क्या है? टॉक्सॉइड। टॉक्सॉइड इज नथिंग बट अ काइंड ऑफ वैक्सीन। तो आप किसी को ये एडमिनिस्टर करोगे तो इम्यून सिस्टम बनाएगा एंटीबॉडीज। ठीक है, सो टॉक्सॉइड इज नॉट एन एग्जाम्पल ऑफ पैसिव इम्यूनिटी। रेस्ट ऑफ द थ्री ऑप्शंस आर। एंटीटॉक्सिन क्या है? इट इज नथिंग बट द एंटीबॉडी अगेंस्ट द टॉक्सिन। सो इसको सबसे अच्छा समझने का उदाहरण है डिप्थीरिया। मेनस्टे ऑफ ट्रीटमेंट ऑफ डिप्थीरिया क्या है? जहाँ पे विलन या कल्प्रिट क्या है? टॉक्सिन होता है। तो उसी जो इमीडिएट प्रॉब्लम है, जो बीमारी है, उसको काउंटर करने के लिए आप क्या दोगे? टॉक्सॉइड या एंटीटॉक्सिन? एंटीटॉक्सिन। यू माइट स्टार्ट टॉक्सॉइड डिपेंडिंग ऑन द वैक्सीनेशन स्टेटस ऑफ द पेशेंट, बट टॉक्सॉइड इमीडिएटली प्रॉब्लम को केटर नहीं करेगा। रिमेंबर दिस। आगे बढ़ते हैं। कोल्ड स्टेरिलाइजेशन मेथड्स आर ऑल एक्सेप्ट UV रेस, ऑटोक्लेव, गामा रेस, प्लाज्मा स्टेरिलाइजेशन। ऑटोक्लेव तो भाई क्या है? ऑटोक्लेव इज अ मेथड ऑफ स्टेरिलाइजेशन बाय मॉइस्ट हीट। सबसे पहले CDC ने ये बात बोली, सेंटर्स फॉर डिजीज कंट्रोल एंड प्रिवेंशन ने, कि जो गामा रेस है ना, गामा रेस के संदर्भ में दे यूज द टर्म कोल्ड स्टेरिलाइजेशन बिकॉज देयर इज नॉट एन अप्रिशिएबल इंक्रीज इन टेम्परेचर। लेकिन अगर आप अनंत नारायण पानीकर देखोगे, उसका टेक्स्ट क्या कहता है, और बाय द वे मैं उससे सहमत हूँ, नॉट CDC, बट हमें CDC की बात माननी पड़ेगी। अकॉर्डिंग टू द इंडियन स्टैंडर्ड टेक्स्ट बुक अनंत नारायण पानीकर, कोई भी मेथड में अगर आप हीट को छोड़कर जितने भी आपके स्टेरिलाइजेशन डिसइंफेक्शन के मेथड्स हैं, क्योंकि उनमें बहुत हाई टेम्परेचर यूज नहीं कर रहे हो, कुछ में तो बिल्कुल भी हाई टेम्परेचर नहीं है, सबके सब कैन बी ब्रैकेटेड अंडर द मेथड्स ऑफ कोल्ड स्टेरिलाइजेशन। ठीक है, ये एज इट इज चीज अनंत नारायण में लिख रखी है, और ये बहुत सीधा साधा क्वेश्चन है। यहाँ पे हम ऑटोक्लेव ही मार्क करेंगे। ठीक है, okay, guys, I'll just go back to the previous question. I'm getting some input. Let us complete that question. रित्रा, you're talking about कौन सा? इसी वाला 11th क्वेश्चन की आप बात कर रहे हो? On aspiration, head with rostrum. What about the rest of you? Let me know, guys. कि कई बार पेपर दे के आता है ना, तो बहुत सारे चीजें दिमाग में घूम रही होती हैं। I want to recall the questions. I want the questions to be correctly recalled. ठीक है, तो एक बार जरा और लोग भी जरा याद करके इस पे इनपुट्स दो, फिर हम इस पे थोड़ी देर में आते हैं। चलो, in the meantime, let's continue. Culture medium for Mycobacterium tuberculosis, Lowenstein Jensen medium, STA. Answer तो LJ medium है. Please help me with options C and D. LJ medium पे रफ टफ बफ कॉलोनीज मिलेंगी Mycobacterium tuberculosis की. You should know the selective media for all the bacteria. जो भी क्लिनिकली हम सस्पेक्ट कर रहे होते हैं कि पेशेंट को शायद ये वाला इन्फेक्शन है, अकॉर्डिंगली एक डिसीजन लिया जाता है कि चलो फिर ये मीडिया यूज करो. Apart from, of course, using the routine media like blood agar में कौन किया अगार. Any inputs on this question, the two options? Okay, next question. Which of the following viruses is waterborne? HAV, HBV, HCV, HDV. सीधा सीधा आंसर क्या है? HAV, which is transmitted by fecal-oral route. गंदा पानी पी के या फिर intake of consumption of shellfish. HAV and HEV, ये जो तो हेपेटाइटिस वायरसेस हैं, दे आर ट्रांसमिटेड बाय फीको-ओरल रूट. तो ऑब्वियसली इससे ये भी याद कर सकते हो आप कि इनके पास एनवेलप नहीं होता है, क्योंकि जो गट में GIT में जो बाइल सॉल्ट्स हैं, वो एनवेलप्ड वायरसेस को तो सर्वाइव ही नहीं करने देंगे, बिकॉज एनवेलप इज नथिंग बट फोस्फोलिपिड बाइलेयर. तो कोई भी वायरस है विच इज ट्रांसमिटेड बाय फीको-ओरल रूट या फिर जो डायरिया कॉज करता है, बाय डिफॉल्ट वो क्या होगा? नॉन एनवेलप्ड होगा. लेकिन दो इंपॉर्टेंट एक्सेप्शंस यहाँ पे आती हैं. एक तो CMV, जो कि सबसे बड़ा हर्पीस वायरस है, लेकिन उसके पास एनवेलप है. वो क्या करता है? CMV कोलाइटिस एड्स पेशेंट्स में. दूसरा क्या है? कोरोना वायरस. सो रिमेंबर दिस. Next question. A farmer presented with the history of blunt trauma to the chest. Microscopy of the sample showed mildly acid fast bacteria with branching, which of the following can be the likely cause? अब देखो, let me also tell you कि यहाँ पे आई एम डाउटफुल कि एसिड फास्ट पक्का था या फिर माइल्डली ऐसे ग्राम पॉजिटिव लिख रखा था. प्लीज ट्राई टू रिकॉल दिस. ऑप्शंस ये दो तो पक्का थे, नोकार्डिया, लिस्टीरिया, एंड प्लीज हेल्प मी आउट विद द ऑप्शंस आल्सो. एनीवन? हिम्मत सिंह, अरित्रा, योगी, श्रुति. आंसर इसका वैसे नोकार्डिया है. Was mildly gram positive mentioned in addition to mentioning कि acid fast था या फिर acid fast दिया ही नहीं था? Try to recall this, guys, please. So branching filamentous bacteria, I think filamentous term probably was mentioned. I'm not sure. Filamentous rod ऐसे कुछ था mentioned in the question. Okay, Bacillus anthracis was one of the options. Thank you, Kush. Okay, Kabir Kane is mentioning mildly acid fast. ओके चलो, ये तो पक्का था हमारा आंसर. तो फिर उस हिसाब से ऑब्वियसली नोकार्डिया है, क्लियर कट आंसर है. ऑप्शन डी किसी को याद आ रहा है? वॉज फिलामेंटस रॉड, ये दो वर्ड थे मेंशन्ड क्वेश्चन में. ओके कुश इज, आई थिंक कुश यू आर सेइंग नो टू द प्रेजेंस ऑफ ग्राम पॉजिटिव बैक्टीरिया इन द क्वेश्चन. ये शब्द नहीं थे. ओके वीकली एसिड फास्ट, माइल्डली नहीं वीकली. ठीक है, थैंक यू गाइस. ऑप्शन डी किसी को याद आ रहा है? तो फिलामेंटस रॉड पूरी बैक्टीरियोलॉजी में दो ही हमें जो पढ़ने होते हैं, नोकार्डिया और एक्टिनोमाइसिस. नोकार्डिया एसिड फास्ट है, पार्शियली एसिड फास्ट 1% H2SO4 तुम यूज करते हो सस्पेक्टिंग इन्फेक्शन बाय इट. लेकिन एक्टिनोमाइसिस एसिड फास्ट नहीं है, दोनों के दोनों ग्राम पॉजिटिव हैं. ये नोकार्डिया एरोबिक है और एक्टिनोमाइसिस एनएरोबिक है. तो ये एक्सपेक्टेड क्वेश्चन है. आई एम नॉट सरप्राइज कि ये अभी तक जितने भी क्वेश्चन हैं सारे के सारे डूएबल हैं. ठीक है, कुछ ऐसा नया टचवुड बाउंसर नहीं आया है. नाउ नेक्स्ट क्वेश्चन एंड लास्ट क्वेश्चन which I could get. A 2-year-old child with history of diarrhea presented with fever, thrombocytopenia, hematuria. Which of the following can be the likely cause? E. coli, O157H7, Salmonella, Shigella, Yersinia. सीधा सीधा क्या बन रहा है भाई आंसर इसका? This is nothing but enterohemorrhagic E. coli. ठीक है, serotype O157H7. तो बच्चा कमिंग विद हिस्ट्री ऑफ डायरिया एंड बुखार, थ्रोम्बोसाइटोपिनिया, हीमोचूरिया. तो EHEC you know is notorious for causing what? Hemorrhagic colitis, hemolytic uremic syndrome, which is characterized by the triad of माइक्रोएंजियोपैथिक हेमोलिटिक एनीमिया, थ्रोम्बोसाइटोपिनिया एंड रीनल फेलियर. तो यही फीचर्स क्वेश्चन में मेंशन है. ठीक है, तो आपको क्या मार्क करना है इसमें? बिल्कुल सीधा अच्छा क्वेश्चन, E. coli O157H7. So these are the questions which I could get. If you have any other inputs, कुछ आपको याद आता है to help me complete the questions, please connect with me. You can mention in the comments or you can DM me on Instagram mj.micro. Thank you everyone. Okay.
Thank you, ma'am. I think microbiology this time was very straightforward, very pet topics, previous year topics, favorite with INICET.
बिल्कुल. Thank you, sir.
We'll move on to forensic medicine now. Thank you, ma'am. Over to you, Manjunath, sir.
Yes, sir. Thank you. Am I audible, sir?
Yes,
Am I
sir.
audible, sir?
Yes, sir.
Yes. Hi, hello, everyone. So welcome to discussion of FMT questions. I think there were 4 or 5 questions asked from forensic medicine, especially from toxicology. Okay, let's start with the first question. The first question is about poisoning. That is, a college student came with a history of unknown substance. Unknown substance. Presents with pulmonary edema, hypotension, abdominal pain, silver nitrate test on breath gives black color. Which of the following used in treatment? Options are atropine, BAL, that is option B, magnesium sulfate, that is option C, Prussian blue, that is option D. Yes, anyone can answer this question? Anyone? Kush, Kabir Ken, Mukherjee, can you just correct me about the question and the options? Okay. So here the clue is silver nitrate test. Okay. Silver nitrate test. The silver nitrate test gives black color that go in favor of alphos poisoning. Okay. Alphos poisoning, also known as cell-phos poisoning. So the best answer is, that is magnesium sulfate. So the answer is magnesium sulfate. So that prevent organ toxicity. Atropine is not the answer. So atropine is given in OP poison. As you know, it's a drug of choice. The ball is a drug of choice in arsenic poison. The Prussian blue. The Prussian blue is used in, anybody can answer? The Prussian blue is used in, that is thallium poison. Okay. So the answer is C, magnesium sulfate. So this is exact line from PW MedEd 2.0 recordings. You can see there the phosphorus, yellow phosphorus and red phosphorus, aluminum phosphate, very commonly asked question in any exam. Okay. Yes. Fine. Parth Acharya, Dr. Okay. Fine. So just remember, alphos is a grain preservative. You can see here cell-phos or alphos, which is a well-known grain preservative. You can remember clinical feature with the mnemonic alphos only. We discussed many times in our classes. A for abdominal pain, L for lung failure, pulmonary edema, hypertension, oliguria, seizures. The treatment is magnesium sulfate. The fatal dosage is 150 to 500 milligram. Yes. Next question. The next question from bomb blast injuries, that is air blast injuries. One very frequently asked question in exam. Marshall triad is a triad of punctate bruise, punctate abrasion, and punctate laceration, which is seen in which type of explosion injuries? Options are primary, secondary, tertiary, quaternary. Can anyone answer this question? Anyone can answer this question? Marshall triad. The primary, remember, primary is because of the blast wave. The blast wave commonly affects lung, your tympanic membrane, and your intestine. So A is not the answer. Quaternary, because of the structural damage, like example, burn injuries, electrocution injuries, all this comes under quaternary. Tertiary, because of the victim displacement characterized by head injuries or amputation of the limbs in case of bomb blast. So it is not C also. What is the best answer? The best answer is secondary. The secondary is the best answer. The most common and the most fatal type of air blast injury is secondary. So it is also from exact lines from PW 2.0. And also, interestingly, this was discussed in PW reels, 1 minute reels. Primary blast injuries, secondary blast injuries, tertiary blast injuries, quaternary blast injuries in one of the reel of the PW. Yes, fine. Yes, any correction in the question? Parth and others? The question number 3, match the following type. Match the following with the poisoning and the antidote. Alcohol dependence. So alcohol dependence, One very commonly asked question. So what is used in alcohol dependence? Acamprosate. Acamprosate. Right? A2 that is. Benzodiazepine. Flumazenil. That is B1. Smoking, that is varenicline, that is C4. And D, that is 3. So the answer is A is the correct answer. So this is one frequently asked question from toxicology. Yes, fine. Yes, Dr. Parth and others. Good. Fine. And the last question in forensic medicine. This powder is used in treatment of which of the poisoning? The image of the powder was given in the exam, which was blue in color. So anybody can identify this substance, which is also known as blue vitriol? Blue vitriol. Yes, doctor. So this is your copper sulfate. Right? Copper sulfate. So the copper sulfate is used in. So options are arsenic trioxide, lead carbonate, mercury, and phosphorus. See, in arsenic trioxide, we use BAL, not the copper sulfate. Lead carbonate also we use penicillamine, BAL, and many other drugs. Mercury, penicillamine is used. DMSA, DMPA is used. The answer is phosphorus poisoning. Nowadays, it is not used. It is the question taken from old edition of the textbook. Probably copper sulfate used in treatment of phosphorus poisoning. So this is about the forensic questions. Around 4 to 5 questions asked from forensic medicine and toxicology. All 4 from PW MedEd 2.2 recordings. Strike rate is 100%. Thank you.
Thank you, sir, for that quick FMT recall. Again, as INICET, it is favorite for them to ask toxicology and predominantly base their questions in FMT in toxicology. And as a general trend this year, INICET had less questions from all minor subjects.
Exactly.
So now we'll move on to PSM discussion by Murugan sir. Over to you, sir.
Thank you, Dr. Rishabh. Am I audible?
Yes, sir, you're audible.
Fine. So as such, PSM, we got questions around 11, 12 questions. Okay, some amount of overlapping was there with other subjects. Okay, we will discuss the questions here. This is straight question. Okay, from community medicine. Okay, what is the best study method for hierarchy of study? Okay, so out of these various study designs available, okay, which one is the best study? Okay, so this one is straightforward. Okay, we have discussed in our sessions also, and it's very common question only. Okay, so anyone can answer it. Okay, the best study is that. Okay, the first study, best study here is meta-analysis, guys. Okay, meta-analysis. Fine. So this is the hierarchy. Okay, first we'll have this meta-analysis. Then we have this systematic reviews will be there. Third, we will go into RCT. Okay, after that, we have this cohort study, case control study. These studies will come. So first, the answer for the first question is that it is meta-analysis, guys. Okay, among all the study, that is the best study. Okay, fine. We have discussed elaborately in our sessions also. Fine. Next. This is not randomization. Okay, probably this is RCT. What are the steps in RCT? Okay, fine. RCT. What are the steps here? RCT is the first step. It's a experimental study. Okay, yes. Okay, what you are going to do? Experimental study. Okay, suppose I have a new drug for hypertension. I want to find I want to do RCT. So what I will do? I will select hypertensives first. That is the first step. Population. From the population, what I will do? The next step is that I will select a sample. Okay, when I'm selecting sample, I will use this exclusion and inclusion criteria I will do. Okay, this is the first step. Okay, fine. exclusion criteria. Based on inclusion exclusion criteria, I will select a sample. After that, what we will do? I will do randomization. So randomization is the second step. Fine. Once I have done randomization, I will divide them into two groups, group 1 and group 2. Okay. So if I want to do blinding, okay, I have to do it here. Okay. Yes, that is the third step, blinding. That what is blinding? Okay. They are not aware. Okay. They belong to which group? Treatment group or in control group. Okay. That is blinding. That I am going to do it here. That is the third step. Then what is the last step? Once I have blinded, I'm going to give the drugs to them. And after some time, I'm going to do the analysis. This is the order, guys. This is the order which we are going to do. Okay. So first step is I have given the order itself. I have given. Okay. So first step is that select a population from that sample. At the time, we'll use this inclusion exclusion criteria. Then do randomization, blinding. Then go for analysis, guys. Fine. Next. What is the answer for this question, guys? Okay, fine. Malaria screening at a community level. Okay, probably the terminology was field level was given. Field level. What is the options? Can anyone tell me what is the options here? Okay, what is the options? Okay, what is the options here? Malarial screening at field level. You can do two types of things. Okay, one, you can do peripheral smear. This is peripheral smear. You can do. Fine. Second, you can do rapid diagnostic test. You can do. But for the peripheral smear, what you require is that you have to take slide, thin and thick smear. You have to send it to lab. It will take time, guys. Especially at areas where falciparum is very common. Okay. So it will take time. And usually in those areas, hilly and tribal areas. Okay. So government has given this RDT. They have given rapid diagnostic test kit. It will identify the circulating antigens. It will identify. Probably that was the option. Identify circulating antigens. If the question correctly says, at the field level, then rapid diagnostic test is the answer. Because thick smear, thin smear, we can take slide, but it has to go to lab. Okay, so this immediately you will get within 15 minutes, you will get results. This is especially important in the case of falciparum. Okay, so if there is any other, okay, that is histidine-rich protein was the option. That is fine. Histidine-rich protein. Okay, rapid diagnostic test is based on the concept of histidine-rich protein. Okay, HRP2. That is correct only. That is the option. Okay, then that is the answer. HRP2. Fine. It will give the results. Fine. It will give the results quickly, guys. Fine. Next. Which of the following is not used in uncomplicated malaria? You take either falciparum malaria or Vivax. Okay, fine. So in question is uncomplicated malaria. Okay, this is according to National Drug Policy, guys. National Drug Policy. Yes. Are you going to give chloroquine? Definitely you are going to give chloroquine. Are you going to give primaquine? Yes, you are going to give, because it is only it prevents relapse. Okay, fine. So pyrimethamine sulfadoxine, yes, this comes in ACT. It is given in falciparum. That is also okay. But when will you give this artemether? Artemether and lumefantrine, usually we will give in falciparum case in northeastern states. Okay, so better answer here is artemether and lumefantrine, guys. Okay, better answer here. Artemether and lumefantrine. Okay, this is not given as such. It is not given in other parts of India. Especially this is given in the northeastern states. It is given in the northeastern states for falciparum. So this is the answer, guys. Okay, fine. Hope these options are correct. And this is the answer. Artemether plus lumefantrine, guys. Lumefantrine, fine. Yes. Pyrimethamine sulfadoxine, that is part of ACT we are providing. Artemether, okay. Artesunate, sulfadoxine, pyrimethamine, and primaquine we are giving. Fine. Fifth one. family members of diagnosed hypertension, diabetes or screened for diseases. What type of screening is this? Okay, we are having this mass screening, high risk or selective screening is there, or multiphasic screening is there. I don't know what is the fourth option. Okay, if you know the option, just let me know. Mass screening means what? You are going to screen everyone, guys. Everyone. Multiphasic screening means you are going to use multiple tests to screen. Okay, multiple tests like master health checkup we are going to do. Okay, this is the best possible answer what you get. Okay, that is selective screening because these are family members of the patient. That means the patient is already having diabetes and hypertensive. Okay, this is selective screening. Okay, this is the right answer. Okay, if you have any other option, just let me know. Otherwise, this is the answer, guys. Selective screening. This is the answer because the patient is already known diabetic and hypertensive. Their family members are being screened. Okay, mass screening, we don't do it. Multiphasic screen, that is not going to be much useful, guys. Master health checkup, not much useful. Fine. Which is not a live vaccine, guys. Okay, this is probably discussed in other subjects also. Okay, fine. In our program, okay, national immunization schedule. Okay, yes. Everyone are coming to visit. I'm not understanding it, guys. Sai Ganesh. Fine. So measles, what is measles? Measles is a live vaccine. Rotavirus is a live vaccine. Varicella, this comes with 𝐒𝐿 strain. Yes, mass screening is everyone is coming for checking. So that is not the answer. Okay. So the family members are doing it means it is the screening. Okay, mass screening was everyone are coming for checking. So that is not the question what was given to us is the other way around. Anyway, fine. Now, so which is not a live vaccine here. So measles is a live vaccine. Rotavirus is a live vaccine. Varicella is also a live vaccine. What is this hepatitis B vaccine? Okay, I think in last session only it was asked. Okay, what is the hepatitis B? Okay, it was recombinant beta subunit vaccine. Okay, recombinant beta subunit vaccine. Fine. Recombinant beta subunit vaccine. Fine. These are based on recall only, guys. Okay, based on students. Okay, it may be okay, little here and there, maybe some changes may be there. Okay, final version anyway, we'll upload it later. Now, so BCG, these are the list. Okay, we already discussed. Live vaccines are there. Fine. This again, it was already discussed. Mamta madam has discussed. A 2-year-old child with severe dehydration, most common agent. Okay, we discussed in probably in IMNCA guidelines, guys. Okay, IMNCA guidelines. Okay, most common one is rotavirus. Most common cause, any diarrhea in children is mostly due to rotavirus. And what is our job in IMNCA guidelines? So we have to rule out dehydration, and we will use yes. Okay, we will use various test we will do. General condition you will assess. You look for sunken eyes, the skin pinch test you will do. So that is rotavirus, because based on that context only, the IMNCA guideline says, okay, if blood is there, then it becomes what? Dysentery. If no blood, we consider its diarrhea is rota, and we will start for looking for dehydration. We will do. Fine. Anemia Mukt Bharat. Okay, this is a regularly asked question. Okay, how many beneficiaries are there? Okay, which is not correct? Question is which is not correct. What is the answer here, guys? Which is not correct? Okay, we have 6 beneficiaries are there. 0 to 6 years children are there. Okay, 0 to 5 years. Okay, 5 to 9 years. 5 to 9 years you will have. 10 to 19 years you will have. Pregnant women, lactating mothers you will have. Okay, women in reproductive age group you will have. Okay, 6 institutional mechanisms. Okay, 6 interventions you will do. So one such intervention is that you will provide IFA tablets. IFA tablets you will provide. Other intervention, for example, is deworming, guys. Deworming. So it uses this 6 into 6 into 6 matrix. Okay, so what is not here is 6 health functionaries, guys. Okay, that is not part of this. 6 health functionaries, that is not part of this one. Fine. Next. Which of the following is not included in SAM child? Okay, the mid-arm circumference, it was given in the option less than 11.5 centimeter. Edema was there. Is it height for age or weight for height? Weight for height should be less than, okay, less than 3 standard deviation, guys. 3 standard deviation. Severe acute malnutrition. Height for age is not part of SAM child. It indicates chronic malnutrition, guys. It indicates chronic malnutrition, which we have discussed in the class. So if you are seeing a case of SAM child, what you are supposed to do? You can refer the child to this nutritional rehabilitation centers. Okay, fine. Answering nice. Okay, nutritional rehabilitation centers, guys. Fine. Next. What is this question, guys? Okay, what is this question? What is universal health coverage? Okay, what is this universal health coverage? Okay, you can tell me the options. Otherwise, what is universal health coverage? I will let you know. This is based on SDGs, guys, Sustainable Development Goals. Okay, we are having a target under Sustainable Development Goals. Okay, we are having a target of universal health coverage. Okay, universal health coverage. So UHC only targets primary healthcare services. Since this is the, I don't think this was the correct answer. Okay, so provide free services to all point of care. This is also wrong. I don't know what is the other options. Okay, it was a statement. Probably if you can do it here. Okay, so we can add it to this. Okay, but what is universal health coverage? Universal health coverage means all the people has full access to quality of health services they need when and where they need them without financial hardship. Okay, the quality of health services when and where they need without financial hardship. It doesn't mean no free services. Okay, no free treatment. Okay, they can also pay, okay, because country cannot survive, okay, if you provide free treatment for everyone. Okay, but the services should be provided in such a way that it should not be a burden for the people. Fine. It is tracked by 2 indicators. One is that how much is the coverage of essential services and how much catastrophic health spending was done. Okay, this is the progress. Progress is measured in terms of this. Okay, so SDG, Sustainable Development Goals, this is the 3rd indicator. This is the 3rd indicator, 3rd goal, and we have these indicators we have. Okay, fine, for the target. Next. What is the analysis which use ICER as a mode is? Which one? Can you tell me? This is also probably a new question. The analysis which use ICER. What is ICER? Answer is cost effectiveness, guys. Cost effectiveness. What is ICER is incremental cost effectiveness ratio, guys. It is incremental cost effectiveness ratio. Suppose I have 2 treatment available. Okay, I am comparing the cost of both the treatment, okay, with the outcome. Cost, okay, we are going to use a formula and we are going to compare it with the outcome, okay, in terms of quality adjusted life years. How much is the difference between the cost of the 2 treatment? Treatment A, treatment B. What is the difference in cost divided by treatment A, treatment B? What is the outcome in terms of quality? So, okay, that is called as incremental cost effectiveness ratio. Okay, fine. Now, these are the questions we have discussed it, guys. And hopefully there was no problems, not much calculation. But I think you can answer most of the questions. Okay. Okay. So hope you are done well. Thank you, guys. Thank you, Doctor.
Thank you, Murugan sir. Thank you for that very crisp session. So the good thing this time for some students was there weren't a lot of calculation-based questions. I personally used to be very afraid of them.
Yes, lucky for them.
Very cut-to questions, right? Very program-based and yeah.
Thank you.
Thank you, sir. So next we have Era ma'am with Psychiatry. Ma'am, are you there? Yeah. Hello. Hi, ma'am. Good evening, ma'am. Era, ma'am, you're on.
Hi, audible?
Yes, ma'am. Yes.
All right, great. So psychiatry has unfortunately not been given the moment of shining this time. We've had one or maximum two questions from the recall that we've gotten. Anyway, we're going to cover whatever we can. And please chime along in the chat box so that I know that we are on the right path or not. Just going to try to get the questions on your screen in a minute. All right. There was this question from the best of the recall that we've gotten where it said match the following. And the options were clearly from, substance and also psychopharmacology, as you can see. Smoking cessation, which had to go with vanicillin. Delirium tremens, which had to go with a benzodiazepine. In this case, it was oxazepam, which we use when there is liver particularly damaged. Alcohol de-addiction, which was to go with acamprosate, and opioid OD, which was to go with naloxone. Obviously, because the order is not the same as what you've gotten, that's why I chose not to write one A, B, C. Was this question there, students? Please help me with this recall. Was this question there? So as I keep saying, if something that you must read, it's substance and psychopharmacology, right? Was this question there? Please help us understand whether this question was there or not. Give me a thumbs up in the chat. If this question was there, give me a no, ma'am, this question was not there. And then we'll obviously better our recall as we go along. I understand everybody's very tired, but just a little feedback on psychiatry very quickly. We have maximum 1 or 2 questions, and that's all that we will take your time. All right, not heard back. Presuming everybody does agree that the recall में ये question था. All right. Another thing that what we have gotten from our recall is the precursor of. Now, I'm unsure about the entire question, of course. As we go along, we'll better this question, we'll improve our recall. But was this, we didn't have any psychiatry question. Wow. It turns out that 2 questions have been created and curated through the recall of our students, but it appears there were no psychiatry questions at all. Chaliye, no problem. Then in this case, this question may not have been there at all as well. However, if this was there, then in the form of precursor, if not directly psychiatry, then the precursor of histamine is histidine, melatonin is serotonin, serotonin is made from tryptophan, and adrenaline is made from tyrosine. Even dopamine is also made from tyrosine, L-tyrosine. So was this there, something around this at all, remotely, long shot? Or was this also not there? Amazing, right? Psychiatry. I understand there something was going on with the psyche of the examiner that he didn't want to put psychiatry this time. But I hope you all were calm and you all could keep a level head and give the exam well. No problem. I'm not going to take much of your time. If you said there are no questions, we'll just move on to the next teacher so that Dr. Ishika can then take up OBGYN. Thank you so much.
Thank you, ma'am. So psychiatry has been done dirty this time, it seems. Okay. So starting with the OBG questions, I was able to get 19 questions, and of course recall thoda dicey रहता है because some person you tend to remember the options that you think are correct as the only recall. So these are the recall and the questions that I have gotten. If there is anything wrong with them, do point them out. So of the 19 questions that we had, I feel there were only 3 that may have caused a confusion, of which I feel I'm 100% sure, in fact, that one probably, if in fact the recall is correct, one answer was a misprint, which was the quadruple screen question. So without further ado, let us begin. So first question was pretty straightforward, which is not a germ cell tumor. So we have done this repeatedly in class. We have done the classification of ovarian tumors, and there are 4 types. There is the epithelial type, germ cell type, sex cord stromal, and then finally the metastatic. And we have done this diagram with the classification, and the question that was, the options that were given, I believe, were choriocarcinoma, yolk sac tumor, dysgerminoma, and granulosa cell tumor. So the answer over here will be granulosa cell tumor. This will be a granulosa cell tumor. Okay. So moving on to the contraindications of instrumental delivery. So I believe what was given, was it forceps or was it instrumental delivery? In either case, let us just look at what the options are. So one option was cephalopelvic disproportion. Another option was maternal exhaustion. Then one was prolonged labor, and finally fetal distress. So remember, instruments we are using to expedite the delivery, to make the delivery faster. So delivery fast, what are the situations where we might need to make the delivery fast? One is the mother is not able to push anymore, right? So maternal exhaustion is definitely an indication. Next, if the second stage has become prolonged, which means it has been more than 1 hour for a multigravida and more than equal to 2 hours for a primigravida. So if the second stage has been crossed, there has been a prolonged second stage, more than prolonged labor, a prolonged second stage, that is an indication for using instrument. Then finally, if the fetus is low enough, it is lower down in the pelvic cavity, the rotation and everything else is fine, then it is actually faster to take out the baby through instrumental delivery than prepare them for cesarean section. So yes, fetal distress is also an indication. Another indication for instrumental delivery is what? To cut short second stage of labor. So in cases like heart disease, severe anemia and failure, severe preeclampsia, where we do not want the mother to go through a lot of stress, we can use instrumental delivery. Once the baby is low enough, instead of waiting for her to push, we can just take it out. So cephalopelvic disproportion or contracted pelvis. These are contracted pelvis means the pelvis is too small. Cephalopelvic disproportion means the pelvis may be okay, but the baby is too big to navigate through the pelvis. So if it is too big to navigate through the pelvis, there is no way it can come out from down below, whether it is a normal delivery, whether you use instruments. So the answer over here will be cephalopelvic disproportion. Moving on to the next question. So this was also pretty straightforward, a little application based, but it was a very basic question. So which ovarian structure is responsible for this? I believe this was the picture that was given to you. So there were only 2 possible pictures that could have been given to you. One was where the glands are a little convoluted, a little longer, a little bit of branching, known as corkscrew glands, or it could be, more of stroma, less of, glands which are sort of circular and not very branched out. So the first one, I believe this is the question, that this was the kind of glands that was given to you. So this is the secretory phase. This is a secretory phase, or the last 14 days, or the luteal phase of the cycle, which means that these changes are being mediated by progesterone, which is being secreted by which structure? It is the corpus luteum. All right, moving on. I believe the essence of the question was that there was a young female who had a malodorous discharge and the whiff test was positive. So whiff test positive, very straightforward question, one-liner. The other malodorous discharge is Trichomonas vaginalis or Trichomoniasis. Candida does not have that bad of an odor. So the 2 options that have a malodorous discharge are Trichomonas and bacterial vaginosis. or Gardnerella vaginalis. But the moment they tell us the whiff test is positive, the answer becomes Gardnerella vaginalis. In the same vein, there was a question that was sort of related to this, which does not cause urethritis in males. So we have discussed this in class, that of the 3 vaginitis that we have done, which is the one that does not require partner treatment because it is not an STI, it's not a sexually transmitted infection, of candidiasis, trichomoniasis, and bacterial vaginosis. We studied in bacterial vaginosis, we need not give partner treatment. Why? Because Gardnerella vaginalis does not cause urethritis or STI in the male partner. Right? Moving on. Okay, so this was a bit of a confusing question. I have included 5 options in this because in the recall, the students were not very sure which one option was missing. So I have included all 5. But the ones that were definitely there were uterine massage, and bimanual compression. So according to the latest WHO guidelines, and we've done this multiple times in class, and I keep telling you this, that uterine massage used to be a part of active management of 3rd stage of labor. It has recently been dropped as a part of active management of 3rd stage of labor. So there are 3 things that we do, and the other 3 options, which are delayed cord clamping, controlled cord traction, and use of uterotonics, are actually the ones that are used in active management of 3rd stage of labor. Now, the problem was in the options, you were given uterine massage and bimanual compression as well. So remember, for me, the more appropriate answer, although both of them are not a part of AMTSL, the better answer over here would be bimanual compression, because this is used for treatment of atonic PPH. And sort of because uterine massage used to be at least a part of active management of 3rd stage of labor in the past, recently being dropped in the guidelines. So the more correct answer in this case would be bimanual compression. Now moving on, there was another question where there was a young female who was quite athletic and very thin. She had a BMI less than 18, and she had secondary amenorrhea and probably also primary infertility. And they had mentioned the values of FSH and LH, and both were low. So remember, what are we talking about over here? A lot of weight loss, a lot of stress, or too much athleticism, or anorexia nervosa. We are talking about functional hypothalamic amenorrhea. Right. So the cause is hypothalamic, which means the FSH and LH will be less, as a result of which the estrogen will also be less. So this will be hypogonadotropic. Yes. So Dr. Akanksha, FSH less than 2 is quite less. 2 is quite less. More than 10 is high. Less than 2 is less. LH is also quite less. So prolactin is within the normal range. Another reason for amenorrhea, secondary amenorrhea, is hyperprolactinemia. But 23 to 25 is the cutoff in most labs. FSH and LH, as you can see, is less. The key word over here is that this is a very thin woman and she is athletic. So that automatically should ring bells in your head that we are talking about functional hypothalamic amenorrhea. TSH is also fine. So they have mentioned all the important hormonal causes of secondary amenorrhea, in which we can see that, she is not pregnant. So amenorrhea is not because of pregnancy. She's come with infertility. TSH, prolactin are normal. Next, we move on to the other hormones. FSH and LH are low, which means there is a problem with either the hypothalamus or pituitary. In both cases, this is going to be hypogonadotropic hypogonadism. Okay, moving on. So this was a question. Can anybody help me with the options? BRCA1 ovarian tumors, what is the new treatment? So this has been discussed in class. So the new treatment that is being used in BRCA1 is PARP inhibitors. So the ones that are FDA approved for ovarian cancer are olaparib and niraparib. So if they were there in the options, you could have marked those. So were they there in the options? Okay. So you can just let me know what the options were. We will move on. We will move on to the next question. So the exact wording of the question was not clear to me. I think 21-year-old girl had come for CA cervix screening, or there was a doctor who had gone to a low resource area setting. So what were the exact words? So there was a low resource area, and she had to formulate a screening protocol for CA cervix, So what have you marked in this? What have you marked in this? So remember, the screening protocols, again, as done in class, we start at 21 years. At 21 years, goes up till 65 years. The best way is to do a co-testing, which is PAPS plus HPV. PAPS plus HPV, right? But if the word low resource was given, HPV is expensive. So low resource, actually, WHO says, the guidelines say you can even do VIA or villi. But because this is not given in the question, the next best answer is Pap smear. Now remember, Pap smear, if done alone, it is done 3 yearly. And if the question said that the patient was 21-year-old, remember, before 30 years, we do not do HPV DNA. HPV DNA testing starts after the age of 30 years. After the age of 30 years. Okay. So this was another question which I feel was wrong. The options given were wrong. So quadruple screening, as everyone knows, we do have HCG, we do have alpha fetoprotein, we have unconjugated estriol, and we have dimeric inhibin A. But I believe the option that was given, from what I have heard from a lot of students, was the option was inhibin B and estradiol. So I feel like you should be getting 3 marks on this one, because this may have been a misprint. So, but if anybody's, remembers this correctly, what were the words, or whether, it was actually inhibin B or estriol, do let me know. Okay. Moving on, there was a very simple question, very commonly asked PYQ, primary amenorrhea with a bluish bulging membrane. What was the diagnosis? So remember, bluish bulging membrane, the reason there is a bulge is because the membrane is thin, a septum is not thin, a septum is thick. I do not know what the other options were, but this is a very straightforward question. I believe this girl also had urinary retention. So everything points towards an imperforate hymen. Moving on, another question that was asked was delayed cord clamping is done in. So the options were term and preterm baby not requiring resuscitation, all term babies irrespective of weight, vigorous term babies not requiring resuscitation, all preterm irrespective of weight. So the answer, as we have done in class, is the only contraindication for delayed cord clamping. The only time you should not delay cord clamping is if the baby requires resuscitation, be it term or preterm. Rest, each and every baby, irrespective of their weight, be it term or preterm, you should go for delayed cord clamping. So the best answer over here, although more than one answer is correct, the best answer over here is term and preterm babies not requiring resuscitation. Moving on, another straightforward question. Early onset preeclampsia is before 34 weeks. Before 34 weeks. After 34 weeks is late onset preeclampsia. Next, ectopic, which is false. Yes, pain is a common presentation. STI or PID is a risk factor. The third option I could not get, but I believe it was something to do with progesterone levels being low, which is true, because progesterone levels are much higher in an intrauterine pregnancy than in an ectopic pregnancy. And there was another option, which was medical management is done with methotrexate when the patient is in shock. Remember, methotrexate is a cytotoxic drug. It will kill the ectopic, but it will take a lot of time. So we do not have that kind of time with us when the patient is in shock. We do not have weeks and weeks. She will die within hours. So remember, whenever the patient is in shock, the treatment of choice is always going to be surgery. So the answer is medical management. The answer is medical management. Moving on, which is the smallest diameter, true conjugate, obstetric conjugate, diagonal conjugate, and anatomical conjugate. So remember, true conjugate and anatomical conjugate mean one and the same thing. So what is obstetric conjugate? And why is it the one? This is the one thing I keep telling you in class. The only one of importance to us is the obstetric conjugate, because this is where the baby can get stuck. Why can the baby get stuck here? Because this is the smallest diameter. So the smallest AP diameter is the obstetric conjugate. Next question. What percentage of couples have unexplained infertility? Slightly tricky question, because if you look at the actual stats, it's 15 to 30%. But if you look at what the guidelines and the American Association are saying, it is up to 30%. So the answer will be D, 30%. 30%. Moving on, there was another question. This was one question which was a little confusing. If anybody can help me with the wording of this, I will be very, very grateful. So there was a 24-year-old with a 8 into 6 centimeter ovarian mass. She had a 14-week sized uterus. Because of this mass, was a pregnancy mentioned? The patient had RHD, probably had a valve replacement, due to which she was placed on warfarin. And she has a cyst which is hypoechoic with a reticular pattern on ultrasound, which means this is a hemorrhagic cyst. So remember, the cyst is more than 6 centimeters. So usually we go for surgery, but what it seems like in this scenario, is that this patient was taking warfarin, due to which she had a bleeding tendency and she had bleeding within the cyst. So tell me, was there anything about abdominal pain? Was there anything about abdominal pain? Were any symptoms given for this patient? Any abdominal pain, shock, vomiting? Okay, so probably with time, with more recall, we will get to what the exact question was. But the way I have worded it over here, if it was like this, and if the patient had symptoms, if she had pain, then the answer is going to be surgery. It is a large cyst. So if there are symptoms, we are going to go for surgery. With such a big cyst, and if she's taking warfarin, she has a bleeding tendency, we are not going to wait and watch. We are not going to wait and watch. Now, moving on, what is restitution? So restitution, remember, it is not an active movement of labor. It is a cardinal movement, but it's not an active movement of labor. When the head undergoes internal rotation by 1/8 of a circle, the shoulder at the same time does not undergo rotation, which means the head is twisted like this, right? So because it's in a bony cage of the pelvis, the head cannot untwist itself. But the moment the head comes out, it wants to untwist itself and sort of align itself in this position again. From here, it wants to go here. So restitution is nothing but the untwisting of the fetal head to its original position. So it is in line with the shoulder. It is in line, it's perpendicular to the shoulder. So the answer is A, head rotating due to untwisting. Head rotating due to untwisting. Now, again, a pretty straightforward question, physiology of pregnancy, which is incorrect. What is incorrect? So yes, due to HPL, there is a state of fasting hypoglycemia and postprandial hyperglycemia. There is an increase in RBC mass to increase the oxygen carrying capacity for the baby and placenta. And again, because of the HPL, there is peripheral insulin resistance. The answer is, remember, the BP falls during pregnancy. The peripheral vascular resistance falls during pregnancy. The maximum fall is in the second trimester, due to which patients complain of dizziness, the maximum in the second trimester, right? But even in the first trimester, there is a fall in BP. There is no increase in systolic and diastolic blood pressure. Okay. So this was it. This was it. Thank you. OBG, barring 3 questions, was pretty straightforward, of which 1 question probably had a mistype or typing error in the options, which was the quadruple screen question. I do not have the exact recall of the large cyst question. So if anybody can tell me what the exact scenario was, then maybe we can discuss it. And finally, there was one more, which was AMTSL does not include, but bimanual compression is the least likely thing to be included in AMTSL. So that would be an answer. So all in all, I would say there was 1 typing error. And if anybody can give me the details of the variances, then we can find out if it was a confusing question or straightforward question. So that is it. Now, I'd like to hand it over to Dr. Jazir for dermatology. Sir, are you there?
Yes, ma'am. Thank you so much. Am I audible?
Yes, sir, you're audible.
Okay, thank you so much, ma'am. I'll take over. Yes. So my dear students, I hope the exam went well. I was just checking regarding the dermatology questions that were asked. And quite surprisingly, I could not find the commonly asked main topics in dermatology this time. So anyways, whatever questions I have collected, I would like to do a very quick recall. And I hope I can proceed. So just give me a minute. Yeah. So the first question that I have got from the students is that a patient with a ulceronodular lesion in the forearm with axillary lymphadenopathy. So when we see such a question, so basically when you go through all the options, what you can find is sporothrix 𝐒𝐿, histoplasmosis, blastomycosis, etc., which means the question is about a deep fungal infection. So once it is a question regarding a deep fungal infection, so what is most important is whenever you get a deep fungal infection, especially after getting a thorn prick with a rose plant, that is why we call some disease as a rose gardener's disease, right? So rose gardener's disease. So this question is very much about rose gardener's disease, which is also called as sporotrichosis. So what happens in a sporotrichosis, we all know that when you get a thorn prick, let us say in this site, so in few days what happens, the patient would develop a nodule, and this nodule may eventually become multiple nodule, which is arranged linearly. And this linear arrangement of these nodules is also called as a sporotrichoid pattern. So because it is running along a lymphatics, isn't it? So that is how. So once you go to the options, you can see that sporothrix, histoplasmosis, blastomycosis. Obviously, what should be the right answer here? The right answer here should be sporothrix 𝐒𝐿, because this is the causative of sporotrichosis. Sporotrichosis. So this sporotrichosis is also called as a rose gardener's disease. And usually what happens, these kind of deep fungal infections usually happens due to a fungal implantation due to some trauma. So that is the first question which I could collect. So now with your permission, if there is any corrections, you can just let me know in the chat box. So if there is no corrections as such, then I shall just continue as well. So just going to the next question. So just now I saw that Oshika ma'am, you were talking about the Weave test and all. So similarly, I just got one more question, like what is a common cause of urethritis in male? So when we see the options, so if there is any correction, you can anytime correct me in the chat box. So the question which was shared to me was, what is the most common cause of urethritis? So urethritis, we already know that there is either a gonococcal urethritis or a non-gonococcal urethritis. By the name gonococcal urethritis, it is caused due to Neisseria gonorrhoeae, whereas non-gonococcal, the most common organism can be chlamydia, isn't it? So here, if you ask what is the most common in males when it comes to urethritis, the right answer should be gonococcus. At the same time, I saw that some of the students were confused. No, it is not the common cause that was asked. Instead, it was what is not common. So what is not common? In case the question was like, what is not common? So in case it is not common, then let us assess the same MCQ again, the same options again. So gonococcus, हाँ तो वो तो common है. So the next one is Gardnerella. And the third one is Trichomonas. So we know that this Gardnerella, this is mainly implicated in the bacterial vaginosis, which Oshika ma'am had just now discussed. Acha, Amrita is confirming that the common was asked. If it is common, then no confusion. So among the options, the common one should be definitely be gonococcus. In case the not common was asked, in such cases, the right answer would have been Gardnerella, because that is not commonly seen in males. It is more commonly seen in bacterial vaginosis. Okay? So I'll just remove this not common one. So here the right answer should be gonococcus. So now let's go to the next one. So this time they had asked you some question regarding the treatment part of onychomycosis. So onychomycosis, it is where you get a dermatophytic infection of the nails. So here they asked you regarding the topical treatment. So we know that when it comes to dermatophytosis, the overall drug of choice is usually going to be terbinafine. Whereas when it comes to nail, so there is less likely that when you apply a cream or an ointment, so it may not be absorbed properly. So according to the guidelines, when there is less than 50% of involvement of the distal nail plate, then we can definitely go with topical antifungal agents. And these topical antifungal agents, they come as nail lacquer. So what are these nail lacquer? These nail lacquers are something like a nail polish. So you can apply this nail polish which contains an antifungal agent. So what are the common nail lacquers that is available which can be used for the management of onychomycosis? We will look into the options later. First, let us see what are the nail lacquer that is available. One is amrolfin. And then we have cyclopyrox. Then we have cyclopyrox. So whatever I have written just now, it is not seen in the options, right? So what do we have in the options? The next one more agent which can be used is efinaconazole. So that is also used as a topical antifungal agent which can be used for onychomycosis. The last agent which can be used is tavabarol. So now let's go back to the MCQ. Voriconazole, tavabarol, caspofungin, itraconazole. So what is used? So here the right answer should be tavabarol. So all these are available today as nail lacquers which can be used in the management of onychomycosis. But in case they ask you what is the oral agent that could be used. So here the oral agent could have been itraconazole. Okay, so the oral agent could have been itraconazole, which could have been used for the onychomycosis. But I guess they asked you regarding the topical treatment itself. So please confirm in the chat box if there is something different. So just going to the next question, that there was a question which gave you a history, like there is a farmer who was walking barefoot, isn't it? And the farmer presented to you with an ulcer and edema of the foot. So based on the kind of clinical scenario that was given, again, this barefoot means, again, the examiner is trying to put across that there is a deep fungal infection which may have been acquired due to a traumatic implantation of the fungus, right? So out of all the options, I feel I was not able to get all the options that were given, but obviously based on the MCQ, the right answer should have been Madurella mycetomatis. So what is a disease where the patient can come to you with a large swelling ankle of lower limb? So here this should have been mycetoma. So we know that mycetoma, it can be either caused due to bacteria or due to fungus, out of which fungus is more common. And the most common fungus which causes mycetoma or Madura foot is going to be Madurella mycetomatis. And these are the only questions that I could gather from dermatology. So we usually expect questions from psoriasis and several other topics, but that was not the case in this INICET exam. But I hope that whichever questions you got, you were able to answer it properly. And without wasting any more time, if there is anything, you can definitely get back to me. And I'll just hand over to back to Oshika ma'am for the next faculty. Thank you so much. Ma'am, are you there? So I think, yeah. And I'll just hand over to Ben.
Hello. Thank you, sir. Thank you for the session. Sudha ma'am, are you here? Sudha ma'am is next. So we'll start with Ofthal. Ofthal, I was always scared of. So I'll quickly hand it over to you and run.
Hello, Dr. Vishika, and hello, students. So we'll do a quick recall of Ofthal. It's been a long day for all of you. And I know that you're all really very tired, and that's why we obviously could not get a complete recall. The students were like, they were exhausted after the exam. So I have the set of Ofthal questions, but get a complete recall. I have a set of Ofthal questions, but most of them, the options are not like available completely. So I will just go through the questions. Essentially, as has been the case with INICET most of the time, they were PYTs, but I would not say that they were like exactly the regular kind of questions. Let us anyway go through. See, there was the first question was a simple one. Like there is a question like, which is there was a question probably which said that there is a patient who has anterior uveitis and sacroiliitis, or they could have said that there is a young patient who has got anterior uveitis with low back pain, something on these lines. And it was asked that which is the HLA that is commonly associated with this. I hope that this was the question, something on these lines. And I do not know what options were given, but then the combination of low back pain, that is anterior uveitis, and morning stiffness or sacroiliitis, all this kind of points to a diagnosis of ankylosing spondylitis. So the HLA that is associated with angspond is HLA B27. So a pretty straightforward question. Whether you want to call this orthopedics or ophthalmology is your take, but like this is probably what the question was. I hope this is what it was, or was it something different? HLA associated with anterior uveitis and sacroiliitis. This was a simple one-liner. Right? Okay, let me move on to the next question. The next question was like, what do, yeah, it was the same, yeah. How do microaneurysms look like on a fundus fluorescein angiography? Now, we know that microaneurysms, this is the earliest detectable lesion in diabetic retinopathy. So the earliest feature that you see in a patient of NPDR are microaneurysms. And when you look at a fundus picture, they look like small, very, very small red dots. And when you do an FFA for this patient, they look like these kind of small white dots that you see in this picture. So I don't know what options were there, but the answer that should have, the option that should have been is they look like very tiny hyperfluorescent dots. They are hyperfluorescent because they are white, right? When there is the black, when you have something in black here on the FFA, we call it as hypofluorescent. So like if you have a hemorrhage, that is likely to be hypofluorescent. But microaneurysms, they look like these tiny, small, white dots. So the answer would have been, I think one of the options should have been hypofluorescent dots. And if it was there, then that is the answer. I hope this was the question. Hyperfluorescent. Yeah, hyperfluorescent. So that is the correct option. The third one. Now, this, I don't know what exactly was the question. A couple of options. Yeah, hyperfluorescent dots, hypofluorescent dots. It is definitely not hypofluorescent. Huh? Hypo means, it, as I said, hemorrhage will be hypofluorescent. So, and it is not line or branch or anything. It's a small dot. So, hyperfluorescent dot is the answer. Now let's go to this question. So there was this question on sudden and painless loss of vision. Now, see, the first two options that students could recall are acute ACG, that is angle closure glaucoma, and iridocyclitis. Both these are sudden, but they are painful. So these are sudden, of course, but this is sudden and painful loss of vision. Now, I do not know what the third option was, but it may have been proliferative diabetic retinopathy. Now, in proliferative diabetic retinopathy, there is vitreous hemorrhage. There may be vitreous hemorrhage. So PDR is associated with vitreous hemorrhage, and vitreous hemorrhage can cause sudden and painless loss of vision. So I don't know if I am not sure of the fourth option actually, so I cannot say, but this is what I can kind of gauge. This causes a sudden and painless loss of vision. Keratoconus was there in the option. Keratoconus was there in the option. Keratoconus is generally gradual and progressive loss of vision until and unless the patient gets a high drops, which may be there in advanced keratoconus. But if I were to say just keratoconus, I would say that it's a gradual and painless loss of vision. It would not be sudden and painless loss of vision. Question mentioned that it is bilateral. Now, this is also, was diabetes there in the option? I am not sure. I mean, somebody told me the students were not able to recall. The patient presents with bilateral. Bilateral was given in the question, but was diabetes there? Proliferative diabetic retinopathy or vitreous hemorrhage? Even vitreous hemorrhage is very unlikely to be bilateral at the same time. Diabetes was there. So maybe we can say proliferative diabetic retinopathy presenting with vitreous hemorrhage, sudden and painless loss of vision. But this also is very, very unlikely to be bilateral. At least, I mean, suddenly happening in both eyes, getting diabetic retinopathy in both eyes is not very common. But if I were to choose between diabetes and keratoconus, then I would probably choose diabetes only because keratoconus, having advanced keratoconus, which gives rise to high drops in both eyes, is far more unlikely than getting vitreous hemorrhage in both eyes. So probably we will have to mark diabetes only. Proliferative was not given, but they probably meant proliferative only because otherwise you cannot get a sudden loss of vision in diabetes. So this was like a dicey question. Either the options were a little muddled or they could have probably not been recalled properly. Let's go to the next question. This was a straightforward question. This has been discussed many times. We have discussed this in our sessions. So what is the investigation of choice for Best disease? The investigation of choice for Best disease is EOG, that is electrooculogram. Electrooculogram or EOG is the investigation of choice for Best disease. And EOG, this is mentioned, this is measured in terms of a ratio which is called as Ardens ratio. And this is a typical question which is asked by the INICET people only. So this has rarely come in NEET PG, but INICET people ask this question. So this is almost a P by Q. So investigation of choice for Best disease is EOG, electrooculogram, and it is measured in terms of the Ardens ratio, which is a ratio of, as all of you know, it's a ratio of the light peak to the dark trough. Yeah, so EOG was there in the option. That is the correct answer. Next question was what kind of I don't know how the question was exactly framed, but there was a question on pterygium which asked that what is the refractive error that is seen in pterygium, or what is the visual disturbance that is caused by pterygium. Now, the commonest visual disturbance that we get to see in pterygium is astigmatism. It is astigmatism. Why astigmatism? Because you know that what the pterygium does is, the pterygium, it presses on the horizontal axis of the cornea and it flattens the horizontal axis. It flattens the horizontal axis of the cornea, and as a result, it gives rise to with the rule astigmatism. Astigmatism was there? Yeah, it flattens the horizontal axis of the cornea because it grows on the horizontally. So it flattens the horizontal axis. So it causes astigmatism. And if it was asked what kind of astigmatism, it is generally with the rule, that is WTR astigmatism. I do not know what the other options were. Can you recall the other options? But if I have to say what is the visual disturbance or commonest refractive error that is caused by a pterygium, it is astigmatism. So I assume that this was there in the option. Can you tell me what the other options were? Can you recall? I know you people are like really tired, but kind was not asked. What type of astigmatism was not asked? And the question was, what is the refractive error in pterygium? Purulent discharge. Yeah, that's not likely. Pterygium is not infective, so you are not going to get any purulent discharge. Yeah, okay. You are not able to recall the options. Most probably, whatever the option was, this is the answer, because this is the commonest thing that they generally ask in pterygium about visual disturbances or visual problem in pterygium. Just 1 minute, I'm sorry. Yeah, I cannot recall the others, which is very, very likely. Generally, what happens is by the end of the day, we just forget. Now, this is another where you want to call this an embryology question or an ophthalm question. Which of the following is not derived from the neural crest cells? Now, see, what are the derivatives of the neural crest cells, basically? So, the neural crest cells, the main derivatives in the eyes are layers of cornea except the epithelium. So the neural crest cells, they give rise to all the layers of the cornea except the epithelium. I'm going through the important derivatives, right? Then they give rise to the angle of the anterior chamber. They give rise to the angle of the anterior chamber. They give rise to the stroma of the iris and the ciliary body. They give rise to the stroma of the iris and the ciliary body. And they also give rise to the choroid. So these are the main derivatives of the neural crest cells. So all the layers of the cornea except the epithelium, the angle of the anterior chamber, the stroma of the iris and the ciliary body, and the choroid, these are the derivatives of the neural crest cells. Now, once again, I do not have the options, but I believe that there was an option retinal pigment epithelium. Retinal pigment epithelium, all the layers of the retina, including the RPE, these are derived from the neuroectoderm actually. Or we can call it the neuroepithelium. Neuroectoderm. Neuroectoderm or neuroepithelium. Yeah, ciliary muscle, yeah, these are derivative. Ciliary muscle is a derivative of the neural crest cells. So if there was RPE in the option, that is only the right answer, because RPE or retinal pigment epithelium is a derivative of the neuroectoderm or the neuroepithelium. It is not a derivative of the neural crest cells. Yeah, ciliary muscle and melanocytes. Yeah, so these are derivatives of neural crest. Yes, so if RPE was given, that is only the right answer. Shall we move to the next question? Yeah, now this question, I am not sure what was there in this question, because none of the students could actually recall this. Which is not present in the photoreceptors, or did it say which is not present in the inner segment of the photoreceptors? What was the question? Now I'll tell you what. There are two segments in the photoreceptors. We have the outer segment and we have the inner segment. I believe that the question was probably about the inner segment of the photoreceptors. Now the inner segment generally contains the organelles. Yeah, it generally contains the organelles, like for example, the mitochondria, it contains the Golgi body, it contains the endoplasmic reticulum, and it contains the ribosomes. Okay, of course, apart from the nucleus. So it contains these. And the outer segment, it actually contains the membranous discs. It contains the membranous discs which have the pigments. So the outer segment has the membranous discs which have the pigments, and the inner segment contains the cell organelles. So I think that probably the question was which of them is not present in the inner segment of the photoreceptors, and the answer to that will be the membranous disc, because the membranous discs are actually there in the outer segment. I think this was the question. So mitochondria, Golgi body, ER, and ribosomes are there in the inner segment, and membranous disc in the outer segment. So what is not present in the inner segment would be the membranous discs. Yeah, so the answer is the membranous discs. If that was there in the option and if this was the question, then the answer is membranous disc. Right, shall we go to the next question? Right, now the next question is again another confusing question. What is not seen through a macular corneal opacity, or what can be seen through the macular corneal opacity, something on these lines. So basically, through the macular corneal opacity, the definition itself says that the iris details are hazily visible. iris details are hazily visible. So they can be seen, but they cannot be seen very easily. But the rest of the thing you will be able to see. You'll be able to see the iris, you will be able to see the pupil, you will be able to see the margin of the pupil, but you will not be able to see the iris details very clearly. They are not clearly visible. So if there was an option that iris details are what is not seen through a corneal opacity, iris details are not clearly seen through a corneal opacity. Was this the question? On macular corneal opacity, that in macular corneal opacity, which is visible? What is visible? What is visible through a macular corneal opacity? That was the question. A macular corneal opacity, see, you know that it means that about 1/3 to half of the corneal stroma is actually involved by the opacity. And the clinical definition is that the iris details are visible, but they are visible very hazily. So you cannot clearly delineate the iris details. So what is visible through a corneal opacity? If that is the question, then iris details are hazily visible. Was this the question? Only pupillary margin is visible, only iris is visible. Both are visible, but iris details are hazily visible. So I think the answer should be both of them are visible, but they are hazily visible. Pupillary margin as well as iris are visible, and pupillary margin and iris details are both hazily visible. That should be the answer. So in case of a nebular opacity, they are clearly visible. In case of a macular opacity, they are visible, but they are hazily visible. And in case of a leukomatous opacity, they are not visible. So if the question says that iris details are visible, they are visible, but they are hazily visible. So I think both are visible should be the answer. Yeah, both are visible should be the answer. Both of them are visible, but they are hazily visible. Right. Now let's go to there are two other questions. Another question was a pretty straightforward question. That was the normal AV ratio. Normal AV ratio, arteriovenous ratio at the angle. Yeah, what is the normal AV ratio? This, I think most of you would have got it right. It is 2:3. So the importance, as you all know, is for if you want to see arteriolar narrowing, which is seen in case of severe hypertension, then you try to look at this ratio. So the normal AV ratio at the optic disc is 2:3. Was this the question? I think this was a pretty straightforward question. This most of you would have answered. And another is a question on leukocoria. Again, no INICET exam goes by without a question on leukocoria. Yeah, without a question on leukocoria, they would have probably mentioned that the child is 1 to 2 years old. The child is brought with white pupillary reflex or leukocoria, and they would have probably mentioned that the USG shows an intraocular mass with calcification. Was this the question? So they must have mentioned something like this: 1 to 2 years old, USG shows intraocular mass with calcification. Yeah, so if this is the question, then you know what it is. It is retinoblastoma. I don't know the options, but I am fairly sure that this is the question because this is a pet question of INICET people. Right, so this is what we had in ophthal. Ophthal was, yeah, it was the same question. So ophthal, we have about 8 to 10 questions. 2-3 questions are a little dicey. They are PYTs, as it has always been with our INICET. They are PYTs. We cannot exactly say they were PYQs, except for maybe 1 or 2, which were like direct PYQs. But they were PYTs, previously asked topics, but questions were a little confusing, or maybe they are appearing confusing because we don't have the options, all the options. So this was just to give you a gist of the questions, and we will create a complete recall with all the options for you in a few days. So thank you very much, everyone. Now I'll ask Dr. Rishabh to take over.
Thank you, ma'am. I think Optha now, in the last 2 sessions also, we have seen the questions coming from Optha have increased. So during the last 3 to 4 years back, the trend with ENT Optha was really declining. 2-3 questions, maybe 3-4 questions were asked, but now again Optha ENT is picking up back again. So this is sort of, subject distribution that INI keeps on having. Nobody can predict which subjects are important, which subjects are not important, but that is the way it is.
Yeah.
Thank you, ma'am.
They are
Next,
predictably unpredictable.
yes, ma'am. So next we'll have anesthesia by Vinesh, sir.
Hello, sir. Visible
Hello,
and
sir.
audible?
You're audible. Yes, sir.
Okay, sir. So shall I take over then, sir?
Yes, sir. Please.
Right, sir. Thank you, sir. I'll just start. So, good evening, guys. We'll be doing a fast recall of the anesthesia questions. This time, almost 6 to 7 questions. 6 are there. Yeah, I'll say 6 to 7 questions from anesthesia. Few were easy, few were difficult. That's my analysis. Previous year's topics, previous year's question. No previous year's questions were there, but we'll put it as previous year's topics. So let's jump into the questions straight away. If there are any questions, if there are any points where you want to correct me out, please do that. Okay. So overall, anesthesia was easy, not very difficult, what I found. But yes, you'll have to have your concepts clear. 1 or 2 questions we'll discuss which are the difficult ones. The first was Jackson-Rhee circuit is used in obstetric general anesthesia, pediatric anesthesia, neuroanesthesia, cardiac anesthesia. Simple question. Jackson-Rhee is Mapleson F Jackson-Rhee circuit, and this is used in pediatric anesthesia, right? So I think all of you must have got this answer clear, and everyone has covered it everywhere. So we have also covered in our lectures and everywhere which is there. A simple question. Jackson-Rhee circuit is used in pediatric anesthesia. This was the first one. The second question that came, all are true about thiopentone except, right? Or which one of the following, which is the following is not correct about thiopentone, either of that. That is the way the sentence was framed. 4 options were given. The first option was it is lipid soluble. The second option was it has maximum concentration in the brain after IV injection. The third was it gets redistributed to adipose tissue and muscle. And the fourth is the time of action is less as it is maximally excreted by the kidney. So which is true? Is it a lipid soluble agent? Absolutely correct, right? It has maximum concentration in the brain after IV injection. Yes, that's why we use it for anesthesia. Right? It goes immediately. The arm brain circulation time, what we reach in general pharmac, is hardly about, which is about 11 to 15 seconds. It reaches the brain very, very fast, very, very fast. And that is why it produces immediate anesthesia. C, it gets redistributed. Yes, that's the reason for the effect to get over fast. So the correct answer here is D. This is the one which is false. This is the one which is false. The reason is the time of action is less, not because it gets maximally excreted by the kidney or the excretion that takes place by the kidney, but because of the point mentioned above. The time of action is less because of redistribution to adipose tissue and muscle, because of which it makes thiopentone ultra short acting drug. If you will see the same thing we have covered in our classes, you'll see it's the rapid redistribution which makes the thiopentone drug ultra short acting, right? That's what we have covered there. Now, so the correct answer here is option D. This is the reason. The redistribution is the one which makes it ultra short acting. It's because of this reason, right? Ultra short acting. So time of action is less because of redistribution. That was the next question. Let's go to another one. Again, a simple one. So questions still here are very simple. Huh? Adrenocortical suppression is seen with which of the following drug? Again, a simple answer. Option C, etomidate. Okay. Option C, etomidate. Correct, Dr. Kiran is there, huh? Right? Correct. Absolutely correct. Okay. Option C, etomidate. So this is again, all of these questions are easy. When you speak of etomidate, there are only 3 complications majorly you're supposed to know. Adrenocortical suppression, nausea, vomiting, and focal seizures that take place, right? Apart from myoclonus, right? These are 2, 3, 4 things that take place. Apart from that, etomidate is a fairly simple drug and most cardiostable as well, right? So here, this is what was asked. This also we have covered. You can see myoclonus, hiccups, nausea, vomiting, adrenal suppression, and the biggest problem is adrenal suppression or adrenocortical suppression that takes place. So we've discussed this as well. Next, a patient with multiple rib fractures, right? 3 to 8. Some people said 5 to 8. Some people said 2 to 6. Okay. So this was not very sure, right? 2 to 6, 5 to 8, or 3 to 8, but this is what we got. So let's take in between 3 to 8. A patient with multiple fracture ribs 3 to 8 is not responding to the effect of IV analgesic drugs given to him. Next step, supraclavicular block, cervical plexus block, a thoracic epidural block, or lumbar epidural block. Again, this we have covered in our lectures also. I could not have a Dr. Kiran's exact recall. Yes, thank you. But the students have helped there. The students have recalled, not we. The students could recall anesthesia questions. I'm telling you, anesthesia students could recall, and some of them are not easy. Anyway, so here the correct answer is a thoracic epidural, which is very commonly used for flail chest. In fact, we have used it practically also. In flail chest, a lot of time the treatment used to be intubate the patient and put on ventilator because the patient could not breathe. I remember doing my post-graduation when I was doing it, intubation and put the patient on ventilator. This was the trend. But when epidural came and we started using epidural, because of using of epidural, this intubation and putting the patient on ventilator for multiple rib fractures decreased, and it takes care of the pain. So this is the answer over here. Thoracic epidural block is the answer. Supraclavicular and cervical. So if you give a cervical plexus block, means somewhere in the neck, it's going to cover only this area. Am I right? Supraclavicular means above the clavicle. So you give it above the clavicle, it's going to cover somewhere around the hand, arm. That's what's going to get covered. Now here you have a patient who's got fracture between 2 to 6 or 3 to 8, something like this in between, right? So if you are going to cover up this area, you are in the thoracic vertebra, you are supposed to give the thoracic epidural to this patient because lumbar epidural is going to be over here, right? If you want the drug from lumbar area to reach the high upper, thoracic area, it's not possible. So this is your lumbar epidural. Just by the knowledge of anatomy, you can give this answer. Cervical plexus is not the right answer, right? The limb block which you're saying supraclavicular is not the answer. It's the thoracic epidural that you put that will take care of the pain, right? So this is the next question. 3 to 8 is given, says Dr. Kiran. Alright, thank you. The students have really recalled that. The ones who have given me the questions, the ones who have given me the options are really good. So the students who gave me, they could recall anesthesia. Very good. Fine. So the correct answer is thoracic epidural. Nice. So let's go forward. Right? This was one question. Now, next question is a difficult one. UMBU Aura 40 is which generation of supraglottic devices? And I'm telling you, yes, even this is something which people have not heard. It is not commonly used in India. It is not commonly used, right? And that's how you expect the questions from INICET and AIIMS to be there. They will ask you a few questions which are, still in the pipeline. It's available. I'm not saying it's not available, but it is not used so common. In India, what we use is ProSeal, a classic LMA, and iGel. These three things are used, but you people need to know what is the meaning of first and second generation LMA, which we have covered in everything, all our classes, right? So, a second generation LMA will have 2 tubes. A single first generation LMA, it has only 1 tube. That's the basic thing. And the other 2 options which were given over here, third generation and fourth generation, they are not there. That's the wrong thing, right? So third and fourth are out. Your options should have been between first and second. Now, when you look at the image, guys, so what you see, this is the image of UMBU Aura 40. This is UMBU Aura 40. The advantage is that it is a reusable LMA. Reusable LMA. And it is soft and all, whatever things are there in the brochure, that's a different thing. It's a reusable LMA, right? But do you realize it has got only 1 tube? If you speak of UMBU has other variants also. The one which you see next to it, this is called UMBU, I think GAIN, or something with G, I forgot the name. UMBU, right? So if you will see, this has 2 tubes. One is the airway tube, and here is the drain tube. So one airway tube, oxygen goes here, and here is the drain tube. And you will find that Aura UMBU has only 1 tube. So according to me, it will be the first generation. That's according to me. Am I visible, audible, guys? All of a sudden, I can't see myself.
Yes, sir, you're audible.
Am I visible, audible, guys?
Yes, sir, yes.
Yes. Okay. So anyways, fine. So this UMBU GAIN has to be the second generation. So if someone will ask me what answer would I go for? So I will be going on for the answer. It is the first generation LMA because I think it has got 1 tube. If it has 2 tubes, then it has to be second generation. But according to me, thank you. I'm visible. Thank you for that response. And UMBU Aura 40, according to me, has one tube, so it will come as the first generation LMA because it has one tube. If it has two tubes, this is the image that I could gather from where I can see only one tube, guys. If it has a second one, then I don't know. But according to me, the second tube is here, which you can see the other variant of AMBU LMA, right? This should be first generation, according to me. I may be wrong, huh? I may be wrong. Next, which of the following is correct regarding pediatric CPR? I think it must have been covered by Dr. Balaji as well, right? So option A, 30:2 with 2 rescuers, right? Chest compression, 1/3 the depth of the chest, right? Adenosine is given by the intraosseous route, and adrenaline is given by 0.01 milligram per kg IV/IO in 1:1000 concentration. That is the kind of recall that students told. So first thing, 30:2 with 2 rescuers in a pediatric CPR is wrong. This is false, right? Chest compression, 1/3 the depth is correct. Adenosine is given by intraosseous route. Yes, you use intraosseous route, but remember in CPR nowadays, adenosine is not used because the drugs used in CPR are adrenaline. You are going to use amiodarone, lignocaine at the max magnesium, right? These are only things. Adenosine is out. We don't use it. So this question is not correct because adenosine is not used nowadays. The fourth is adrenaline. Adrenaline given by 0.01 mg per kg. Yes, this is correct. But remember, when you talk of CPR, you don't use 1:1000 concentration. This is normally used for anaphylaxis. Anaphylaxis. When you talk of CPR, I think you use 1:10,000. I mean, that's according to me. So this point is not correct. It is correct till here. So if you will see the first option, 30:2 with 2 rescuers, no, it has to be 15:2 with 2 rescuers. This is the answer for the first one. So the first one also is wrong. The third one is wrong because adenosine is not used. And the fourth one is wrong because adrenaline is used, but not in 1:10,000 concentration. We use it 1:10,000 concentration. So therefore, the correct answer here is option B, chest compression, 1/3 the depth of chest. This is correct. Both in adults, both in pediatrics. This is the practical way how you come to know. Otherwise, normally in adults, the chest compression is how much? It's about 5 to 6 centimeter or 2 to 2.4 inches. How will you come to know while you're doing it practically? It's basically 1/3 the depth of the chest. So it's true both for adults as well as pediatrics. All right. So this was another question. The last question, where this is what some students told. Now I don't know what are the correct options, what options were given, but this is the maximum that some of them could recall. So even the sentence, I'm not very sure if the question is right or not, but this is how it was. Post cardiac arrest, which of the following is not included? Right? The first option they said was give hypothermia if patient is not at all responding. Second option they said was maintain SpO2 to more than 94. I'm talking of post cardiac arrest care when the patient has got a return of spontaneous circulation, which is called as ROSC. It means the patient's pulse, patient's response, patient's pulse, patient's BP has come back, right? Pulse and breathing has come back. It's called return of spontaneous circulation for this patient. Right, so hypothermia was one option that they said, maintain SpO2 more than 94, mean arterial pressure more than 65, and transfer the patient for a procedure if ST changes seen. Now, if you ask me from what the students could recall, actually all the 4 are correct. If you look at the post-cardiac arrest algorithm, when the patient have come back with a spontaneous circulation, you will find that when you speak of ventilation, saturation is to be maintained between 94 to 98, which is correct. Hemodynamic parameters, mean arterial pressure should be more than 65, which is correct. All right. They're doing other investigations also. A temperature control is maintained between 32 to 36. Induced hypothermia is one of the things. I'm not denying. So induced hypothermia also is included many a times. And the fourth point is, if there is evidence of ST elevation when you're doing an ECG, it's been said do a ECG also when the cardiac arrest patient has come back to normal. Do a 12-lead ECG. And in case you find ST elevation, you are supposed to shift the patient for angiography. So therefore, if you ask me, guys, so even this answer, transfer the patient for an angiography procedure, if ST elevation is seen, that may also be correct. So there may be something wrong in the sense that this may be ST inversion or something like that. I'm not very sure if this was given or not. But this question, maybe they will come back later with a proper reconstruction if, when we're doing a proper recall, which we normally do with all the questions. But according to me, if these are the 4 options, maintenance of hypothermia is not wrong. SpO2 more than 94 is fine. Mean arterial pressure more than 65 is fine. And transfer the patient for angiography is also correct if there is ST elevation. So maybe there is some change in the sort of option. You guys can correct me. Yes, guys? Anyone remembers this question? Till now, I think most of the things were fine. But in this question, anyone would like to correct me or add to it? Yes? Anyone? I can't see the options. Chat options. Okay, so maybe we'll put, when we are coming back again, then we'll have those options. But right now, I did not get options from anyone. Right. So that was the last question from anesthesia. Okay. So according to me, there has to be some changes in the options which are there. Only then we can frame this question and these 4 options correctly. So there we go. Thank you, guys. And if there's anything you can put down on the comment box for us. Right. Rishabh, sir.
Thank you, Vinish, sir.
Over to you, sir.
Thank you, sir. Thank you. Now we'll move on to pharmacology. We have Siraj sir discussing the pharma questions. Quite a lot of questions in pharma, sir. Some one-liner.
Hi, sir. I hope I am visible now.
Yes, sir. You're visible. You're audible, sir.
Everything is fine, right?
Yes, sir. So tell us, sir, how was the paper?
Sir, the paper I saw, it's pretty basic. Just a minute. I think I need to just attach a charger. Just a minute, please.
Yes, sir. Yes.
Sir, I hope I am audible, visible again.
Yes, sir. Yes, sir. You're audible.
Okay. So paper, sir, was pretty basic. और 2-3 चीजें ऐसी थी जो ऐसा लगा कि एग्जामिनर nowadays is very fond of Goodman-Gilman. Goodman-Gilman को उठाया, उनके पैराग्राफ को लिया और उनके पैराग्राफ से डायरेक्टली थोड़ा बहुत चेंजेस करके क्वेश्चन फ्रेम कर दिए. टू द पॉइंट. अभी मेरे पास कुछ स्क्रीनशॉट भी हैं, बुक्स के भी और अपने लेक्चर्स के भी. बच्चों को दिखाएंगे हम लोग कि हाउ एग्जामिनर इज फॉन्ड ऑफ आस्किंग डिटेल्ड क्वेश्चन. एंड जैसे कि INICET में हमेशा होता है, जो INICET है उसमें जो कुछ एग्जामिनर जो PGI चंडीगढ़ वाले हैं, we have seen their favorite part is always the monoclonal antibody, the newer anti-cancer drug. जो भी क्वेश्चन आए हुए हैं नए वाले, वो देख के पता चलता है कि दिस इज स्पेसिफिक ऑफ PGI चंडीगढ़ एंड एम्स लाइक पेपर. वो उनके बड़े स्पेसिफिक से रहते हैं, हमेशा से ही आए हुए हैं. पहले भी उनके क्वेश्चन हमने वो देखे हुए हैं. इनफैक्ट हम लोग की जो रेजिडेंसी की एग्जाम होती थी, सीनियर रेजिडेंसी की, तो वैसे पेपर आते थे. उस लेवल का भी कुछ क्वेश्चन हैं जो सीनियर रेजिडेंसी में आप PGI में जाते हो तो एक एंट्रेंस एग्जाम होता है, उस लेवल के भी कुछ क्वेश्चन डायरेक्टली आए हुए थे. ठीक है, तो आई थिंक अभी दिखा लेते हैं. आई थिंक हमारे पास 14-15 क्वेश्चन है फार्मा के. आई होप कि दिस ऑल 14-15 क्वेश्चन, मोस्ट ऑफ द क्वेश्चन डायरेक्टली नोट से ही हैं. एक आध क्वेश्चन डायरेक्टली जो बुक से हैं वो हम लोग बच्चों से डिस्कस कर लेंगे अभी.
ओवर टू यू, सर.
राइट. सो आई एम हैविंग द वेरी फर्स्ट क्वेश्चन इन अ हिस्ट्री ऑफ फंगल इन्फेक्शन टू नेल्स एंड विद द डायग्नोसिस ऑफ ओनिकोमाइकोसिस. ओनिकोमाइकोसिस का नाम ही है फंगल इन्फेक्शन टू द नेल्स, और उसमें पूछ रहा है कि विच ऑफ द फॉलोइंग कैन बी गिवन इन टॉपिकल. तो ओनिकोमाइकोसिस के लिए ये हमने एक नेल लेकर फॉर्मुलेशन के लिए एक नेमोनिक दिया है, C8 इज द नेमोनिक. ये हमारे लेक्चर का स्क्रीनशॉट है जिसमें साइक्लोपैरोक्स, कैनिस्टैन, फिनाकोनाजोल, amorolfine, tavaborole. So tavaborole is one of the protein synthesis inhibitor that can also be utilized for your onychomycosis, right? However, if the examiner is going to ask you the drug of choice for onychomycosis, drug of choice, it is going to be a terbinafine. But here they are asking which is the preparation that is available. Now ये preparation वाला question पहले भी एम्स में INICET में आ चुका है. ठीक है, so this was the first question. The drug of choice of fasciola hepatica, once again we have fasciola hepatica, liver fluke, that is liver fluke caused by your fasciola hepatica, and fasciola hepatica लिए drug of choice is triclabendazole. Again very basic question. All MBBS student, MBBS में तो बच्चों को रटवा दिया जाता है कि fasciola hepatica liver है, liver toxicity handle करता है triclabendazole, right? Next question regarding fosphenytoin. Now this is something that is directly taken from AIIMS का textbook, Goodman-Gilman का textbook, and typical of AIIMS question. Now if you see, fosphenytoin is given to all seizure patient in ER irrespective of CNS side effect and hypertension. Safe dose is 250 ml per minute. Now see here, this is the Goodman-Gilman का screenshot. They are giving that if you are going to give fosphenytoin, which is water soluble one, they will be having a lot of side effect, including arrhythmias, hypotension, CNS depression. So अगर पेशेंट को ऑलरेडी चल रहा है तो यू शुड अवॉइड, डेफिनेटली शुड नॉट गिव. अगला बोल रहा है कि द कॉम्प्लिकेशन कैन बी मिनिमाइज्ड बाय एडमिनिस्टरिंग द रेट लेस देन 150 इक्विवेलेंट्स पर मिनट, आपको इससे कम में देना है 150। यहां पे बोला सेफ इज 250, नहीं, सेफ इसका आधा है, ठीक है। नेक्स्ट इट इज सेइंग दैट एक्यूट ओरल डोसेज primarily leads to cerebellar and vestibular symptom and can be associated with cerebral atrophy. डायरेक्टली क्वेश्चन जैसे कि मैंने बताया गुडमैन गिलमैन से उठा करके इसको पेस्ट कर दिया गया आपके लिए। देखिए, मैक्सिमम ओरल डोज causes cerebellar and vestibular symptom and high doses can lead to cerebral atrophy. So you have to find out a correct statement. This is the only one that is correct. High dose can cause cardiotoxicity. Yes, in older population it can cause cardiotoxicity, but they have not mentioned anywhere that it is causing nephrotoxicity. Rather, it is having a lot of hepatotoxicity. Liver enzymes are getting altered. Right? Look at this. Although the cardiotoxicity occur more frequently in older people. एक एक जैसे ऑप्शन नंबर ये हो गया, एक ऑप्शन ये हो गया, एक ऑप्शन ये हो गया, एक ऑप्शन ये हो गया, चारों ऑप्शन एक ही बुक से उठाया और बुक से उठा के चारों ऑप्शन पेश कर दिया। तो टेक्स्ट बुक का उठाया हुआ क्वेश्चन है, ये देख के लग रहा है, ठीक है, प्रीवियस ईयर नहीं है, एंड दिस इज द वेरी फर्स्ट टाइम दे हैव आस्क्ड दिस क्वेश्चन। Next is false about thiopentone. We have read it a couple of times. Thiopentone having high redistribution. So you have to find out a false statement. Lipid soluble है. Redistributed definitely to the adipocyte and muscle. Initially जब दोगे तो it will be giving to highly vascular area like brain. And it has low duration of action because maximally excreted by kidney. See, duration of action is definitely going to be short, but that is not because they are renally excreted, because they are highly lipid soluble. They show a phenomena known as your redistribution. ये कौन सा फिनोमेना शो करते हैं? redistribution. तो redistribution में देखिए, ये स्क्रीनशॉट हमारे लेक्चर का है जो हम लोग ऐप में दे रखे हैं ऑलरेडी और लाइव क्लास में भी डिस्कस किए हैं। रीडिस्ट्रीब्यूशन थायोपेंटोन सोडियम जो आपने दिया ब्रेन में तो गया, concentration maximum हुआ, but from here it will be redistributed to the more bulky tissues or the one that is having lesser blood supply. So it will be redistributed and it will stay there to the adipocyte and the muscle. So the termination of action is not because of renal excretion, but because of the redistribution. That is about your thiopentone. Pharmacokinetics में redistribution में भी have discussed. Now this was volume of distribution का to the point question. Digoxin दिया गया, 46-year-old female was put on digoxin. The volume of distribution दिया गया 6 liter. Clearance has been given that is going to be 4.6 liter per hour. Now they are asking what is the half-life. Now what is the formula for half-life? Formula for half-life has been given here already, 0.693, और बार-बार हम लोग बोलते हैं कि you can multiply with the 0.7. So you can take it like this, 0.7 into volume of distribution, that is going to be 6 liter, and clearance that we know, clearance is going to be 4.6. तो अगर आप इसको सॉल्व करोगे, सॉल्व करके देखिए 0.7 into 6, 4.6, right? Let us see. We are going to get a value that is known as 0.9. 0.9 के आसपास हमको जो वैल्यू मिलेगा, that is going to be the half life. That is going to be the half life of this one. अगर वैल्यू यही था, if they are going to get this value, तो we are having 0.7. Let me just collect 0.7. एक बार आपके सामने कर लेते हैं, 0.7 into 6 and divided by 4.6. So given these values that we have, it is coming 0.9. So 0.9 will be the correct answer for a question like this. आपको सिर्फ इसमें क्या करना है, वैल्यू को पुट कर देना है, and then you are going to get the answer immediately. ठीक है? Which of the following is not given in uncomplicated malaria? Yeah, which of the following? All of the following will be given in uncomplicated malaria except हो या not given. Uncomplicated malaria. Now, when they say uncomplicated malaria, always remember they are talking about something that is, let's say, not very severe, like a cerebral malaria, right? Not given. Artemether lumefantrine हम देते हैं ना, artemether plus lumefantrine we used to give in someone coming from north state. Primaquine, देखिए primaquine यहाँ पे मैंने शो किया, एक ही स्क्रीनशॉट डाला, हालांकि डिटेल डिस्कशन वीडियो लेक्चर्स में है। Primaquine, tafenoquine इसी का congener है, that is having hepatic schizonticides. So they are mainly utilized for the hypnozoid stage of the your Vivax and OL, and they are also having gametocytic property. So primaquine is something that can be added depending on the patient situation. So not every physician will be adding this one. अगर आप देखोगे Lumet 80 जो आता है उसमें lumefantrine, artemether, lumefantrine ये वाले जो कॉम्बिनेशन आते हैं, among the given choices अगर मैं देखूं तो नॉर्थ ईस्ट स्टेट वाला पेशेंट जो आता है उसको देते हैं artemether, lumefantrine, and we are having rest of the India. अगर ये क्वेश्चन आया था और एक आपको सेलेक्ट करना है रेस्ट ऑफ द इंडिया, तो वी गिव artesunate, sulfadoxine, pyrimethamine. Chloroquine is something definitely can be given for uncomplicated malaria, but इन दोनों के साथ एक चीज ध्यान रखिएगा, बार बार बताया जाता है कि फॉर द गैमेटोसिटिक प्रॉपर्टी सिंगल डोज ऑफ प्राइमाक्विन इज गिवन. गैमेटोसिटिक प्रॉपर्टी के लिए सिंगल डोज ऑफ प्राइमाक्विन इज गिवन ऑन डे 2. बट गिवन द चॉइस, अगर यही चॉइस था, यही आंसर था, यही ऑप्शन थे सारे, देन विल गो विद द primaquine. Primaquine is having gametocytic property. Mainly, we are going to utilize in Vivax oil for a duration of 2 weeks. Given these options, we will go with the B. Now here, which of the following matching with the receptor? So you can consider this as a physio pharma because हम लोग इसको general pharma में भी consider करते हैं, and we used to discuss like Janus kinase वाले कौन से हैं, right? Janus kinase वाले, right? So tyrosine kinase, that is enzymatic receptor. All of them have been discussed here. Okay. Other type of receptor like nuclear, cytoplasmic. So this I have already arranged. Nuclear receptor, thyroid, it's already mentioned here. Nucleus में मैंने बताया था, trap हो जाता है, nucleus में trap हो जाता है. Thyroid, retinoic acid, aryl hydrocarbon receptor, PPAR, ion channel acetylcholine, ion channel receptor that we know, acetylcholine, they will be acting by ion channel. Okay? Then tyrosine kinase, enzymatic receptor, insulin, JAK-STAT, growth hormone. So everything has been mentioned in the order. So this is the correct order already. आपके एग्जाम में ऊपर नीचे करके आया हुआ था, but we have already corrected, we have already arranged them in the enzymatic receptor के form. ठीक है? And other receptor, जो भी है receptor के order में we have already given. Which of the following anti-epileptic drug molecule modulate voltage gated sodium channel? Now this is also exact line ये book का है. देखिए क्या word बोला है? Anti-epileptic drug modulate voltage gated sodium channel and enhances the slow inactivation. मतलब जो inactive state में चला गया तो inactive से activation में आने में उसको time लगे. Name of the drug here is lacosamide. लैक्मे वाला क्रीम मैं बताता हूं आपको. लैक्मे वाला क्रीम तो CRMP प्रोटीन इनहिबिटर तो है, but their main mechanism of action is they are going to modulate the voltage into sodium channel. They block sodium channel and they inhibit the activation rapidly. So look at this. Directly ये book का question है. ये Goodman Gilman का screenshot है. It is the first anti-seizure drug that is enhancing the slow inactivation of voltage into sodium channel. देखिए डायरेक्ट टेक्स्ट बुक से उठा के दे दिया गया क्वेश्चन ये. ठीक है. सो लेकोसामाइड मैं पिछली बार भी बोल रहा था कि लेकोसामाइड न्यू ड्रग है आएगा. इस बार रैपिडली लकीली दे हैव आस्क्ड दिस वन. डुअल मैकेनिज्म ऑफ एक्शन है. दे आल्सो हैव CRMP प्रोटीन इनहिबिटिंग प्रॉपर्टी. ठीक है. Which of the following drug act by binding with the CD4 receptor and can be used in both CCR5, CXCR4 tropic HIV virus? So again, simply asking CD4 cell receptor. So CD4 cell receptor inhibitor HIV lecture में we have already discussed this. CD4 cell receptor only for HIV1 is ibalizumab, right? CD4 HIV1 के लिए we have discussed it already. So the correct answer for this one is ibalizumab, right? Ibalizumab. Now, if you are going to look at Maraviroc, so that is already given here. They are going to be CCR5 and enfuvertide GP41. They are the infusion or I would say fusion inhibitor. Animal fusion inhibitor. Okay. So everything has been discussed here. Already taken. This screenshot has been shown here. Ibalizumab is the correct answer. That is having CD4 cell receptor inhibitor. Next question, which of the following lead to fall in the diastolic blood pressure? Now ये ANS में कई जगह पे अलग-अलग जगह पे डिस्कस किया हुआ है और बहुत क्लियरली डिस्कस किया हुआ है. तो उनके इतने सारे स्क्रीनशॉट मैंने यहाँ पे नहीं लगाया. सिंपली आपको बताया fall in diastolic blood pressure और इसमें मल्टीपल करेक्ट था. अकॉर्डिंग टू स्टूडेंट दिस सेड ये सर मल्टीपल करेक्ट आंसर सही थे. इसमें लॉस ऑफ सिंपैथेटिक आउटफ्लो, यस लॉस ऑफ सिंपैथेटिक ड्राइव जिसके वजह से देयर विल बी फॉल इन द diastolic blood pressure. Definitely that's correct. beta 1 is not present on the blood vessel. However beta 2 agonist अगर होता तो they would cause vasodilatation and they would cause the fall in the blood pressure. Alpha blockade will also cause vasodilatation and they can also lead to fall in the blood pressure. So इसमें दो होगा A and C. Because there is multiple correct choices, you are going to go with the A and C. Beta 2 agonist होता है, beta 2 antagonist नहीं होता है. Beta 2 agonist होता है, antagonist नहीं होता है. अगर किसी भी पॉइंट पे आपको लगता है कि सर ये क्वेश्चन का ऑप्शन थोड़े बहुत अल्टरेशन रिक्वायर्ड है या कुछ एडिटिंग कराना है, फील फ्री टू मैसेज इन द कमेंट सेक्शन. मैं आपके कमेंट सेक्शन को कंटिन्यूअसली मॉनिटर कर रहा हूं. राइट. सो दिस वाज आल्सो वन ऑफ द क्वेश्चन मल्टीपल करेक्ट वाले में. Which of the following is true regarding pretomanid? Delamanid, pretomanid बताया था, manid and manid वाले, right? एग्जाम से पहले भी हमने जो सेशन लिया था उसमें बताया था manid and manid. So they are the mycolic acid synthase inhibitor. They develop mycolic acid synthase inhibitor, manid and manid. ठीक है. तो पूछ रहा है which of the following is true regarding pretomanid? Contraindicated with CYP2C inducers. Can be used in resistant malaria के लिए तो नहीं है ये. Approved for XDR-TB. With bedaquiline and linezolid. Yes. So they are the one that is approved for XDR-TB and they are actually utilized with the bedaquiline and linezolid. So B-Pol regimen. ये जब लेक्चर रिकॉर्ड हुआ तो उसमें B-Pol regimen था. Very recently गवर्नमेंट ऑफ इंडिया ने इसमें एक और चीज ऐड किया जिसको बोलते हैं B-Palm regimen. उसमें moxifloxacin ऐड किया है. Moxifloxacin has been added here. उसको B-Palm कर दिया, बट अभी के लिए B-Pol regimen है. So pretomanid they have already been approved, right, for IPD patient because there are two drugs that is causing cardiotoxicity. आपका बेटाक्विलिन भी करता है और आपका प्रिटोमिनेट भी QT प्रोलॉन्गेशन करता है, राइट? सो यूजुअली मॉनिटरिंग इज वेरी रिक्वायर्ड, वेरी मच रिक्वायर्ड. ड्रग एक्टिंग ऑन द मार्क्ड साइड. अब ये इमेज जो आया हुआ था, ये ऐसे इमेज आया हुआ था, गैट 1 को इनहिबिट करके काम करने वाले ड्रग, और ये आपके लेक्चर का स्क्रीनशॉट है. देखिए ये गैट 1, ये हमारा प्रीसिनेप्टिक न्यूरॉन है गाबा का. देयर इज अ गैट 1 को इनहिबिटर कौन कर रहा है? दैट इज गोइंग टू बी योर टियागाबीन. बहुत आसानी से बोलता हूं, ट्रांसपोर्ट इनहिबिटर ऑफ अ गाबा इनसाइड. ये अंदर नहीं जाने देगा. फिर से देखिएगा, ट्रांसपोर्ट इनहिबिटर ऑफ अ गाबा इनसाइड, अंदर नहीं जाने देता गाबा को, तो गाबा का रीअपटेक इनहिबिटर. व्हाट इज द नेम ऑफ द ड्रग? दैट इज गोइंग टू बी टियागाबीन. रेटिगाबीन, इजोगाबीन, they are the potassium channel opener. Usually they are causing, retinal pigmentation, skin and eye pigmentation, so not very commonly utilized. Ganoxolone is new drug that is utilized for infantile spasm. Along with valproate, along with ACTH, we are going to give them in the infantile spasm. मैं बोलता हूँ infant है ना, इन्फेंट गाना गाता है एलोन, गैनोक्सोलोन गाना गाता है एलोन. वेल्प्रोएट तो है नहीं, बिकॉज वेल्प्रोएट कहाँ काम करेगा? अगर इसी इमेज में, यही इमेज पहले भी आया हुआ था, उसमें क्या किया था पहले वाले में? दे हैव गिवन द एरो चेंज कर दिया था. दे हैव गिवन द एरो यहाँ पे सक्सिनिक सेमीएल्डिहाइड और दूसरा था गाबा ट्रांसअमाइनेज. पिछले एग्जाम का पेपर उठा के देखिएगा, इसी इमेज में इन्होंने चेंज किया और पूछा था यहाँ पे कौन सा ड्रग काम करेगा. तो यहाँ पे जो ड्रग काम करता है दैट इज गोइंग टू बी वेल्प्रोएट. बट अगर ओनली गाबा ट्रांसअमाइनेज देता है, ओनली गाबा ट्रांसअमाइनेज, देन द आंसर विल बी योर विगाबैट्रिन. देन द आंसर विल चेंज टू विगाबैट्रिन. ठीक है, आंसर इज गोइंग टू चेंज टू विगाबैट्रिन व्हिच इज गाबा ट्रांसअमाइनेज इनहिबिटर. बट दोनों होगा गाबा ट्रांसअमाइनेज एंड सक्सिनिक सेमीएल्डिहाइड डिहाइड्रोजिनेज, देन दैट इज गोइंग टू बी योर वेल्प्रोएट. सो आई थिंक ऑल ऑप्शंस आर सॉर्टेड हियर. एंटीडोट मैच्ड, कई जगह पे हमने डिस्कस किया इंपॉर्टेंट एंटीडोट्स. करेक्ट मैचिंग जो है वो हमारे पास कौन सा है? जो द वन व्हिच इज करेक्ट मैचिंग इज गोइंग टू बी बेंजोडाज़ेपिन, जिसका है फ्लूमाजिन. बाकी बार्बिट्रेट का कोई एंटीडोट है नहीं, तो बार्बिट्रेट के लिए वी डू फोर्स्ड अल्कलाइन डायूरेसिस. ठीक है, ये जो हमने स्क्रीनशॉट लिया हुआ है, ये देखिए आपका इसमें भी होगा. कॉपर ऑर्गेनोफॉस्फेट भी, आई थिंक ये भी कई बच्चे बोल रहे थे आया हुआ था. ठीक है, देन डिजॉक्सिन का डीजी बाइंड होता है, ये भी देखिए ऑप्शन में था, राइट. बेंजोडाज़ेपिन का देखिए बेंजोडाज़ेपिन फ्लूमाजिनिल, राइट. बेंजोडाज़ेपिन फ्लूमाजिनिल ये रहा, राइट. सो बेंजोडाज़ेपिन फ्लूमाजिनिल, ये टेबल हमारे पास है, 2 स्लाइड का टेबल है. डेफिनेटली वी हैव डिस्कस दिस ऑलरेडी. सो अगेन ये है. डिजॉक्सिन का क्या ऑप्शन में था? अगर आपको याद आ जाए तो बता दीजिएगा. अगेन दैट वाज नॉट डीजी बाइंड ऑप्शन में नहीं था बिकॉज उसका डीजी बाइंड एंटीडोट होता है. Which of the following JAK-STAT inhibitor approved for ulcerative colitis for a patient who is intolerant to anti-TNF drug? एंटी-TNF अल्फा इनहिबिटर. अगर TNF अल्फा इनहिबिटर से रेजिस्टेंट है तो टायरोसिन काइनेज इनहिबिटर, जैनस काइनेज इनहिबिटर हमारे पास है. देखिए बेरिसाइटिनिब, टोफासाइटिनिब, तो दीज आर द वन, दीज टू दैट हैज अप्रूव्ड फॉर रूमेटॉइड आर्थराइटिस एंड इन्फ्लेमेटरी बाउल डिजीज. तो हमारे पास जो साइटिनिब वाले हैं, टोफासाइटिनिब, इट्स अ वेरी कॉमनली यूज्ड ड्रग एज वेल, राइट. टोफासाइटिनिब वेरी कॉमनली यूटिलाइज्ड ड्रग, रिमेंबर दैट, राइट. नाउ एरेनुमाब, ये तो CGRP एंटागोनिस्ट है, राइट. मैंने बताया भी था एरेनुमाब, EFG, एरेनुमाब, एप्टिनिजुमाब, फ्रेमानिजुमाब, गैल्कानिजुमाब, they are CGRP antagonists utilized for the prophylaxis of migraine. Ustekinumab, interleukin 12 and 23 inhibitor, utilized for your inflammatory bowel disease and also for the chronic plaque psoriasis. ठीक है. Vorinostat, belinostat, they are the histone deacetylase inhibitor. They are not one of the agent that is going to be utilized, and that they do not act by JAK-STAT. JAK-STAT वाले जो निब वाले होंगे, टोफासाइटिनिब, बेरिसाइटिनिब. ठीक है, that is also sorted. PARP, poly-ADP ribose, right. PARP, poly-ADP ribose, ये देखिए, ये टिपिकल आपके PGI चंडीगढ़ का है बिकॉज PGI चंडीगढ़ मल्टीपल टाइम ये क्वेश्चन पहले भी पूछा हुआ है. ठीक है. नाउ प्रोटियाजोम, प्रोटीन, ज़ोंबी खाते हैं प्रोटीन, ज़ोंबी मल्टीपल नंबर में आते हैं, तो मल्टीपल माइलोमा का ड्रग ऑफ चॉइस. पॉली-ADP राइबोस, ये सब आते हैं पेरिब, ओला पेरिब, रुका पेरिब, नीरा पेरिब. तो मैं क्या बोलता हूँ, ओला वाला रुक नहीं रहा, ओला वाला है ओवेरियन कैंसर के लिए वी कैन यूटिलाइज, राइट. ब्रेस्ट कैंसर के लिए भी ऑल्सो वी कैन यूटिलाइज, रिमेंबर. सो दीज आर द वन that is correct answer for this one, poly-ADP ribose, that is going to be your rucaparib. Palbociclib, cyclin dependent kinase, CDK inhibitors, 4 and 6 inhibitor. Bortez में zombie वाले हैं, ये कौन सा है? प्रोटियाजोम इनहिबिटर, जो यहाँ पे दिया हुआ ऑलरेडी. Vemurafenib, right, they are the tyrosine kinase inhibitor, right. They are not the one that is utilized, they are not the one that is PARP inhibitor. ठीक है. मैच द फॉलोइंग। आई थिंक ये एंटीडोट पे 2 क्वेश्चन आए थे मैचिंग टाइप, तो मैचिंग टाइप है तो यहाँ पे कर लेते हैं तुरंत इमीडिएटली, बिकॉज ABCD ऑप्शन में था, तो मैचिंग टाइप इमीडिएटली करते हैं। स्मोकिंग के लिए क्या यूज करते हैं? वेरेनिक्लीन। निकोटीन को क्लीन कर देता है वेरेनिक्लीन, तो आई थिंक ये हो गया ए का हमारे पास क्या हो जाएगा, नंबर 2। फिर अगला क्या आ जाए, ओपियोइड नैलोक्सोन, सबसे आसान तो यही है, सबको पता होता है, ओपियोइड नैलोक्सोन। डेलिरियम ट्रेमेंस, डेलिरियम ट्रेमेंस के लिए डायजेपाम्स, राइट, तो ऑक्साजिपाम हमारे पास है, दैट इज सी का, देयर विल बी सी का, वी आर गोइंग टू गिव 3। And last, acute alcoholism. So acamprosate, they will decrease the craving behavior. So craving के लिए we have naltrexone, acamprosate, topiramate and ondansetron. Craving को कम करने के लिए we are having D का number 4. So correct, ये हमारे जो भी है ऑर्डर मैंने यहाँ लिख दिया, ये correct आंसर है। तो जिसमें ये मैच हो रहा था, that was going to be the correct one. I hope all of you guys have got this one right, correct as well. नाउ ये भी सारे जितने भी हैं हमने डिस्कस किए, बिकॉज ये अलग अलग चैप्टर में डिस्कस हुए, सबके स्क्रीनशॉट को नहीं रख सकते। जैसे ओपियोइड अलग डिस्कस हुआ, लेकिन सबके एंटीडोट को भी एक जगह लिखा हुआ है। डेलिरियम ट्रेमेंस, अल्कोहलिज्म, स्मोकिंग, एवरीथिंग हैज बीन डिस्कस्ड इन डिफरेंट पार्ट्स, सो उसका सबका स्क्रीनशॉट यहाँ पे लगा पाना मुश्किल है, बट इट हैज बीन गिवन ऑलरेडी इन आवर लेक्चर्स। ठीक है, अ पेशेंट विद हिस्ट्री ऑफ MI ऑन स्टैटिन थेरेपी, तो मान लीजिए एटोरवास्टैटिन, रोजुवास्टैटिन, जो भी स्टैटिन ले रहा है, विच इज वन ऑफ द HMG कोरिलेक्टेज इनहिबिटर, एस्पिरिन, थ्रोम्बोक्सिनेटिव इनहिबिटर एंड मेटोप्रोल, दैट इज कार्डियोसेलेक्टिव बीटा ब्लॉकर। लिपिड है HDL ठीक है, नॉर्मल है। ट्राइग्लिसराइड ठीक है, ये भी नॉर्मल है, बिकॉज बिलो 150 वी हैव टू कीप ऑलवेज। ठीक है, कोलेस्टेरॉल वी हैव टू कीप बिलो 200, बट थोड़ा सा बढ़ा हुआ है। HMG कोरिलेक्टेज इनहिबिटर ऑलरेडी ले रहा है, बोल रहा है विच ऑफ द फॉलोइंग विल बी एडेड टू द प्रेजेंट रेजिमेंट। अच्छा, कौन कौन सा ऐड कर सकते हैं, कौन कौन सा ऐड, ऐसा नहीं कि ऐड करना ही है, विच ऑफ द फॉलोइंग इज रिकमेंडेड। जेम फाइब्रोजिल, मैं बोलता हूं क्या, PPAR अल्फा, so there is a Fa and then there is a Phi. Fa-Phi, that is going to be fibrate. So Fa-Phi is utilized mainly for hypertriglyceridemia because they increase the level of lipoprotein lipase and they are utilized mainly for hypertriglyceridemia. Now आपका triglyceride level तो बढ़ा नहीं है, बाकी जो चीजें हैं जैसे एजेटिमाइब, इजी पीजी ड्रग, मैं बोलता हूँ ये कोलेस्ट्रॉल को एब्जॉर्ब नहीं होने देता है बाय इनहिबिटिंग NPC1L1, इजी पीजी ड्रग है, राइट, इजी पीजी ड्रग है। बेम्पिडोइक एसिड, ACL इनहिबिटर, दैट इज आल्सो इनहिबिटिंग द कोलेस्ट्रॉल सिंथेसिस। जेम फाइब्रोजिल, अच्छा जेम फाइब्रोजिल 2 जगह आ गया ना, जेम फाइब्रोजिल 2 जगह आ गया, तो हमारे पास जो भी ऑप्शन है यहाँ पे जेम फाइब्रोजिल नहीं होगा। आई थिंक आप लोग को हेल्प करना पड़ेगा यहाँ पे, एक और ड्रग यहाँ पे हो सकता है, बिकॉज जेम फाइब्रोजिल 2 जगह पे नहीं होगा, ऊपर ऑलरेडी जेम फाइब्रोजिल है, तो वी हैव 2 and 3, 2 and 3 को तो यूज कर सकते हैं, 2 and 3 को यूज कर सकते हैं। यहाँ पे एक और ड्रग, अगर ड्रग आपको याद हो रहा है तो बता दीजिए, और नहीं तो विल गो अहेड विद जस्ट 2 and 3। अगर अगला ड्रग अगर ऑप्शन याद आ रहा है तो आप बता सकते हैं, उसके अकॉर्डिंग वी कैन मॉड्यूलेट, बिकॉज दीज ऑप्शंस आर फ्रेम्ड अकॉर्डिंग टू, ऊपर नीचे हो सकता है आपके एग्जाम में, ऊपर नीचे हो सकता है। जेम फाइब्रोजिल 2 नंबर पे हो सकता है, एजेटिमाइब 1 नंबर पे हो सकता है, राइट। सो 4th ऑप्शन अगर आपको इसमें याद आ रहा है कौन सा अगला ड्रग था, तो यू कैन टेल अस। अदर देन दैट 2 और 3 है, अगर 2 3 होगा तो विल जस्ट कंसिडर दिस वन, दैट 2 and 3 आर गोइंग टू बी करेक्ट, 2 and 3 आर गोइंग टू बी करेक्ट। अगर यही दोनों अगर आपको याद आ रहा है तो उस कंडीशन में 2 और 3 होगा। अगर एक ऑप्शन याद आ रहा है तो प्लीज कमेंट इन द कमेंट सेक्शन, राइट। सो दिस वाज अबाउट द क्वेश्चन। एक बार क्विकली 60 सेकंड में रिकैप करेंगे। हमारे पास डिसलिपिडेमिया का पेशेंट है, उस पेशेंट को हमारे कोलेस्ट्रॉल के लिए वी कैन यूज एजेटिमाइब, बेम्पिडोइक एसिड। देन वी आर हैविंग मैच द कॉलम, इंपॉर्टेंट एंटीडोट, सबके एंटीडोट को यहाँ पे मैच करके यहाँ पे बता दिया गया है। PARP पॉली एडीपी राइबोस, पेरिब वाले ड्रग है, ये टिपिकल ऑफ आपके INICET वाले हैं और PGI चंडीगढ़। जैकस्टैट, टोफासाइटिनिब, एरेनुमा, बाकी सारे ऑप्शन को रूल आउट किया गया यहाँ पे। एंटीडोट मैच्ड करेक्टली, द वन दैट विच इज करेक्टली मैच इज गोइंग टू बी बेंजोडाइजेपिन, बाकी सब करेक्टली मैच नहीं है। एट्रोपिन के लिए हमारे पास एंटीडोट जो होता है दैट इज गोइंग टू बी फाइसोस्टिग्मिन, इसके लिए जो होता है दैट इज गोइंग टू बी फाइसोस्टिग्मिन, तो इट इज नॉट करेक्टली मैच्ड, करेक्टली मैच इज ओनली ऑप्शन A। मार्क्ड साइट, दैट इज GAT1 ट्रांसपोर्ट इनहिबिटर ऑफ द GABA इंसाइड, थियाकाबिन। प्रिटोमेनिड, मेनिड माइकोलिक एसिड सिंथेसिस यूज्ड फॉर XDR-TB, प्री XDR-TB, बेटाक्विलिन और लाइनोजुलेट के साथ देते हैं। Which of the following can lead to diastolic blood pressure का fall? That is going to be your alpha blockade, this one, and also your loss of sympathetic drive. Other options cannot. CD4 inhibitor, recent drug, CD4 cell inhibitor, that is going to be ibalizumab, already has been mentioned here. Screenshot has been attached here as well. Okay. Then lacosamide वाला drug, again as I told you, lacosamide directly आपके book का है, lacosamide, they inhibit the, or they slow down the activation of the inactive voltage related sodium channel. This is already receptor से already लिया गया. Screenshot has been attached. Nuclear receptor किससे काम कर रहा है? Ion channel, acetylcholine, tyrosine kinase, insulin और JAK-STAT growth hormone already has been marked as it is. Primaquine again among the given choices. ऐसा नहीं कि primaquine use नहीं करते. It is used single dose on day 2, but among the given choices, primaquine is the one that is least preferred, or I would say most preferred answer, least preferred drug and most preferred answer for this question like this. डिजॉक्सिन का वॉल्यूम ऑफ डिस्ट्रीब्यूशन आई थिंक डायरेक्टली फॉर्मूला पे आपको वैल्यू पुट करना है एंड देन यू विल बी गेटिंग द आंसर ऑलरेडी. ठीक है. फॉल्स अबाउट द थायोपेंटोन. तो थायोपेंटोन का जो हाफ लाइफ कम है जस्ट बिकॉज ऑफ द रैपिड रीडिस्ट्रीब्यूशन एंड दिस इज अगेन फॉस्फेनेटोइन से रिलेटेड. जैसे मैंने एबीसीडी ऑप्शन बुक से उठा के दे दिया इन्होंने, थोड़ा बहुत चेंजेस करके. द करेक्ट आंसर हियर इज गोइंग टू बी हाई डोज में इट कैन कॉज सेरेब्रल एट्रोफी. फैसियोला हिपैटिका ट्राइक्लोबेंडाजोल बीइंग द ड्रग ऑफ चॉइस. नेल के लिए और नेल इन्फेक्शन ओनिकोमाइकोसिस के लिए द वन दैट इज अवेलेबल बाय द नेल लेकर, नेल पेंट के फॉर्म में है, दैट इज गोइंग टू टावरोल एंड दीज आर द अदर ड्रग्स. C8 निमोनिक से हमने याद किया है कि दीज आर द अदर ड्रग्स दैट इज अवेलेबल एज अ नेल लेकर formulation, right? So this was everything in pharmacology. Very quickly we have covered pharmacology.
Thank you, sir.
Rishabh sir, over to you. I hope
Yes.
the pharma is done.
Yes, sir. Yes, sir. Lot of recent advances, lot of anti-cancer drugs, typical
Yes,
of
newer
INICET.
drugs they have asked. Yes,
Yes, sir. Typical of an INICET paper.
right.
You know, such paper makes you think that यार फार्मा पढ़नी कितनी है, क्योंकि अगर न्यू ड्रग से ही 3-4 क्वेश्चंस आने हैं और
नहीं सर,
बाकी
ये बहुत कॉमनली यूज है. जितने भी रिव्यू क्लासेस हम लोगों ने कंडक्ट किए हैं उन सारे रिव्यू क्लासेस में इन सब का जिक्र है. यूट्यूब में ऑलरेडी पढ़ा हुआ, बहुत सारे बच्चे चाहें तो इसको देख सकते हैं आराम से.
yes, sir.
वेरी फ्रिक्वेंटली डिस्कस्ड ड्रग्स, बिकॉज न्यू ड्रग्स है तो इनको पढ़ाते ही पढ़ाते हैं. एक टेबल में पढ़ाते हैं, उन्हीं में से 3-4 क्वेश्चन तो सिर्फ एक टेबल से आया हुआ है, जो टेबल हमने
एग्जैक्टली
डिस्कस
सर.
किया
वो
था.
न्यू ड्रग टेबल्स हम अपने टाइम पर भी एकदम लास्ट डे पहले एक बार पढ़ के जाते थे कि यार इसमें से तो एक तो क्वेश्चन आने ही आने हैं.
राइट राइट.
Thank you, sir. Now we'll
Thank you, sir.
move on
Thank
to
you very much.
pediatrics. Over to you, Sharad sir.
Hi. Thank you, Siraj and Rishabh. As far as pediatrics questions are concerned, it is pretty easy. Not up to the standards of INICET. They are all basic questions. I don't think there are any points with respect to getting confused with yourself. Basically, it is a easy paper. Right. So what is the first question? The first question is the most common cause for croup in children is influenza, para-influenza, Haemophilus influenza, and Streptococcus pneumoniae. So what is the correct answer? Remember, any virus can produce. Any virus that can produce upper respiratory tract infection can produce croup. It can be an influenza, it can be a para-influenza, it can be a respiratory syncytial virus, it can be an adenovirus, it can be a COVID. Any other virus can produce croup syndrome. Bacterial unlikely to produce croup syndrome. So it cannot be Haemophilus influenza, it cannot be Streptococcus pneumoniae, it can be influenza or it can be para-influenza. But the question asked here is the most common cause of croup in children. The most common cause of croup in children, as you all know, it is para-influenza. Para-influenza is the most common cause for croup in children. Remember, any virus that produces upper respiratory tract infection can cause croup in children. Whatever it may be, the treatment is one and the same. A single dose of dexamethasone or a nebulized budesonide twice daily for 2 days or a oral prednisolone with or without a nebulized adrenaline is the treatment of choice. So as far as this question is concerned, para-influenza is the answer. That is the most common cause for croup in children. Let's go to the second question. All the following are live vaccines except. So option D is left out. If you have anyone who can offer the fourth option, I will be happy to include in that discussion. But basically, very, very simple to remember. Very, very simple to remember. You have BCG to start with, and you have an OPV, you have IPV, you have measles, mumps, rubella, as well as you have DPT, and then you have HIB, hepatitis B, as well as PCV. So these, and again, you can have JE vaccine. What else you can have? So these are all the vaccines that are available in our national immunization schedule. Of this, what are all the live vaccine? BCG is your live vaccine. Oral polio vaccine is a live vaccine. It is prone to produce vaccine-induced poliomyelitis, as a result of which it is going to be soon withdrawn from the immunization schedule, and it will be replaced completely by intradermal IPV. Okay, DPT, it is Toxoid. Haemophilus influenza is not a complete vaccine. Again, it is a subunit. Hepatitis B is a subunit. PCV is a conjugate vaccine. JE is a live vaccine. Your measles is a live vaccine. MMR is live vaccine. Rubella is live vaccine. Apart from that, which is not given here, one is hepatitis A. You have live as well as killed. And in varicella also, chickenpox also, you have live and killed vaccine. So these are all the vaccines that are available, that are live vaccine. So measles, definitely it is live vaccine. Measles, mumps, rubella, all are live vaccines, but in government we are giving only measles, one at 9 months and another at 15 to 18 months. Hepatitis B is a subunit vaccine. It is not a live vaccine. Varicella, you have both live as well as killed vaccine. Both are available in the market, but both of them are not available in national immunization schedule. Can anyone offer me what is the option D? So far, whether option is available or not, let me repeat. BCG is a live vaccine, OPV is a live vaccine. Measles, mumps, rubella, hepatitis A, as well as varicella, chickenpox are all live vaccine, and it is discussed in our video session, also in our app. So these are all the live vaccine: BCG, OPV, measles, mumps, rubella, varicella, rotavirus, yellow fever. These are all the live vaccines. This is discussed in our session in PW videos. And the previous question also, the most common cause for croup in children. Majority of them are viral. Your para-influenza is the most common cause for croup in children. Question number 3. All the following are manifestations of cystic fibrosis except. You all know that the majority of the manifestations of the cystic fibrosis are with respect to lung. So what are all the manifestations in the lung? In the lung, you can have bronchiectasis predominantly involving the upper lobe. There are 3 main differential diagnoses for upper lobe bronchiectasis. One is cystic fibrosis, second one is TB, third one is sarcoidosis. But what is the peculiar manifestations of cystic fibrosis in newborn? One, as you said, it can produce meconium ileus. Why? It can cause bleeding diathesis. Bleeding diathesis can occur because cystic fibrosis is a disease in which you have a pancreatic insufficiency. Whenever you have pancreatic insufficiency, your fat-soluble vitamins such as A, D, E, and K will be less absorbed. You all know that K is responsible for 2, 7, 9, 10. Okay, activation of 2, 7, 9, 10. So in cystic fibrosis, because of pancreatic insufficiency, vitamin K will not be available, as a result of which 2, 7, 9, 10 will be low in the body, leading to hemorrhagic disease of newborn. Classically, this hemorrhagic disease is otherwise called as late onset hemorrhagic disease of newborn. Late onset means usually it occurs after 1 week of birth. Late onset hemorrhagic disease of newborn. Apart from that, it will not produce biliary atresia. Instead, it produces neonatal cholestasis. It produces neonatal cholestasis. It doesn't produce biliary atresia. It produces neonatal cholestasis. Right. Okay, nasal polyp. Yes, it produces nasal polyp in adolescent kid, but not in young children. So nasal polyp can come. Meconium ileus as well as meconium perforation of the ileum is most common. Bleeding diathesis is due to the malabsorption involving vitamin K. It is not biliary atresia. It is neonatal cholestasis that can occur as a result of cystic fibrosis. Apart from that, what are all the things that were discussed in our video section in PW? Look at this. Meconium ileus was discussed. Neonatal cholestasis was discussed. Pancreatic insufficiency because of absence of absorption, because of absence of enzymes that digest your fat, you will get oily stools. Because of malabsorption, you can get failure to thrive. Predominantly, your fat-soluble vitamins A, D, E, K were not absorbed. And hemorrhagic disease of newborn is mainly due to vitamin K. Your rickets is mainly due to deficiency of absence of absorption of vitamin A. Ataxia is due to vitamin E deficiency. Apart from that, you can have other symptoms such as bilateral absence of vas deferens, summer dehydration. What is called summer dehydration? Summer dehydration, any child who is brought with severe dehydration in the absence of loose stools or diarrhea, you need to think cystic fibrosis in India, and it is otherwise called as pseudo-Bartter syndrome. Definitely it will be asked in your future examination. It is called as what? Pseudo-Bartter syndrome. That is hypochloremic, hypokalemic metabolic alkalosis, but polyuria will not be there because here sodium and chloride are lost in sweat and not in urine. Pseudo-Bartter syndrome. Apart from that, recurrent bronchiolitis can happen, upper lobe bronchiectasis. The most common organism are Pseudomonas and Burkholderia sapaceae. Okay, so the answer for this question is not biliary atresia, it is neonatal cholestasis, and it is very well covered in our section. Sodium benzoate is used in urea cycle disorder to chelate. Okay, we all know that hyperammonemia, hyperurea cycle disorder often leads to hyperammonemia. Your ammonia will be more than 1000 milligram per deciliter, and it can present as raised intracranial tension in newborn immediately after birth in the absence of acidosis. There will not be acidosis in urea cycle disorder, where there will not be any ketosis in urea cycle disorder. So whenever you have sky high level of ammonia elevation in a child who is sick and septic workup is negative, the next investigation of choice that you need to do in a newborn is you need to find out how much is the ammonia. When the ammonia is sky high, there are so many drugs that can act on the ammonia so that it can be sent out from the body with the help of some chelator. So what are all the drugs we use? Again, it was discussed in our discussion in PW videos. The immediate treatment of choice is hemodialysis, and you can use either sodium benzoate or phenyl acetate. This sodium benzoate and phenyl acetate usually combines with the glycine. So glycine is the substrate for ammonia. When this sodium benzoate and phenyl acetate combines with the glycine, it can be excreted in urine easily without formation of any ammonia. So by using sodium benzoate and phenyl acetate, it chelates the substrate, that is glycine of ammonia, so that it can be excreted in urine well. Apart from that, you can use arginine. So you all know that arginine is the final pathway through which the ammonia is excreted in the urine. So the drugs which are used in hyperammonemia urea cycle disorder are sodium benzoate, phenyl acetate, as well as arginine. Remember, in arginase deficiency, you are not supposed to use arginine. But here the question is, what is the mechanism of action of sodium benzoate? The mechanism of action of sodium benzoate is substrate reduction. That is, the substrate of ammonia is glycine. That is glycine reduction. Again, it is discussed in our PW section videos. Right. Question number 4. So this is an often asked question. All the following are manifestations of severe acute malnutrition except bilateral pedal edema. Previously, you have syndromic diagnosis. What are all the syndromic diagnosis? One is, they used to say kwashiorkor. Kwashiorkor is nothing but, what is kwashiorkor? Kwashiorkor is nothing but protein will be less in the body, leading to pedal edema. Whereas marasmus. So what is marasmus? Marasmus is nothing but a reduced calorie or energy intake in the body. When calorie or energy intake is poor in the body, it can often lead to reduced triglyceride deposition or fat, leading to low weight. So they have combined this severe acute malnutrition. The current definition of WHO had combined both features of kwashiorkor, that is bilateral pedal edema, and the loss of subcutaneous fat and low weight, that is, these are all the clinical features of marasmus. They had combined as severe acute malnutrition. So what does this question says? All the following are manifestations of severe acute malnutrition except pedal edema. The answer is yes. Mid upper arm circumference, normally it should be more than 12.5. So less than 11.5 is severe, whereas 11.5 to 12.5 is moderate. More than 12.5 is normal. So here it is less than 11.5 centimeter. So this is correct. This is correct. Then we have a doubt whether it is weight, whether it is weight for age or weight for height. It is always weight for height and not weight for age. If you need to calculate weight for height, and weight for height, it should be less than -3 standard deviation. So the answer is obviously bilateral pedal edema is correct. Reduced mid upper arm circumference less than 11.5 centimeter is correct. Reduced weight for height less than 3 standard deviation. Correct. It is not weight for age. Weight for age, the definition is underweight. We don't call it as severe acute malnutrition. Weight for age is usually called as underweight, and it doesn't come under severe acute malnutrition. So as far as severe acute malnutrition is concerned, it is weight for height and not weight for age. Weight for age means undernutrition. It doesn't come under severe acute malnutrition. Again, look at this. This is also explained in our videos. This is also explained in our PW section videos. Right. The following are criteria for secondary failure. I don't know. I could not get the exact question pattern or question frame in this regard. Whenever, definitely you will be getting some questions in severe acute malnutrition, but this is the first time I think they have asked questions regarding this primary failure and secondary failure. You all know that the treatment of severe acute malnutrition usually includes two things. One is stabilization phase. Another is maintenance phase. Stabilization phase means you need to concentrate more on the complications associated with severe acute malnutrition. Usually it lasts for 1 to 2 weeks. It lasts for 1 to 2 weeks, whereas maintenance phase usually lasts for 2 to 8 weeks. Or else I can say less than 10 days usually may stabilization phase, and more than 10 days, as a rule of thumb, you can say it comes under maintenance phase. When you will say primary failure, that is, even from the beginning, the child is not responding, when will you say? You remember two things: 4 days, 4 days. By about 4th day, the child should have some form of appetite. The child should have some form of appetite. By about 4th day, if the child develops some form of appetite and started eating, it means the child is showing some response. Second 4 is, by about 4th day, the edema should start disappearing. I mean, should not disappear totally, should start reducing. And then you need to remember to 10th day. So in the first 10th day, there should not be edema. There should not be any edema. Second one is there should be a minimum of 5 gram per kilogram per day weight gain. There should be a weight gain of minimum 5 gram per kilogram per day. So when these things are there, then it is called primary failure. I repeat, by about 4th day, there should be some appetite. By about 4th day, edema should start disappearing. By about 10th day, there should not be any edema. By about 10th day, there should be a minimum increase of 5 gram per kilogram per day. Okay, what happens to secondary failure to response? Very, very simple. Secondary failure to response is nothing but the child is not showing. Initially, the child responded well, but after 10th day, the child is not showing any response in the form of an increase in weight of more than 5 gram per kilogram per day. But I really don't know what is the exact question here. Let me try. No more than weight gain in the first week comes under primary failure. Pedal edema subsides in 14th day. It is not 14th day. Pedal edema should subside by 10th day. Again, no more than, it is not 10 gram, it is 5 gram per kilogram per day. I will be happy if you share any options in here, but let me, whether options are available or not, When you apply this rule, by about 4th day, should be some form of appetite, should be start losing edema. By about 10th day, there should not be edema. By about 10th day, there should be weight gain of 5 gram per kilogram per day. And secondary treatment failure means there is no weight gain of more than 5 gram per kilogram per day for 3 consecutive days after 10 days. Usually you need to rule out TB in a country like India. So this is the option. From this you can, if you can share your doubts in chat box, I am ready to help you. Right. Then, right. I could not see any doubts. Okay. Right. Then, yes, next question. A kid copies cross. Cross means this one. Cross usually occurs by the child can do 2 plus R cross by about 4 years. Tell stories again by about 4 years. It goes to toilet alone by about 4 years. What else the child can do at by about 4 years? The child can hop in one leg by 4 years. So these are all the things. So motor milestone, hopping in one leg. Fine motor milestone, draw a cross. Social and language. Language tells stories, and social means goes to toilet alone. So as far as this question is not that difficult, so the answer directly goes without saying. The answer is 4 years. Okay, a straightforward milestone question as expected. Right. Then comes, all the following are true about NADA's criteria. Again, this is also discussed in our PW videos. All the following are true about, we all know that NADA's is mainly meant for congenital heart disease. Any child can come with cyanosis. It can, or any child can come with congestive cardiac failure. How do we know that it is due to congenital heart disease? Whether it can be obstructive, or it can be a left to right chain, or it can be a cyanotic congenital disease. How do I know whether that child's cyanosis or congestive cardiac failure or absence of peripheral pulse is mainly due to congenital heart disease? That is explained by NADA's. So what is this NADA's criteria? Major criteria, minor criteria. Major criteria, systolic murmur of grade 3 or more. Why systolic murmur of grade 3 or more? Because even in anemia, you can get a systolic murmur of grade 1 and 2. That's why systolic murmur of grade 3 or more is considered as major criteria. Diastolic murmur of any cause, cyanosis, congestive cardiac failure should be taken as a major criteria. Minor criteria means abnormal S2, abnormal ECG, abnormal X-ray, abnormal S2, abnormal ECG, abnormal X-ray, abnormal BP, and systolic murmur of grade 1 and 2 is considered as minor criteria. When you have one major criteria and 2 minor criteria, it will be considered as NADA's syndrome, suggestive of congenital heart disease. Abnormal X-ray chest should be taken into criteria. Diastolic murmur, yes. Congestive cardiac failure, yes. So we have not heard about this abnormal troponin as a manifestation of congenital heart disease included in NADA's criteria. So the answer is, it is not troponin. It is not troponin. Right. So this question was discussed by Vinesh sir. So I am going to skip it. This is also a little bit. Let me discuss the choices first. Following are true or false, I don't know. As far as the sources are concerned, I have got not a fully framed question. So breast milk jaundice. So what are all the things that you need to discuss with respect to breast milk jaundice? So breast milk contained glucuronidase, as a result of which conjugation will not occur. So it is basically an unconjugated hyperbilirubinemia. So basically it is a unconjugated hyperbilirubinemia. Which one? Breast milk jaundice. Remember, previously they used to stop breast milk, but right now, nowadays, there is no need to stop breastfeeding in breast milk jaundice, even though it is the cause, because it is not going to do any harm to the child. Phototherapy is seldom required. Phototherapy is never required in breast milk jaundice. Nowadays, they don't treat. And urine urobilinogen, what does it mean? I don't know whether it is a correct choice or not. Urine urobilinogen mainly indicates whether it is a hemolytic jaundice or obstructive jaundice. In hemolytic jaundice, you will get urine urobilinogen. In obstructive jaundice, it will not be present. So breast milk jaundice, I don't think you need to confuse this with urine urobilinogen, because it is, yeah, but you can say it is due to exaggerated hemolysis. So RBCs comes here but cannot be conjugated, so it is excreted in urine. So urine urobilinogen may be increased. So what are all the points that we need to know with respect to breast milk jaundice? There is no need to stop breast milk. It is basically an unconjugated hyperbilirubinemia. Phototherapy is seldom required. Urine urobilinogen is increased because it is an exaggerated form of jaundice that occurs in newborn, because normally the RBC lifespan of an adult RBC is 120, whereas lifespan of a newborn RBC is 90 days. So more and more RBCs are get broken down, leading to increased hemolysis, leading to increase in urine urobilinogen. I don't know the exact answer. If you can post, I can help you. Again, this is also discussed in our videos. Okay, and what is this? 2-year-old broth with severe dehydration and diarrhea. What is the most common cause? Yes, in India, the government had come up with the Rota vaccine, which indicates that rotavirus is the most common cause for severe diarrhea in children. So, followed by rotavirus, it is E.coli. And very, very rarely it is due to cholera. Cholera usually doesn't come as a sporadic disease. It is usually occurs in a pandemic disease. So it is usually a rotavirus. Amoebiasis will not produce any acute diarrhea. It is usually a chronic diarrhea. So rotaviruses, Shigella is not diarrhea, it is dysentery. Ascariasis will not produce any diarrhea. E. coli, yes, it produces, but it follows rotavirus, right? Enterotoxigenic E. coli. And the last question, neonatal cholestasis. Again, I don't get proper choices. When you will consider neonatal cholestasis, when the jaundice crosses more than 2 weeks, you will call it as neonatal cholestasis, and it is predominantly direct bilirubin rather than indirect bilirubin. Third point is, we can consider if 20% of total bilirubin is direct bilirubin, then you need to consider neonatal cholestasis. There are so many causes. Two main causes is, one is neonatal hepatitis. Another one is extrahepatic biliary atresia. In neonatal hepatitis, the child will be very, very sick because the liver cells are damaged. Most common cause are torch infection, or either it can be due to inborn errors of metabolism. Whereas extrahepatic biliary atresia, the synthetic function is intact, so the child is not sick. Child is not sick. This is usually associated with pale stools. Also, people used to say HIDA scan is sensitive, but it is not so. The treatment, the investigation of choice is percutaneous cholangiography, and you need to take biopsy, then only it can confirm. In biopsy, if you see multinucleate giant cells and architectural distortion, it is more in favor of neonatal cholestasis. But in case of extrahepatic biliary atresia, you will get bile duct proliferation. So these are all the questions that were asked in our INICET recall. So thanks for your patient listening. Over to you, Rishabh.
Thank you,
So
sir.
basically, it is relatively easy
Yes,
paper
sir.
with respect to pediatrics.
Yes,
It is
sir. I think
purely a direct form of questions. No
neonatology, yes,
case-based
sir.
scenarios also.
Neonatology, general pediatrics, recipe constituting majority of the questions again, as we see in the INICET pattern. Thank you, sir. Over to you, Santosh, sir. So finally, two major subjects are now left, medicine and surgery. So I think sir can have all the time he needs because only two subjects are remaining now. So Santosh, sir, over to you.
Thank you, Dr. Rishabh. So medicine, guys, this time, as usual, less representation, few questions, or maybe whatever we could call as medicine questions have been already taken by physio, pharma, patho, microbiology. So I'm left with only few questions. I will address that. And I was listening to Dr. Sharath Balaji, and I realized one more time, and I reinforced this notion that a child is not a miniature adult. So the same diseases which he was talking about, we would manage it so differently when it comes to adult patients. Okay, so let me begin with the first question without taking too much of your time, because we also have surgery guy waiting out there with the scalpel. If I take too much time, I'll be scalped. Okay, so here's the first question. I need your help, guys, to build this stem. There was one question about the celiac disease. Let me, please help me with the exact framing or the examiner's language to understand what they were trying to test. This is what I've got it from one of the students. Which of the following is not related to celiac disease? And I have received 3 options. First one is anti-TTG antibodies. We know that anti-TTG antibody is the initial investigation whenever you're suspecting celiac disease. So that is certainly true. Second, anti-gliadin antibodies. I do not know how the question stem was formed. Anti-gliadin antibodies are seen in celiac disease, but they are least specific. This is most sensitive. This is least specific. But if they just say seen, yes, it is seen. And then third statement was there is something called as Marsh classification, whether it is related to celiac disease. Well, pretty much the histopathological grading of celiac disease is into different classification using Marsh-Oberhuber classification, which we have covered in the video modules. So in terms of serology, we know that anti-TTG is the initial investigation of choice. Anti-endomycin antibody is the most specific antibody. Anti-gliadin antibody is seen, but it is the least specific. And in subset of patients where you're expecting IgA deficiency or the children less than 2 years of age, we use today what is called as anti-deaminated gliadin peptide antibodies. These are the MCQ points. Please be aware about it. And then there is a histopathological classification called as Marsh-Oberhuber classification, which we have discussed at length in the main video modules. Yes, so these points suggest that whatever these 3 options we have recalled, they're all related to celiac disease. Whatever was the 4th option, it was not related to celiac disease. So please help me with the option. I will complete this question and share it back on the social media. Okay, then there was one more question on the initial investigation of choice for pheochromocytoma, or in other words, probably they wanted to know what is the screening test when you're suspecting pheochromocytoma. And from the recalled options, obviously it is urine metanephrines. So that's again a straightforward question. Coming to the main question that I would consider finally truly a medicine question. There was an image-based question of ECG. There was some story of a female with palpitations for past 2 years. ECG was there and they had asked you to identify what is the diagnosis. Options were the arrhythmogenic right ventricular dysplasia or cardiomyopathy, Brugada syndrome, left ventricular hypertrophy, and we were not able to get the one more stem. So guys, I have just lost the power. Give me a few seconds, but anyway, I will continue with the discussion because it's ultimately questions that we need. Okay, so ECG image-based question that we were talking about. Let me see if I can get a power source. Okay, so the ECG image-based question, that was only point I could hear from the student is that in the V2 or V3, there was some ST depression. That is what I could hear. And this is the only stem that I could gather from the student. Help me with more details if it is available with you. Now in the ECG, history of exercise and patient fell unconscious and was the last option was HOCM. Okay, good. HOCM was the last option. Okay, so let me summarize what ECG findings you will expect in these individual conditions, and then let me know if that is how the description fits into. So, okay, in Brugada syndrome, what do we expect? We expect ST elevation in lead V1 to V3 with T wave inversion. What am I expecting in the left ventricular hypertrophy? Obviously, we have a criteria called as Sokolov criteria, where S in V1 plus R in V5 or V6, whichever is taller, collectively it is more than 35 millimeter. Can I have ST depression? Because student was very clear that there was ST depression in lead V2. Can we have Farhan Mohammed? Oh, very good, very good. So that would be the answer there. Okay. So if we have, let us say, left ventricular hypertrophy, can I have ST depression? Yes, because of the left ventricular strain, but usually in the left ventricle leads, which is V5, V6, or in other words, you can say lateral leads, I can have the ST depression because of strain. It's called as left ventricular strain pattern. So when the student was very clear that, sir, there was ST depression, there was no ST depression, rather T inversion, I'm sure it is unlikely to be left ventricular hypertrophy. And with the history that PK is telling me, I would think of ARVD, Brugada, and HOCM. These are the three conditions where sudden deaths or collapse are known to occur because of these are associated with increased risk of arrhythmias. ARVD, we can have VT or VF. Similarly, HOCM, we can have VT or VF. Now, HOCM is better diagnosed with the echocardiography rather than ECG. But if you do ECG, what are we getting? We are getting dagger-shaped Q waves. Dagger-shaped Q waves. Dagger Q waves is a typical finding. ARVD, what do we get? ARVD, we get QRS prolongation and what is called as epsilon waves. That is the S wave. As it ends, there is a J point. J point becomes slightly having an upstroke called as a epsilon wave. Okay, so in this ECG that we are seeing right in front of you, this ECG is a ECG of Brugada syndrome. This ECG is a ECG of Brugada syndrome. Here also we can have sudden collapses and sudden cardiac deaths. This first ECG is type 1 Brugada syndrome where you see ST elevation. Now, what is ST elevation? The J point. What is J point? End of the S wave being lifted above the baseline. This is my PR segment that will be counted as baseline. And the end of the S wave should be counted as the J point. So J point is quite high. ST elevation. This shape of the ST elevation is code with the T inversion. Code ST elevation more than 2 millimeters with T inversion in V1, V2, V3. That is suggestive of Brugada syndrome. Similarly, Brugada syndrome type 2 is again you will have ST elevation in the same leads, but the difference is the ST elevation shape here is saddle shaped. The saddle shaped ST elevation. Type 3 Brugada is where you have ST elevation resembling the type 1 or type 2, code in type 1, saddle in type 2, but not meeting the basic criteria of 2 millimeter ST elevation. Less than 2 millimeter ST elevation, we can call it as type 3. Some students I had shared this ECG and they confirmed that it was not looking like Brugada, sir. Okay. Then was it looking like this, where you had a QRS widening and a small upstroke of the J point called as epsilon wave? If this is how the ECG looked like, then it was very clearly a case of arrhythmogenic right ventricular dysplasia or arrhythmogenic right ventricular cardiomyopathy. Arrhythmogenic right ventricular cardiomyopathy. So based on whatever information I have got, okay, for now, if it was looking exactly like this, where you have this epsilon wave and the widening of the QRS. Widening of the QRS refers to QRS taking more than 3 small squares on the ECG, then the answer is very clear. It is a case of arrhythmogenic right ventricular dysplasia. Now, how the left ventricular hypertrophy is going to look like? Left ventricular hypertrophy will have very deep S waves in V1 and very tall R waves in V5 and V6. When we measure the height, it should be more than S in V1 should be plus the R in V5 or V6 should be accounting for more than 35 millimeters. Like you see in this ECG, it's pretty damn clear in this ECG. S itself is 1, 2, 3, 4 large squares. So S is 20. And my R, let us say the tallest is here in V5. 1, 2, 3, 4, 5, 6. More than 6 large squares. Even if I take it as 6, this will become 6 into 5. 30 small square, 20 small squares. So 20 plus 30, that becomes 50. Clearly, that means this patient has ST. This patient has left ventricular hypertrophy. And as strain, we can here see that V5 and V6 are showing ST depression. That is the left ventricular strain pattern. So what do you think? What was the ECG more looking like? Was it like the ARVD or was it like Brugada? HOCM on the ECG, we cannot recognize or we cannot diagnose with confidence that this is HOCM on the ECG. It has to be echo directed. Where what do we get in the echo? In the HOCM, in the echo, we get asymmetric septal hypertrophy, systolic anterior motion of the mitral valve leaflet, along with that concentric left ventricular hypertrophy. And this asymmetric septal hypertrophy results in the shape of the ventricle called as banana shaped left ventricle. So if these findings are seen on the echo, that is more diagnostic of hypertrophic cardiomyopathy. On the ECG, we can only get dagger Q waves. Okay, so let's move to the next question. There was one question about the autoimmune polyendocrine syndrome, type 1. They are asking what is true, and there was one statement, type 1 diabetes mellitus is rare, which is certainly true. So what are the usual features of the autoimmune polyendocrine syndrome type 1? We had put this table in the video modules, trying to understand the differences between 3 types of APS. APS 1, I had given you a mnemonic to remember it as pralidoxime, P2AM or PAM. So here we have parathyroid and adrenal gland involved plus mucocutaneous candidiasis. Hypoparathyroidism is the parathyroid manifestation. Hypoadrenalism is the adrenal gland manifestation plus mucocutaneous candidiasis. But when we go to APS2, we will not have hypoparathyroidism. We will have additions, but in addition to additions, we will either have thyroid dysfunctions or type 1 diabetes mellitus. That is where we can call it as type 2 APS. In type 3, neither we have parathyroid involvement nor adrenal, rather we have thyroid and type 1 diabetes mellitus and other endocrine manifestations. So that makes it very clear that in APS2 and APS3, we can have involvement of diabetes. Diabetes is less common in APS1. So if the question was exactly framed like this is very correct. It's very correct. PK, no. See, even patients with arrhythmogenic right ventricular cardiomyopathy are pretty much known to go through the same symptoms that we get in HOCM. Development of VT or VF following exercise. In fact, arrhythmogenic right ventricular cardiomyopathy is also one of the leading causes for the sudden cardiac death. So we have this number 1, HOCM, then the Brugada syndrome and the arrhythmogenic right ventricular cardiomyopathy. These are leading causes for sudden cardiac death in young individuals as well as athletes. So history alone cannot push us to the HOCM. History suggestive of HOCM, but in the ECG, okay, if ECG had no features suggestive of ARVC and you had only dagger Q waves, then maybe you can go for the HOCM as the diagnosis. Okay, now there was one more question on the criteria for the ulcerative colitis. I think we all know that Truelove and Witt's criteria is used for ulcerative colitis. There is nothing more to add here. So whenever we make a diagnosis of ulcerative colitis, we have a stepwise approach to management. First, we have to assess the severity into mild, moderate, or severe, for which we are using the modified Truelove and Witt's criteria. After the classification is done, we initiate with the suitable treatment. So modified Truelove and Witt's criteria is for ulcerative colitis. Now, what criteria we follow for the Crohn's disease? For patients with the Crohn's disease, we have Vienna and Montreal criteria. Vienna and Montreal. Those are the things that we follow for the Crohn's disease. So this was a simple, straightforward question. We are using Truelove and Witt's criteria for ulcerative colitis. Now, this is one more question that I have. I need your help because I'm not able to reconstruct the stem properly. What I understand from the students is that they're asking what is not true about GB syndrome. Okay. Do we use IVIG? Definitely yes. Can we use plasmapheresis? Yes. Is there albuminocytological dissociation? Yes. Now, what is the fourth option? Help me with that and let me know whether the option B is exactly framed how is it mentioned here. Plasmapheresis is not effective in refractory cases. Is it how it is mentioned? Plasmapheresis is not effective in refractory cases. So IVIG and so what studies have shown in the recent times, IVIG and plasma exchange or plasmapheresis are having similar efficacy. Earlier studies had shown that IVIG is slightly more effective than the plasmapheresis. Today's recent studies, whatever that have been conducted in 2020s, 2021, 2022, 2023, they're all suggestive that IVIG and plasma exchange are similarly effective. IVIG is preferred for a simple reason that the administration is convenient. IVIG is convenient. PK, also help me with the last option so that we can choose the right, most appropriate answer for the question. IVIG administration is convenient, that's why it is preferred, but that does not mean IVIG is inferior. But then what is this refractory cases? Refractory cases are those who are not responding to one of the treatment, either to plasmapheresis or IVIG. So in such cases, what is the recommendation? Yes, areflexia was the word, or hyporeflexia was used. Diagnosis, yes, it has to be on the clinical grounds. Patient should have rapidly progressing ascending paralysis with hypo or areflexia and flaccidity or hypotonia. This is the diagnostic criteria, supported by additional investigations in the form of nerve conduction study or the albuminocytological dissociation on the CSF. Okay, so what is the current guideline? The most latest guideline we have is European Association of Neurology or European Society for Peripheral Nerve Society. Their guidelines have come in 2023. So what do they recommend? They say you can use either plasma exchange or IVIG, but when you're starting, once you start, if they do not respond, means if despite giving IVIG or plasma exchange, if patients deteriorate, we will call them as refractory cases, and those refractory cases, there is no evidence for efficacy of switching immune therapy. So if I had started IVIG, it's not helping, there is no point in giving plasmapheresis or plasma exchange. If I had started plasmapheresis or plasma exchange and then it's not responding, there's no point in giving IVIG. That is the current stance. But for those patients who had initially responded, but after that they started deteriorating again, in those patients, we can consider repeating the course of IVIG or plasma exchange. From the wordings that I'm able to understand, yes, areflexia and limb weakness is part of the criteria. So if that is the statement, that is fair enough statement. So what we will choose as the correct answer, plasmapheresis is not effective in refractory cases, is not properly worded. It is not properly worded. Bellroth-C, Miller-Fisher is a variant. So we have criteria laid out for Miller-Fisher. It's a variant, but generally speaking, when we say GB syndrome, we are referring to GB syndrome as a whole, and majority of cases of GB syndrome are AIDP. So for most case diagnosis, we do not need weakness. That exactly boils down to wording of the examiner's wording. If he says it is mandatory or absolutely necessary to have. See, if he just says it is a criteria, it's perfectly right. That is how the guidelines are suggestive of. But if the wording is it is mandatory or absolutely necessary to have weakness, then I would say that is not true. Okay, so right now I have a split between option B and whatever was the option D. I think all of us are very clear that IVIG and albuminocytological dissociation are valid with respect to GBS. But option B, plasmapheresis is not effective in refractory cases. Now, what do they mean by refractory cases? Whether we have already used IVIG and then we are trying plasmapheresis, I don't have the clarity. So I will keep this as a possible potential answer, and whatever is the option D. I will try to reconstruct this better, and I'll also try to see it from the spectacles of the most recent guidelines, and then hopefully we'll be able to arrive at a consensus. Okay, so that's it I had from me. The other questions that can be considered as medicine questions have been already addressed by my other colleagues. So I will pass the baton to the surgery guy. Dr. Rishabh, over to you.
Thank you, sir. Thank you, Santosh. Very short and crisp to the point discussion. So now we have the superstar, Dr. Sandeep, sir, finally taking the remaining questions of today's easy to moderate INICET. Over to you, sir.
Thank you so much, Rishabh, sir. I mean, you are the only one who's going to stay with me. So let's finish the session on a higher note. Just before we go on, there are a couple of things that I just come across. Right. So before we start discussing, guys, this time the exam was on a relatively, I would say, easy to moderate side. A lot of PYQs were asked. Yeah, just give me 1 second. I'm just getting an access. Right. A lot of PYQs was asked, and then the topics are more or less repeated only. Okay, so let's start. The surgery was fairly, I would say, in a very doable manner. There were 1 or 2 bounces that is expected from the INICET part of it. So without wasting any further time, let's kickstart the discussion. There was one question, the options were not being able to recall well by the students. So what I did is I just framed a question with whatever information I have. We'll try to decode it. Okay. So we had a patient who had a breast lump, which is measuring 6 into 4 centimeters. So we know less than 2 centimeters is T1, 2 to 5 is T2, more than 5 is going to be T3. So I have a T3 disease here. Now it is fixed to the pectoralis major, but pectoralis major does not form the component of chest wall. I'm not going to worry about it. Ipsilateral matted axillary lymph nodes. So this becomes N2A. Dimpling does not alter the stage. So for me, the answer has to be T3, N2A, M0. If this was there in the option, could you recall this? Can you recall this? Clear? Anybody can help me with the options? Is this how it was given? See, breast cancer staging, it's like, bread and butter for all the exam preparations. You cannot afford to miss on it. Okay? So if this was on the staging, this would have been an appropriate answer according to the given question. Now, ERAS protocol has become quite important. I've emphasized in my lectures also, that is early recovery in abdominal surgeries. We've been talking about it. It's a protocol in which you are trying to optimize the patient. So ERAS are the pre-op and the post-op recovery protocols that we have. So in an early recovery after an abdominal surgeries or surgery protocol, now the pre-op is going to be malnutrition screening has to be done. You have to decrease the fasting time. Solids is 6 hours, clear liquids allowed until 2 hours. Carbohydrate loading should be done. And then we'll try to minimize the post-operative, maintain glucose control, promote bowel motility, as well as resume oral diet 4 hours post-operatively, right? Now, in that context, according to ERAS, which is a correct statement? Hospital say decreases by ERAS because you are getting an early recovery, you'll send the patient home faster. Beta blockers helps in post-surgery recover, not in the ERAS component. Prolonged starvation is not recommended. This is true. I don't know the option D. If option C is there, it is the right answer that we have. Now, I think they have asked you the triangles of the gastronoma or the boundaries per se. So when you look at the boundary, this happens to be the esophagus, this happens to be stomach, this happens to be the duodenum that goes across here. In the C loop of the duodenum, we have the pancreas, which is going to have the head, the neck, and then the body, and then continues the tail of the pancreas. Now, when you look at the liver segment, this happens to be the biliary component of it. You see, this is the right hepatic duct, so left hepatic duct, right hepatic duct, common cystic duct, the gallbladder, and the common bile duct, right? So when you divide the duodenum, you look at the duodenum, this is the first part of the duodenum, this is the second part of the duodenum, the third and the fourth part. So how do you mark it now? So the marking points that you have is the junction between the cystic duct and the common bile duct, between the second and third part of the duodenum and the neck of the pancreas, right? Between the neck and the head of the pancreas, you make the triangular end, and this is the boundary of your gastronoma triangle, also called as the Passaro's triangle, also referred to as the Passaro's triangle. So I think these are the components that are given, right? So when you look at the options, it has to be cystic duct. It has to be the cystic duct and the junction of common bile duct between the second and the third part of the duodenum and between the neck and the head of the pancreas, right? This are going to be the triangle or the Passaro's triangle boundaries. Okay? So here I'd go ahead with option A. Question number 4. Every year there's one bouncer that INICET usually brings across. Last year, as I've written here, Hanover classification was given for the bile duct and the vascular injury. This year we have True Love and the WIT criteria. This is for ulcerative colitis. We divide the criteria into the component. We have the criteria that is going to be dividing them into mild, moderate, and severe. What are the components? We have number of motions per day, rectal bleeds, body temperature, pulse rate, hemoglobin, and ESR are the components. Again, we'll do an elaborate this. We were not expecting it. So it's a bouncer. Okay, fine. If you can leave it, it's not a big deal about it. Now, investigation for ureteric colic. If they ask you the best imaging modality, guys, I just want to emphasize that if they ask you the investigation of choice, then answer is going to be CT urography, that is NCCT-KUB, right? This is what we're talking about. If they ask you best, then it is ureteroscope. But if you have used the word imaging, then the imaging has to be an NCCT. It can't be ureteroscope. Ureteroscope is not an imaging modality, right? Now, another one, anticipated and expected question that we have a shallow ulcer, which is in the male. Okay, prolonged immobilization is there. Partial thickness skin loss is there. What is the grade of pressure ulcer? So grade 1, there is non-blanching erythema. Grade 1, there is non-blanching erythema. Grade 2, there is partial thickness skin loss. Grade 2, there is partial thickness skin loss. Grade 3, it is a full thickness skin loss. Grade 4, there is involvement of underlying structure. There is involvement of the underlying structure. Now, if you take into consideration here, there is a partial thickness skin loss is given. So it classifies as grade 2. It classifies as grade 2 in pressure also, right? Now, fairly an easy question. So out of the 6 questions that we have discussed, only one, that is the love and wit criteria, is slightly off. Otherwise, most of them are on track. Now, which is the most lethal injury in the neck or the thyroid surgery? Can you recall? Was it similar framed question or was it having a different form of a question? Now, if you're asking the most lethal, it is going to be a bilateral recurrent laryngeal nerve, which is going to cause severe respiratory distress. Now, this severe respiratory distress is because of medialization of vocal cords causing absolute collapse. See, if you're talking about a superior laryngeal nerve damage, it will cause loss of pitch. Unilateral recurrent laryngeal nerve will result in hoarseness of voice. It will result in hoarseness of voice. So if you're talking about most lethal, then the answer is going to be bilateral recurrent laryngeal nerve injury. Now, a wound was left, cleaning and debridement was done. 5 days later, the wound was closed. Now, when you're closing by suturing, it is primary, but you're taking some time and doing it. So it's a delayed primary closure. So the answer here is going to be C for Calcutta. There was a question on intermittent claudication pain. I could not recall or get. Bilateral recurrent laryngeal nerve, partial, but any full nerve damage will be more severe when compared to partial nerve injury. Could you give me a recall on the intermittent claudication? Was there a question which is related to intermittent claudication pain? Was there a question which was related to intermittent claudication pain? Anything? Okay, we'll try to reconstruct it. Now, during splenectomy, while separating the spleen from the stomach, that is from the splenogastric ligament, bleeding has occurred. What is the most likely source of bleeding? Now, when you look at the stomach per se, now this is the stomach that you have. And this is where the spleen is present. So let's say this is the orientation of the spleen. Okay, patient walks 100 meters and feel pain. So what was the question, PK? Now, meanwhile, I'll just complete this question. So from the celiac artery, you have the left gastric artery, which is going here. There is a splenic artery, which is going across here. And then you have the hepatic artery, which is going here. The splenic artery that goes behind the stomach gives rise to the splenic artery, goes into splenic hilum. In reverse manner, it is going to supply to the greater curvature of the stomach. This is nothing but your short gastric artery, and then there's left gastroepiploic artery. Now, if they're talking about bleeding, the bleeding usually occurs because of the damage of these vessels. These are short gastric arteries. So if the option was there in the short gastric artery, then it could be better option. Look at the other options. If there was a left gastric artery, this cannot be the option. If there's a left gastroepiploic artery, this could be possibility, but then more common will be a short gastric artery. So the question on intermittent claudication, couldn't recall the options fully, sir. It's okay. Okay, but it's okay. The question had come now, we'll try to reconstruct it back. Nothing, no worries about it. See? So these are your short gastric arteries. This is your left gastroepiploic artery. This is your splenic artery. This is a celiac artery. This is a left gastric artery. So usually it is going to be because of your short gastric artery injuries, right? Now, laparoscopic angle question, we'll quickly run through it. Let's say we have three components. The first one is going to be camera. When you put the camera, this is what we call it as the optical port. The camera is going to be an optical port. Then I will be using two working instruments. Let's say this is working instrument number 1. This is the working instrument number 2. Right? So I put three instruments here. This is what we call it as the working instrument number 1. This is your working instrument number 2. So what are the angles that you should know? The angle between any of the instrument and the body, this is what we call it as the elevating angle. Right? This is what we call it as the elevating angle. This is what we call it as the elevating angle. Now, usually this has to be at 60 degrees. The angle between the working port and the optical port, this is what we call it as the azimuth angle. It is 30 degrees. The angle between the two working ports, the angle between the two working ports, this is what we call it as the manipulating angle. This is what we call it as the manipulating angle. And the manipulating angle should also be 60 degrees. Right? So look at the question. Did they ask you the manipulating angle? Did they ask you the azimuth angle or the elevating angle? Elevating angle is between the port or the instrument that you've inserted with the body. Azimuth is between the working port and the optical axis. And the manipulating angle is between the two working ports or the two working instruments. Okay? This is on the laparoscopic angle. Now, if a barium swallow image was given, cough was there, halitosis was there, outpouching was present, if this is the image, then there is no doubt about it. This is your Zenker's diverticulum. This is your Zenker's diverticulum. Now, if there was another question, carcinoma esophagus, dysphagia is, remember in CA esophagus, dysphagia will be present, no doubt about it. So the first option, no dysphagia cannot happen. In fact, the most common symptom in CA esophagus is dysphagia. Now, what happens in dysphagia is, whenever we talk about dysphagia, there are three questions that are going to ask. Is dysphagia for solids? Is it for liquids? Or is it for both? That is the question number 1. The question number 2 is dysphagia is more for solids or liquids. And third one, is it a progressive or a non-progressive dysphagia? In the esophageal cancers, dysphagia will be for both solids and liquids. But initially, when the mass starts to grow, it is only for solids, later on liquids. Dysphagia will always be more for solids when compared to liquids. As the growth continues to grow, it will be progressive. So in CA esophagus, dysphagia will be initially for solids, then develop into liquids. Dysphagia will always be more for solids when compared to liquids, and it will be progressive. So if the option says initially for solids, then liquids and progressive, then the answer is going to be B for Bombay. I don't know the other options. If anybody can recall, that would be absolutely great. Okay? That's a question number 13. The question number 14, there was an oral cancer question. Did they ask you the stage? Did they ask you the T stage? I'm not able to understand. Didn't get it. Did they ask you the T stage of it, or the T classification rather? Were they asking you the T classification? Did they ask you the N classification? Or did they ask you the TNM staging? Just could you recall this? So this question, we need to reconstruct it back. Was there a question which says size less than 2 centimeters, bilateral lymph node involvement, what is the stage, something like that? If you're able to recall this, we'll reconstruct this question again. Now, so there was a condition where dysphagia is more for liquids initially than for solids. But a dysphagia will, in malignancies, it will always be more for solids than for liquids. The only condition where you have dysphagia more for liquids when compared to solids is achalasia cardia. Okay? Chalo. Now, in terms of question number 15, there was a history of radiation for neck for Hodgkin's lymphoma. Thyroid swelling has developed. No lymph node involvement is there. FNSA said papillary cancer thyroid. What is the management? Right? Now, if we're talking about the management of the papillary cancer thyroid with no lymph node involvement, so in a quick recap, for a differentiated thyroid cancer like papillary cancer thyroid, the first question you will ask, is it limited to thyroid gland? Is it limited to thyroid, or is it going to involve the lymph nodes? If it is going to be limited to that of thyroid gland, then we will go ahead with two categorizations. Whether it is less than 2 centimeters in size, is it limited to one lobe? If there is age less than 45 years, and if there is no lymphovascular spread evidence is there. In this, then you can go ahead with lobectomy. Otherwise, you have to go ahead with total thyroidectomy. There is no role of prophylactic central neck dissection. Here you will see whether it is involvement of level 6 or level 1 to 5 group of lymph nodes. Level 6 central neck dissection is done. Level 1 to 5 modified radical neck dissection is done. So look at the question. What did they ask you? If the question was framed no lymph node involvement, then the answer has to be total thyroidectomy. Then the answer has to be total thyroidectomy if there is no lymph node involvement is given. Clear? Okay. So if it is hemi, was it total? Was it hemi plus central neck dissection, or was it total with central neck dissection? Right. So we have to recall this. If this is the context, then the answer here is going to be total thyroidectomy. There is no need for lymph node dissection in this patient. What is not included in MEN2B? It's a repeat question we've been asking you. Parathyroid hyperplasia when you talk about it. So you have the parathyroid hyperplasia, the mucosal. You're talking about MEN2B. In the MEN2B, you will see mucosal neuromas are there. You will have marfanoid habitus will be there. You will have medullary cancer, thyroid will be there. The parathyroid hyperplasia will not be there, right? So when you talk about the parathyroid hyperplasia, that is usually associated with MEN2A condition. Okay? That is the we call about in the court. 2A is pituitary adenoma, parathyroid adenoma, pancreatic adenoma. Okay? So 2A is going to be with parathyroid adenoma, medullary cancer, pheochromocytoma. 2B is marfanoid habitus, medullary thyroid cancer, pheochromocytoma. Okay? With mucosal neuromas. Absolutely. Okay, I thought something has happened. Okay, great. Now, 17th question, true regarding acute pancreatitis. Again, an important question. Sorry, again, an important question. Just look at the options. Lipase is more specific than amylase. It is true. Lipase indicates severity. No. Amylase remain high for 30 days. No, it remains high for 14 days and then it declines off. Option D is not known. So if this is the given question, then the answer is going to be A for Ahmedabad. Indication for surgery for parathyroid adenoma, options needs to be recalled. Was it symptomatic or asymptomatic? For asymptomatic, you have renal criteria is there. Your serum calcium levels has to be taken into consideration. You have to take age into consideration. You have to take the bone mineral density, that is DEXA, into consideration. So age will be taken into consideration. You talk about the serum calcium levels will be taken into consideration. You'll see urinary calcium excretion will be taken into consideration. Or I'll say the calcium status per se, urinary excretion status will be taken into consideration. You'll talk about the bone mineral density will be taken into consideration. Okay? Chalo. Vitamin deficiency post gastrectomy. Obviously, when you do gastrectomy, you lose parietal cells, and parietal cells are responsible for your B12 transportation. So it is B12 deficiency, right? So these were the questions that we had, quite easy ones, only 1 or 2 bounces. This is what you had for this session of INICET, right? So I hope you all did well. I am extremely happy that we were able to contribute to you. So over to Rishabh, sir. Sir,
surgery was very typical. What we say to students कि INICET के लिए पढ़ना है तो जनरल सर्जरी स्ट्रांग होना चाहिए, ब्रेस्ट, ट्रॉमा, थायराइड, हिपैटोपैनक्रियाटिकोबिलियरी, ये बोलते हैं, ये पढ़ना होता है. एंड आई थिंक मेजॉरिटी ऑफ द क्वेश्चंस इसी से आ गए थे. लैप्रोस्कोपी का आई वाज लिटिल सरप्राइज्ड कि
लैप्रोस्कोपी वो ऑलरेडी आ रखा है. मतलब लैप्रोस्कोपी का जो वो एंगल वाला है ना, एक्चुअली वो आया था एक बार. दिस वाज आस्क्ड इन SS एग्जाम में पूछा था, एंड लेटर ऑन इट वाज asked in I think one of the NEET exams. पूरे angles की तरह नहीं पूछा था. They've asked you what is the angle called between these two. That was manipulating angle. 2 working ports. So more or less ठीक है सर. मतलब the only thing which I felt was out of the box. No, they have asked you. जैसे last time भी उन्होंने एक सवाल पूछा था. It was from the true love and the WIT criteria for ulcerative colitis. ठीक है. Last time पूछा था Hanover classification. These I felt were like गलत किया है बच्चों के साथ. Otherwise, sir,
ट्रू लव एंड विट तो हम भी पढ़ते थे सर, मेडिसिन में पढ़ते थे ट्रू लव एंड विट क्राइटेरिया.
In general, मतलब अगर पढ़ा है तो very good, because I was very surprised because I have never taught ulcerative colitis में इतने classifications. तो medicine में अगर पढ़ा है तो then it is quite good. Then Santosh sir would be quite happy about it. I felt this was a bouncer. Otherwise, surgery में जितने थे 21 questions, everything was doable, sir. इसमें तो कोई trick भी नहीं था. कोई
I think
मतलब
major
आज option recall पे भी depend करता है.
मेजर सब्जेक्ट्स में तो आई थिंक सिर्फ सर्जरी एंड ऑब्स गायनी वेरी वेरी इंपॉर्टेंट. मेडिसिन के तो जैसे संतोष सर के भी लॉट ऑफ क्वेश्चंस वर टेकन फ्रॉम बाय पेडियाट्रिक्स, पैथोलॉजी, फार्मा एंड अदर्स.
सर इस बार आपने ऑब्जर्व किया पैथो के क्वेश्चंस नो दे वर वेरी मतलब पीजीआई टाइप के थे, मतलब इमेज
फार्मा के
देन
भी
है ना. हाँ, सो आई मीन सेकंड ईयर के सब्जेक्ट सर है इंपॉर्टेंट, मतलब
सेकेंड ईयर इज वेरी वेरी इंपॉर्टेंट. इनफैक्ट all three second year subjects, na, path, micro, pharma, around I would say 60 questions.
नहीं इट वाज सर बहुत इंटर कनेक्टेड भी थे तो, बट फाइन सर. मतलब सेकंड ईयर हमेशा से इंपॉर्टेंट ही रहा है. फाइनल ईयर में मतलब आईएनआईसीटी के लिए मेडिसिन सर्च ऑप्शन गाइनी पीडियाट्रिक्स में रहा है, तो वो उसी रेशियो में चले हैं. तो आई थिंक दिस एग्जाम वाज फेयर सर. मतलब जैसे लास्ट टाइम का था थोड़ा लगा कि इट वाज आउट ऑफ द बॉक्स, बट दिस टाइम इट वाज अ फेयर एग्जाम.
So
व्हाट इज
with
योर
that,
ओपिनियन ऑन दैट?
yes sir, I think INICET का it as I said students ना लोग नीट पीजी की तैयारी करते हैं, बट one exam which is predictable, which happens on time, जिसकी काउंसलिंग भी टाइम पर होती है, that is INICET. एंड मतलब अगर आपको एक एग्जाम जो देना ही चाहिए, मैं सब स्टूडेंट्स को बोलता हूँ कि यार INICET क्यों नहीं दिया. आई वाज लुकिंग एट ट्विटर एंड बहुत सारे स्टूडेंट्स ऐसे थे जिन्होंने INICET का एग्जाम ही नहीं दिया. मैंने यार ये क्यों किया तुमने. नीट पीजी से आसान पेपर आता है, प्रिडिक्टेबल पेपर आता है. सब लोग बोलते हैं फर्स्ट सेकेंड ईयर करके चले जाओ, 50% पेपर तो आपका वैसे ही सॉल्व हो जाएगा. तो INICET तो वन एग्जाम ऑल ऑफ स्टूडेंट्स शुड गिव, स्पेशली इफ यू आर प्रिपेयरिंग फॉर नीट पीजी. तो मॉक टेस्ट की तरह दे दो. अगर हो गया नीट पीजी तो सेंट्रल इंस्टीट्यूट जाने के लिए दे दो.
नहीं ये बात सही बोली सर, मतलब बिकॉज ऐसे काउंसलिंग भी तो खींच ही रहा था. आई फेल्ट लॉट ऑफ स्टूडेंट्स हु मैसेज मी नो. मैंने तो पर्सनली बोला है कि यार आईएनआईसीटी दे दो, मतलब डोंट स्टॉप, बिकॉज काउंसलिंग होगा, देखा जाएगा, पढ़ते रहो कैसे भी. तो कपल ऑफ स्टूडेंट्स डिड डू दैट. ऑलराइट सर, रात भी बहुत हो गई है, बच्चे भी बहुत थक गए हैं, चैट बॉक्स भी थोड़ा नेगेटिव हो रहा है, तो एक काम करते हैं वो भी बंद कर देते हैं. लेट देम हैव फन.
So I think, sir, we'll wrap up today's session. So just before
Yes.
wrapping up, I like to thank all the faculties for sparing their time. First of all the students who have studied from us, thank you so much for showing your support to PW MedEd. It is your feedback, it is your love which helps us motivate, which helps us improve our platform and our content. Secondly, I'd also like to thank all the team of PW MedEd. We are a small team apart from the faculty. So a special shout out to Raman, Dr. Manish, Aditya. Aditya is one who handles all our YouTube sessions, all the recalls that happen on this channel. Dr. Arshad, Dr. Jigar, Dr. Anto for helping us in recall questions, and especially all the students who help us become a better teachers and become a better platform.
And Dr. Hara also, the one who
Yes, sorry, I'm so sorry.
sat behind everybody.
Sorry.
Shout out to all of you guys, like amazing support. Thank you guys. And I mean, post exam, spending a lot of time with us. I know it's tedious, but then you guys did it. We are very, very happy that we all were able to do the recall. This time the recalls were quite impressive from the students as well. So it's getting better. And thank you for all the love and support, as Rishabh sir is saying. So I'll let you conclude, sir, and we'll just stop.
So that's all for today's session. NEET PG counseling is now live. The choice is filling out till 20th November. So if you have any queries regarding your branch choices as well, please do let us know. The results of this INICET will be out in a week. And so again, the counseling will start for INICET, I think in the first week of December. So all the very best to all the students. टेक अ फ्यू डेज ब्रेक, 2-3 दिन घूमने जाओ यार. मैं तो हर बार ट्रिप के लिए बोलता हूँ, जब भी कोई मेजर एग्जाम होता है, यू शुड गो ऑन अ ट्रिप. इट्स टाइम टू सेलिब्रेट, इट्स टाइम टू गिव योर सेल्फ अ ट्रीट. and relax karo. You guys deserved it. This year has been very tough as far as competitive exams have been concerned. NEET PG postponed 2 to 3 times. Counseling not yet happened. INICET now last exam of this year. So you guys deserve a treat. I remember sir, this is one of the toughest period in the life of a medico because MBBS हो जाती है, PG के बीच में लटके रहते हैं, अब पता नहीं यार ब्रांच मिलेगी नहीं मिलेगी. So with that, we'll conclude today's session. Closing remarks by you, Sandeep sir.
Well, most of the things, as Rishabh sir said, please do that. Go have fun. You deserve it. Spend some time. Get to that holiday that you deserve. अब every single thing that has to be done. इस साल का जो last exam है वो भी हो गया है. The last nail in the coffin. अब all that you can do is wait for the result and make sure you get a good rank and just pass on to it. बाकी तो ठीक है, चलता रहेगा. अब कुछ रहा तो कुछ और अगर आपको पता करना है, if you want to talk about it, if you want to know about the branch, especially in the central institutes, do let us know. We will be very happy to do that session as well. With that, thank you so much for patiently listening. We are very happy that since we started this recall series, we have been doing every exam after exam, and it's only getting better. Thank you so much, guys. Good night.
Bye. Good night.
Good night, sir. Bye.
Bye.